In the next 15 to 20 minutes, I will be covering
to you on managing COVID in different criteria.
Good afternoon. Vaccine, cervical cancer vaccine.
I would be covering the topic of newer technologies for diagnosis and management of HIV.
Good morning, everyone. I'm Tinu Khanna, Deputy Director, IC Chandigarh SACS. I welcome you all to the day 2 of AIDSCON, our national conference. Moving on to our first session of the day, free papers. It's an honor to invite Shri Munish Kumar, Team Leader, Technical Support Unit, to chair the session, please. He's been very supportive. He's very intelligent. He's always very, very helpful. Thank you, Mr. Munish, for joining us today and chairing this session. Dr. Sapna, MO, Department of Gynecology, GMS at 16, Chandigarh. I welcome her. Shri Kamaljeet Singh, Assistant Director, CST, Chandigarh SACS. I welcome the chair and the co-chair on the dais. Can one of the virtual participants please give me a thumbs up that I'm audible?
Yes, ma'am, you are.
Thank you so much. So handing over the session to our chair and co-chair. Thank you very, very much.
Good morning. So we are on this day 2 of AIDSCON-11, and we have got 4 speakers as part of the first session. And I would like to introduce the first speaker. We have Dr. Sapna as the co-chair, and she will introduce the first speaker, and then we will go ahead with the session.
Good morning, all. First speaker, I invite Ms. G.K. Gill, intern at GMCH Chandigarh, 32 Chandigarh. She is going to present on care, support, and treatment services, Chandigarh SACS work profile. Ms. G.K. Gill, please.
Good morning, everybody. I'm Jeena Kaur Gill, an intern at GMCH 32. Today, I'll be speaking on care, support, and treatment services under the Chandigarh SACS for HIV/AIDS. Care, support, and treatment services. There is one center of excellence in Chandigarh at PGI. There are 2 centers, 2 ART centers in Chandigarh, that is ART Center PGI and ART Center GMCH 32. There is one Link ART Center in Government Hospital Mani Majra. Care and support centers in Sector 15A, Chandigarh. The Center of Excellence. This center was established in PGI, Chandigarh in September 2008 with a view to provide tertiary care and treatment to people with HIV, the capacity building, training of personnel, and to undertake operational research and publication in the field of AIDS. In the Center of Excellence, there are currently 514 patients on second-line ART and 106 patients on third line. Some of these patients have been referred to the center from various ART centers in the northern region. The ART Center Chandigarh. The ART centers are implementing test and treat policy, ART viral load tests, CD4 counts, and baseline investigations, which are also being done free of cost. 4,900 viral load tests were conducted in PGI, and 86.5% patients are virally suppressed. The ART centers in Chandigarh have registered a total of 16,720 patients since its inception till January 2022. At present, there are 5,647 patients that are alive and are taking regular ART from this center. Among these patients, 1,079 are of Chandigarh. The reasons for not achieving the target of 95 in viral load suppression is that the patients, they start taking complementary and alternative medicine, such as homeopathic or Ayurvedic medications. There are some side effects at initial stages. There are myths about ART medicines, being away from home, and the fear of revealing their HIV status to their partner and the society. People of HIV of high-risk groups make multiple identities. Being busy with other things and simply forgetting are the reasons for non-adherence. Since COVID-19 pandemic, the patient's relatives, they were coming for collecting ART, or the ART was being sent by courier due to fear of COVID-19 exposure. Hence, a lot of patients were dispensed medicines in absentia. These patients could not be monitored regularly for response to treatment. The suggestions to achieving the target of viral load suppression, interstate and interdistrict left to follow-up tracking may be done collectively by VIHAN and the 3 care support centers functioning in the respective states. The care support center may work for social protection services. This will fill the gap of LFU cases. The care support center will work on prevention of linkage loss from ICCT to ARCT. More viral load labs can be opened at ART center and FART center level. Stable patients of Chandigarh can be provided ARV drugs and regular home-based counseling for adherence and viral load suppression. The initiation of telemedicine project to ensure the treatment adherence. The Link ART Center at Civil Hospital, Manimajra. The Link ART Center, Civil Hospital, Manimajra is linked to the ART Center in PGI. This is done to minimize the need for patients, for stable patients to visit PGI. It is for the distribution of ARV drugs and monitoring of drug adherence in stabilized patients. There are currently 33 PLHIV linked with this center. More patients can be accommodated here so that PGI can be decongested and unnecessary exposure can be. Next is Care and Support Center. There is one Care and Support Center at International Boys Hostel, Sector 15A, Chandigarh, and the following services are being provided. Counseling is done. Next is working for removal of stigma and discrimination. Periodic meetings with various groups, home visits for bringing back lost to follow-up cases back to treatment, outreach workers to find reasons of non-compliance. Advocacy meetings are held here for high-risk groups, provide linkage with social welfare schemes. A Link ART center is being proposed for the CSC for better adherence and compliance. Thank you.
By Gina. Thanks, Gina. Now we'll move on to the next speaker, Dr. Anita Gupta, Professor, Department of Allied Health Sciences, Chitkara School, Punjab. Is she there?
I think she is joining virtually, right?
Yes, ma'am.
Okay.
Yes.
Okay.
Can you please share my slides?
Sure, ma'am. Can you start your presentation, your camera, please, first?
Yeah. Camera. Okay. Yeah, it's done.
Yes, we can see you now. Just a minute.
Okay. Good morning, everybody.
Good morning. Good morning, ma'am. Please go ahead.
Okay. And my title for today's talk is Management of Lectins with antiviral activity against HIV-1. So will I be able to see my eyes or should I speak? Should I continue? Okay. Yes. So next slide, please. So human immunodeficiency virus infection, it is a leading public health problem due to rapid mutation of the virus, and it is due to the resistance to the existing therapies, lack of vaccine, and inadequate use of physical prophylaxis. So despite recent advances in acquired immunodeficiency syndrome therapy and available prevention methods, HIV infection continues to spread worldwide with more than 5,500 new infections every day. So in many developing countries like in Africa, AIDS was a disaster because of its devastating socioeconomic effects. And only in sub-Saharan Africa, more than 69% of all living individuals were with HIV and 70% of all AIDS deaths were there in 2011. Next slide, please. There have been a tremendous advancement over the past years in the standard use of antiretroviral drugs for the treatment and prevention of HIV infection. Indeed, current ARVs greatly improve the clinical outcomes of HIV positive individuals and limit disease transmission with improved safety, elevated tolerability, and high potency. And however, poor countries have no access to these ARVs, and moreover, they lack the technical know-how also. One of the most recent tools for HIV prevention is pre-exposure prophylaxis, whereby individuals are prescribed daily doses of antiviral drugs in the anticipation of exposure. So lowering the risk of infection, Truvada was the first FDA-approved drug to prevent this thing, and its consistent intake is highly effective in preventing the HIV infection. Despite the increasing awareness, the benefits with PrEP, its use remains low, especially amongst the women. So even though the antiviral drug has increased the lifespan of individuals, the opportunistic infections they spread, and it is also leads to the sexually transmitted diseases. Next slide, please. So because of these opportunistic infections, lack of know-how, and the cost of the drug, there is a demand for the development of new antiviral drugs that could contain the disease and simultaneously target other pathogens also. For this purpose, many lectins have been discovered which neutralize a number of viruses, including HIV and other pathogens. So they are called the novel they have the potential to be the novel antiviral drugs. This talk will review the currently available lectins with anti-HIV activity. Next slide, please. So for entry into the body, HIV must adhere, or it must stick to the surface on the host cell. And so HIV entry into the target cell is mediated by binding of its glycoprotein to the cell surface receptors. Initially, the cell surface receptor is a single subunit, and it is GP160, and that is synthesized as a single glycosylated polyprotein precursor, which is then cleaved by protease into GP120 and GP41. GP120 is responsible for viral binding to the CD4, whereas GP41 helps in the fusion and entering into the body. So that means these glycoproteins are essential for the binding. That means if we find out some inhibitor for the adhesion at the point, the prevention can be for this disease can be caused. Next slide, please. May I have the next slide? So recent approaches of treatment include design of active compounds interfering with entry events, and to infect cells, the HIV protein envelope binds to the primary cellular receptors to the other receptors also. So this sequential binding triggers fusion of the host cell membranes, initiating the infection. So these glycoproteins, GP1 particularly and GP41, they are highly glycosylated, and 50% of these glycans, they include the complex type oligosaccharides 13 of which are complex type oligosaccharides, and 11 are the high mannose structures. So these complex type oligosaccharides, they include galactose, mannose, glucosamine, glucose, salic acid, etc. So these events, if they can be altered, if the adhesion is altered by some alteration in these binding proteins or glycoproteins or some other of the virus to the body can be inhibited and the disease can be prevented. So that is the main purpose of the lectins. Next slide, please. Now, may I have the next slide? So due to the glycosylated nature of viral envelope proteins, carbohydrate binding proteins have been considered the potential anti-HIV agents that would block the host virus interaction at the earliest, eventually preventing the establishment of the provirus. And lectins with antiretroviral activities have been identified and isolated from many species like animals, plants, microorganisms, and they serve as the anti-HIV natural products. Next slide, please. So now coming to the what are lectins, we must know the lectins are carbohydrate binding proteins or glycoproteins which agglutinate cells or precipitate glycoconjugates. They are also known as the heme agglutinins because they bind to the blood cells and cause the agglutination. So they help in deciphering the sugar code words. The main properties of the lectins include sugar specificity, which can be mannose-specific or glucose-specific, galactose-specific, glucosamine-specific, then fucose-specific and salic acid-specific. Other properties of the lectins include mitogenicity and cytotoxicity. They also act as cell recognition in biological systems and ubiquitous in nature. Next slide, please. So mannose binding lectins, because the mannose content is higher in the GP120 and GP41. So mannose binding lectins are playing very important role in the anti-HIV role. Anti-HIV particularly this function can be held. So animal lectins like serum MBL is there, which is calcium dependent and synthesized in the liver and present in the serum and has a molecular weight of 400 to 700 kilodaltons. And sugar specificity, as the name indicates, is D-mannose or the complex mannose. They act as the anti-antibody, and concentration is, in normal concentration, is 800 to 1000 nanogram per ml. If the concentration increases in some of the diseases and the concentration decreases in some of the diseases, if the concentration goes less than 70 nanogram per ml, it is called the MBL deficiency, and that is one of the cause of many infections, particularly the viral and the bacterial infections. For example, also in addition to the HIV, sepsis, influenza, pneumococcal diseases are the ones. Higher concentration are seen in they activate the complement activation, particularly in the type 1 diabetes or rheumatoid arthritis also. Plants lectins are also there, known as the PMBP, plant mannan binding proteins or mannose-specific lectins. They are present in many plants, particularly in the monocot species and the fungi. Next slide, please. This is the structure of the MBL that we can see on the right-hand side. So that means understanding of these glycoproteins is very important if we want to find out the anti-HIV role of these lectins and for the potential anti-HIV therapy. So next slide, please. And so this slide shows you the anti-HIV lectins of some of the species. Here we can see that the some of the algal species which are given in the first few numbers, the actinohividin, cyanovarin, oscillatoria agglutinin, cytovarin, Microcystis viridis lectin, microvirin. They are all algal lectins and they are mannose-specific particularly. Most of them are mannose-specific and they adhere to GP120 in most of the cases, except in first one here, actinovihivin that binds to GP41 also at a very low concentration from 2 to 110 nanomoles or even less in case of the second one, cyanovarin, and so on. So we can say that these are they have potential for as the anti-HIV agents. So some of the plant lectins also, like narcissus bulbs, they are also manospecific. Then concaveline A, which is very commonly used, banana lectin, that is very commonly used. They are also manospecific lectins. They are specific, they bind to the GP120 and cause the inhibition of the virus to the host cells, that thereby preventing the concentration required in these cases is also very less here. So even the red algae, known as the lectin from the red algae, known as the Griffithsin, is also glucose and manospecific, even glucosamine specific, and so it has higher potential for the to act as the anti-HIV agent. Next slide, please. May I have the next slide? So apart from the anti-HIV, some other roles are also there. They can act as in the diagnosis and of the cancer, and therapeutic properties of the cancer also there. They act as the anti-insect and anti-pest. Banana lectin can act as the anti-HIV. They are the antioxidants and antibacterial also. Galanthus nivalis or bulb lectins from the snowdrop, and they are anti-cancerous, anti-HIV, and then anti-hepatitis, you can say, anti-insect, anti-pest properties are also there. Then red algae or Griffithsin holds more potential, and anti-HIV, acts as the anti-HIV. So it is also being used to prevent all these lectins are also being used to prevent the cancer also, to prevent the cancer plus the coronavirus also, they are being tried. So this lectin, that is mistletoe-lectin, is also having that is galactose or galactosamine specific, has anti-cancerous properties and being used for as the anti-HIV properties. So coming to the conclusions, next slide, please. So we can say that the delivery of mannose binding lectins in the form of encapsulated nanoparticles or liposomal formulations, they serve as antiviral agents or vaccines across the cell membrane. The use of lectins extracted from various natural cells hold great promise and potential for use in future HIV therapy, but it needs further investigations. Thank you very much.
Thank you, ma'am, for your presentation. Any question from Dr. Anita? Okay, so let me introduce the third speaker for today, Mr. Vikram Sethi. He is author and real estate developer, and he actually represents the drug using community. He is in sobriety for so many years, and his vision is to help drug using population to a larger extent, and he'll be talking about injecting drug use and its dangers in relation to contracting HIV. Please.
Good morning, everyone. मंच पे बैठे सभी लोगों को मेरा नमस्कार, और खास करके संदीप मित्तल जी का, जिन्होंने मुझे मौका दिया. So first of all, I'd like to introduce myself. See, my name is Vikram Sethi, as sir told you, and I'm an addict. I've been in recovery for more than 7 years now, and recovery में आने के बाद I've been trying to help people कि जो मेरे जैसे लोग थे वो इस चीज़ से बाहर निकले और सोसाइटी में अपना रोल पॉजिटिव तरीके से प्ले करें. So first of all, आज का मेरा टॉपिक है ID use. I've myself been in ID use for about 5-6 years, और कई बार मैं ओवरडोज हो चुका है मेरे साथ काफ़ी ऐसी चीज़ें हो चुकी हैं जो एक ड्रग यूज़र के साथ नॉर्मली होती हैं आईडी यूजर के साथ, और वो हर एक चीज जो प्रॉब्लम करती है या कोई हर एक चीज जो हो सकती है बुरी, वो मेरे साथ हो चुकी है. सो आई बीन आउट ऑफ इट. और उसी तरीके से मैंने अपना जो प्रोग्राम शुरू किया है, द बिग ब्रदर प्रोग्राम, जो मैं अभी दे रहा हूँ लोगों को. दिस इज द प्रोग्राम. तो वहां से मेरी शुरुआत हुई जब मैंने ड्रग्स लेने शुरू किए, और खत्म यहाँ पर हुआ है कि अब मैं सोसाइटी को वापस दे रहा हूँ जो मुझे अच्छा मिला है. तो लेट्स टॉक अबाउट द टॉपिक टुडे, आईडी यूज. एवरीबडी नोज व्हाट्स आईडी यूज है. आई थिंक काफी बातें हो चुकी हैं इस मामले में, तो मैं क्या बोल सकता हूँ. आईडी यूज तब शुरू होता है जब पहले पहले जब ड्रग्स लेना इंसान शुरू करता है, तो इट इज ओरली ले रहा होता है या किसी और तरीके से ले रहा होता है, लेकिन जब उसकी पोटेंसी उसको हाई नहीं लगती तो फिर वो आईडी यूज में जाता है. आईडी यूज में जाने के बाद दे स्टार्ट शेयरिंग नीडल्स, बिकॉज काफी लोग कम्युनिटी यूज हो रहा होता है तो उसमें नीडल्स आपस में शेयर करते हैं, जिसकी वजह से कई बहुत बड़ी डिजीजेज हैं जो हो सकती हैं और हो जाती हैं, जिसमें HIV है, जिसमें वायरल हेपेटाइटिस है, जिसमें TB है. तो let's talk about the statistics here. People who inject drugs make up to 10% of new HIV infections globally. Of course, HIV injections is the main, जो reason है कि जो आपस में लोग injections share करते हैं, उनको एक दूसरे से कई बीमारियां हो जाती हैं. Estimated 15.9 million people inject drugs worldwide, and up to 3 million are infected with HIV. So most of the ID users are in Eastern Europe, East and Southeast Asia and Latin America. और इंडिया में सबसे ज़्यादा यूजर्स हैं वो नॉर्थ ईस्ट में पाए जाते हैं, और वहाँ पे सबसे ज़्यादा आईडी यूज की डेथ्स भी होती हैं, क्योंकि वो लोग कॉकटेल्स वगैरह इस्तेमाल करते हैं. यहाँ पर जो पंजाब में बहुत बड़ी प्रॉब्लम है, पंजाब में अभी आई वॉज वर्किंग विद एजेंसी जो नार्कोटिक्स एनोनिमस, आप जानते होंगे. आई हैव सीन सो मेनी फैमिलीज जिन्होंने अपने सारे लड़के जो हैं, सारे कमाने वाले मेंबर्स, मेल मेंबर्स जो हैं, वो आईडी यूज के कारण, ओवरडोज के कारण गंवा दिए. एंड लकीली हमारे पास इतनी हेल्प थी कि हम उन यूजर्स को भी नैलोक्सोन वगैरह जो इंजेक्शंस होते हैं वो डोनेट करके आ पाए, ताकि कम से कम किसी को आपके सामने ओवरडोज हो रही हो तो आप उसको बचा सकें, या किसी का कोई फ्रेंड है या रिश्तेदार है जिसको जो क्रॉनिक है और जो प्रोन है ओवरडोज के, उसको वो दे सके. नेक्स्ट स्लाइड. So we'll talk about the means of contacting HIV via drugs. The first is, of course, sharing needles, syringes or other drug injection equipment puts people at risk for transmitting HIV and other infections like TB, viral hepatitis B and C. जिस तरह से हमने बात की. उसके बाद unsafe injecting drug use helps spread in prison settings. अभी normal society की हम लोग बात करते हैं. जब यहाँ पे कोई ड्रग यूजर इंजेक्ट करता है, वो पकड़ा जाता है, उसको जेल भेज दिया जाता है, as you all know. जब वो जेल में जाता है तो जेल में भी वो इंजेक्शन ही लेता है, उसको पकड़ा भी उसी के लिए गया है और आगे जाके भी वही करता है. तो प्रिजन सेटिंग में बहुत खतरनाक शेयरिंग होती है, बिकॉज वहाँ पे इंजेक्शंस कम है, वहाँ पे नीडल प्रोग्राम, सिरिंज प्रोग्राम्स नहीं होते हैं. तो एक ही सिरिंज है जो कई कई दिन चलती रहती है और कई कई लोग उसको यूज करते रहते हैं, और वहाँ पे बहुत ज्यादा प्रॉब्लम होती है. द थर्ड इज यूज ऑफ एम्फेटामिन टाइप स्टिमुलेंट्स बाय होमोसेक्सुअल मेल्स, व्हिच वी हैव सीन इन 90s में अमेरिका में एड्स का बहुत राइज हुआ था. दैट इज बिकॉज ऑफ दिस ओनली. सो द एग्जिस्टिंग मेथड्स ऑफ प्रिवेंशन इज, ऑफ कोर्स, फर्स्ट इज क्विटिंग ड्रग्स, व्हिच इज एक्चुअली वेरी डिफिकल्ट, आई नो बाय माय ओन एक्सपीरियंस. देन हार्म रिडक्शन प्रोग्राम्स जो NACO वगैरह आप लोग चलाते ही हैं, जिसमें सिरिंज सर्विस प्रोग्राम्स हैं, ओपिएट सब्स्टिट्यूशन थेरेपी है, कम्युनिटी डिस्ट्रीब्यूशन ऑफ नैलोक्सोन. So these are the evidence-based approaches to HIV and HCV prevention. Now, ये तो एग्जिस्टिंग हो गया जिससे हम लोग प्रिवेंट कर सकते हैं, लोगों को थोड़ा बहुत बचा सकते हैं. नाउ आई विल टॉक अबाउट माय इनिशिएटिव, व्हाट आई हैव डन नाउ. तो मैंने ये देखा कि जब मैं ड्रग्स में था तो मुझे ये जो इंस्टीट्यूशनल तरीके हैं ठीक करने के, वो ज़्यादा काम नहीं आए. मुझे ज़्यादातर काम आई मेंटरशिप फ्रॉम दोज पीपल हु वर इन ड्रग यूज एंड हु एक्चुअली मैनेज टू कम आउट ऑफ इट, जितनी मर्जी मुश्किल से आए. तो उनकी मेंटरशिप से जो मुझे ये चीज़ मिली है, उसको मैं आगे देने के लिए ये प्रोग्राम शुरू किया है जो मैंने, जिसका नाम बिग ब्रदर प्रोग्राम है. तो एडिक्ट्स कैन बी ट्रेन्ड विद लाइफ कोचिंग टेक्निक्स. फर्स्ट ऑफ ऑल, सबसे पहले मैंने ठीक होते ही लाइफ कोचिंग टेक्निक सीखी. तो आई बिकेम अ लाइफ कोच। लाइफ कोच बनते ही मैंने वो टेक्निक्स आगे लड़कों को देनी शुरू की जो इस समय प्रॉब्लम में है। कई लोग ऐसे होते हैं जो देयर आर टू टाइप ऑफ एडिक्ट्स आई थिंक। एक तो वो है जो अभी तक जिनको समझ नहीं आई है और वो नशों के पीछे ही भाग रहे हैं, उनको और कुछ नहीं पता। सेकंड, दूसरे तरीके के वो लोग हैं जिनको समझ आ चुकी है बट दे आर अंडर इट बिकॉज ऑफ लैक ऑफ अपॉर्चुनिटीज। उनको ये नहीं समझ में आता है कि नशे छोड़ेंगे, बिकॉज सी व्हाट आई बिलीव इज जो एडिक्शन है, इट्स अ फुल टाइम जॉब। व्हेन यू आर इन एडिक्शन, आप सुबह उठोगे, आपको सबसे पहला काम ये होगा कि आपने अपना सब्सटेंस ढूंढना। अगर सब्सटेंस नहीं मिलेगा तो आपको और कोई काम नहीं है उसके बाद। यू हैव टू फाइंड द सब्सटेंस, यू हैव टू फाइंड द नीडल्स, यू हैव टू फाइंड एवरीथिंग जो आपके पास हो सकता है। नहीं मिलेगा तो आपको बंदे ढूंढने हैं जो आपको देने वाले हैं, वो नहीं मिलेंगे तो आपको इट्स अ ह्यूज प्रॉब्लम। तो पूरा दिन बंदा बिजी रहता है बेसिकली। जब आप किसी से एडिक्शन ले लेते हैं, वो इतना फ्री हो जाता है, उसको समझ नहीं आता कि मैं एडिक्शन छोड़ के अब जाऊं कहाँ, करूं क्या। सो वी हैव टू गेनफुली एम्प्लॉयमेंट हमें उनको देनी पड़ेगी। और गेनफुली एम्प्लॉयमेंट मैं इस तरह से अपने लड़कों को दे रहा हूँ कि नाउ विल टॉक अबाउट द बिग ब्रदर प्रोग्राम। सी बिग ब्रदर प्रोग्राम में आई गॉट ऑल दी सपोर्ट फ्रॉम द NA ऑल्सो एंड ऑल दोज पीपल की जो इस कॉज के लिए काम करना चाहते हैं। वी आर ट्रेनिंग those people who have been in addiction, who want to come out of it and they want to make money out of it, selling those courses also. So right now we're training ex-addicts to be life coaches and जो community में जाके आगे लड़कों को तैयार कर सकें। and we are hoping to build a community of de-addiction coaches. तो अभी तो we are at a figure of about 20 odd coaches, लेकिन what I believe is कि जिस दिन ये 200 या 2000 या 20,000 हो जाएंगे कोचेज, उस दिन जो आईडी यूज की या जो ड्रग एडिक्शन की प्रॉब्लम है वो काफी हद तक दूर हो सकती है। सो आई थिंक माय 10 minutes शुड बी ओवर बाय नाउ। और दिस वाज माय फर्स्ट टाइम पब्लिक स्पीकिंग, सो एक्सक्यूज मी अगर मैं थोड़ा सा नर्वस हूं।
थैंक यू, यू स्पोक रियली वेल।
थैंक यू।
मेरा एक सवाल है आपसे।
जी सर। जी।
आपने कहा कि आप लाइफ कोच के तौर पर ट्रेनिंग देते हैं।
जी।
आपके ट्रेनिंग का एलिमेंट क्या होता है? आप किन मुद्दों पर आप ट्रेनिंग देते हैं और आपको क्या लगता है इससे किस तरह से आप ड्रग यूज में जो लोग हैं उनको आप वापस मेन स्ट्रीम में लाने की कोशिश कर रहे हैं?
सी सर, व्हाट आई बिलीव इज वेरी गुड क्वेश्चन, थैंक यू फॉर द क्वेश्चन बाय द वे। तो सर सबसे पहली जो एडिक्शन में प्रॉब्लम होती है दैट इज नॉट द डिटॉक्सिफिकेशन प्रोसेस। डिटॉक्स तो हो ही जाता है। आफ्टर द डिटॉक्स प्रोसेस जब इंसान कम्युनिटी में अपनी वापस जाता है ना, तो उसके ऊपर भरोसा नहीं करते हैं। नॉर्मली एक स्टिग्मा होता है, एक ठप्पा होता है उसके ऊपर ड्रग एडिक्ट का। तो अगर आप किसी नौकरी में थे मान लीजिए, तो आप ड्रग यूज में चले गए, उसके बाद आप कंपटीशन से बाहर हो जाएंगे धीरे धीरे आप सोसाइटी में पीछे रह जाते हो। अगर आपके बिजनेस थे, आप पीछे से अच्छे हैं और आपके पेरेंट्स की या किसी की बिजनेस है जिसमें आप जुड़ सकते हैं, वहां पे पैसे का लेन देन होता है, वहां पे आपको भरोसा नहीं करते। वी आर गिविंग जो टेक्निक्स हम सिखाते हैं, बेसिकली लाइफ कोचिंग की टेक्निक्स होती हैं जिससे आप इंसान को एक बेहतर इंसान बनाते हैं, उसका बेहतर वर्जन बनाते हैं, राइट। और फिर आगे आप लोगों को ट्रेन करके उनको बेहतर वर्जन बनाते हैं। तो वो टेक्निक्स अपनाते हुए जब हम किसी इंसान को ड्रग से बाहर लाते हैं पहले, उसके बाद उसको बेहतर इंसान बना के फिर उसको एम्प्लॉयमेंट अपॉर्चुनिटी देते हैं, जिसकी वजह से उसको पूरा दिन में करने के लिए इट्स अ फीलिंग ऑफ सोशल वर्क दैट इज इन्वॉल्व विद इट। तो किसी आदमी को आप अगर मिशन दे दोगे, किसी के पास अगर करने के लिए काम है, तो बढ़िया बात है, वो अपना काम करे, अपने घर में जाए, सब कुछ करे। लेकिन पहले जो लोग डरते थे कहने से कि कहीं पे, जैसे मान लीजिए अभी हम एडिक्शन रिलेटेड उसमें घूम रहे हैं, तो यहाँ पे तो खुल के बात हो सकती है, लेकिन फैमिलीज में जब कोई एडिक्ट अपनी फैमिली के सामने खड़ा होता है, कहीं पे भी किसी सेटिंग में चला जाए, तो कहीं पे अगर नशे की बात शुरू हो जाए, वो घबराना शुरू हो जाता है कि अब मेरी बात होने वाली है और मैं यहाँ से निकल जाऊँ, क्योंकि बेइज्जती महसूस करता है। लेकिन विद आवर प्रोग्राम दे फील एम्पावर्ड बिकॉज ऑफ ड्रग यूज। दे काइंड ऑफ, जैसे मैं अभी आपके सामने खड़ा होकर सबके सामने बोल रहा हूँ, इवन माय फैमिली इज वाचिंग। तो पहले मैं भी घबराता था, डरता था बताते हुए किसी को कि मैं ड्रग यूज में रहा हूँ या था या हूँ या व्हाटएवर। अभी आई फील वेरी प्राउड कि मैं ड्रग यूज में था, उससे बाहर निकला हूँ और आई एम ट्राइंग टू हेल्प पीपल नाउ। सो इट्स अ प्राउड फीलिंग। सो ये इट्स अ मिक्सचर ऑफ ऑल दीज थिंग्स कि जिससे जो हमारे कोचीज हैं, they feel very proud and they go out and help the society। अपने परिवार में, अपने पूरी social setting में they feel कि उन्होंने कुछ conquer किया है and they earn money out of it also। So this is
thank you, and you are part of NA as well?
Yes sir, yes.
I have one question.
Yes sir.
क्या पंजाब में फीमेल जो इंजेक्टिंग ड्रग यूजर हैं और उनके लिए ड्रग डी एडिक्शन सेंटर है तो कितने हैं?
सर अभी बहुत कम है, जितने होने चाहिए उतने बिल्कुल नहीं है। चंडीगढ़ एरिया में ही है 3-4, लेकिन in this program I'd like to talk about Anuradha ji also. As you see, this is Anuradha ji. So she's in the program to help females only. तो ये anonymously females को ही help करती है. She doesn't deal with males.
क्योंकि females के साथ प्रॉब्लम होती है कि सामने नहीं आते, फैमिली so many problems are there.
Exactly right.
तो आ जाते हैं लेकिन females.
बिल्कुल, you're exactly right. So that is why we have a female partner in the program to deal with females particularly.
Thank you, Vikram ji. Thank you.
Thank you, sir. Thank you everyone for your time. Thank you.
Our next speaker is Dr. Sanjeev Mondal, MD Pediatrics, DM Fellow Pediatric Clinical Immunology and Rheumatology, PGI Chandigarh. I will invite to Dr. Sanjeev Mondal to give him presentation.
Good morning all. I am Dr. Sanjeev, DM Fellow in Pediatric Clinical Immunology and Rheumatology from PGI Chandigarh. So first of all, I will thank all the organizing committee for giving me opportunity to present my case. So I'll present a case of a child who presented with some unusual manifestation. Usually in daily practice, we see with recurrent infection, the child is presenting to us. But here we will present a case, a 7-year-old boy who presented with us with chronic bacterial syndrome. Next slide. So we have Master P, 7-year-old boy from Bhatinda, who was admitted in month of September in 2021 and admitted with us for around 11 days. He presented with us with abdominal distension for 3 months and pain abdomen for 3 months. So basically, he was absolutely fine till July 2021. He developed abdominal distension that started insidiously and gradually progressive, and it was associated with discomfort. Also, the child had abdominal pain that was diffuse in nature, persistent, dull lacking, that was presented all over the quadrant, and there was no radiation to the back. So for this complaint, he was being evaluated and treated with from the OPD practitioners, from the local site practitioners, and treated with multiple times for constipation and antispasmodic, and also evaluated for celiac disease. However, the child had no history of any fever, loose stool, vomiting, constipation, no history of any burning micturition, no history of any increased frequency skin rash, no history of any altered sensorium and convulsion. So for this reason, the child was referred to PGIMR for further evaluation and management. So when the child came to PGI, we also found out the detailed history of the child, and in past history, the child had only one episode of bilateral ear discharge at the age of 4 years. Birth history is non-contributory. The child is developmentally normal as per age. The child was immunized as per national immunized schedule, and the child is born to an unconsanguineous married couple, no similar history in the family member, and child born belongs to a lower socioeconomic sources. Father is a daily wage worker. Next slide. Examination wise, the child had stable vital with the heart rate of next slide, heart rate of 102 per minute. BP was within the 75th to 90th percentile. Respiratory rate was 23 per minute. The child had moderately stunting. On Jan physical examination, he had pallor, bilateral onychomycosis on the finger, and abdomen was grossly distended. Next slide. On system examination, the child has hepatosplenomegaly, the liver was tender, and also he had mild free fluid in the abdomen. Otherwise, the other system was normal. Next slide. So when he came to PGI, he was admitted first in the pediatric gastroenterology unit, and he was being worked up for celiac disease and chronic liver disease. So before planning liver biopsy, he was tested for HIV and he came out to be positive. For this, he was shifted to our unit in immunology unit for further management. Next slide. So on investigation, the child had mild anemia. There was no lymphopenia and thrombocytopenia. The child had significantly low CT4 count, 168 per microliter. The renal function test was normal. The liver function test was also normal, and the coagulation profile was normal. So before starting ART, we also tried to exclude the opportunistic infection. We performed the tuberculosis skin test, gastric lavage for AFP gene expert, that was found to negative. The cytomegalovirus PCR, toxoplasma PCR was also negative. And scraping from the nail was performed for fungus isolation, that was also negative. For coagulation abnormality and abdominal distension, as I will show, in USG there is a defect in the inferior vena cava in the intrahepatic part. So that for this reason the coagulation profile also performed. That showed abnormal normal antiphospholipid antibody titer, and protein C proteinase titer was normal, and serum homocysteine was also normal in this child. Next slide. So chest scagra was normal. Ultrasonography showed attenuated intrahepatic IVC, feature suggestive of Budd-Chiari syndrome. And for that reason, the MRI also performed. That showed chronic liver parenchymal disease with features of chronic Budd-Chiari syndrome. Next slide. Here is the MRI picture. Here we can see the liver is enlarged with coarse ecotexture. And in the angio, there is an attenuation of the inferior vena cava intrahepatic part, that is suggestive of Budd-Chiari syndrome. Next slide. So when we evaluated the fundus, we saw there is a fluffy opacity in the retina, that is suggestive of retinitis. And for this reason, we tapped the vitreous, and the CMV PCR was positive for this child. So the child started with the intravitreal ganciclovir. Next slide. So finally, we diagnosed the child as child living with HIV and severely immunocompromised. CD4 count is 168 with chronic Budd-Chiari syndrome with cytomegalovirus retinitis. Next slide. So we started the child on the treatment of ALD regimen after ruling out opportunistic infection. For Budd-Chiari syndrome, the child was started on enoxaparin, that was given for 3 weeks, followed by oral warfarin for 3 months. And also the child continued on ganciclovir for CMV retinitis. Parents were also screened and started on reactive after positive results. Next slide. So in follow-up after 4 months, the child is doing well. There is no pain abdomen, abdominal distension has been reduced, child is gaining weight, and no further opportunistic infection, and the parents were counseled for adherence to the medication. Next slide. So on discussion, patients with HIV encounter several complications, including vascular thrombosis during their lifespan. Patients with HIV are always at higher risk for developing arterial and venous thrombosis, especially in the setting of severe immunocompromised state. In many studies, it has been shown CD4 count less than 200, the patient may develop thrombosis at any point of time in life. So acquired protein C and ACE deficiency, increased level of anticardiolipin, lupus anticoagulant, anti-dimer, disseminated opportunistic infections such as CMV, non-tuberculous mycobacterium, and drugs like protease inhibitor have been postulated as reasons for thrombotic events in this subset of patients with HIV. Next slide, please. So in Budd-Chiari syndrome, generally we exclude the coagulation profile workup and maximum the hepatitis B and C. The other viral profile is not shouted in general. However, there is a case report in HIV that one child of 6-year-old boy that has been reported with recurrent thrombosis that presented with renal artery thrombosis, middle cerebral artery thrombosis, and hepatic vein thrombosis. And in another adult patient who presented with brachial artery thrombosis and diagnosed to have HIV. Next slide. So in conclusion, diagnosis of HIV may help the index child with starting antiretroviral therapy, timely and improvement of the CD4 count. And detection of the therapy for hidden CMV infection can prevent recurrent thrombosis in the index child. So I presented this case because of this unusual presentation, because if the child is not diagnosed in time, the child in future may develop again thrombosis due to the endothelial injury and coagulation abnormality. So timely initiation of ART can prevent the further thrombotic event in this child and also the infection in this child. Thank you.
This presentation, we come to an end of this particular session. But before we close, I have a quick question from Ms. Gill. You talked about live cases in Chandigarh to the tune of around 5,000 plus. And you said that out of them, around 1,079 are of Chandigarh. So roughly 20% are from Chandigarh and 80% are from outside Chandigarh. So what challenges do you face in terms of following up the LFU cases? If you can talk about that.
सर LFU जो केसेस हैं उसके लिए CSC है हमारे पास, जो भी हमने प्लान किया है, जो CSC है पहले अंबाला, यमुनानगर, पंजाब 3-4 स्टेट्स को जो लिंक के ART सेंटर था उनको भी वो फॉलो अप करता था, बट नाउ वी आर एक्सक्लूसिवली वर्किंग फॉर चंडीगढ़। तो वो सिर्फ चंडीगढ़ के LFU होम बेस्ड उनकी काउंसलिंग करेगा, एडहेरेंस करेगा, तो उससे जो हमारा वायरल लोड सप्रेशन का जो डेटा है जहाँ पे हम लैग कर रहे हैं 86% है, उसको 95 लेने के लिए हम वी विल अचीव दैट टारगेट।
Thank you.
Thank you, our chair and co-chair. I request our project director, Dr. Amandeep, to please honor our chair and co-chair. Shri Munish Kumar, team leader, technical support unit, NACO. Thank you, Munishji. Dr. Sapna, medical officer from GMSH 16, Chandigarh. Thank you, ma'am. And Shri Kamaljeet Singh, assistant director, CST, Chandigarh SATS. Thank you. Before starting the next session, I request our project director and Dr. Shobni Rajan, Deputy Director General, TI and BST NACO Division, to please light up the lamp. Ma'am, we were waiting for you. We didn't light up the lamp. So I request our chair and co-chair for the session also to please join for lighting up the lamp. I request Mr. Sandeep Mittal, Deputy Director TI, and Mr. Manjeet Singh Gulia, Jitendra Dhaiya, Sunil to please join the colleagues from SACS to please join for the lighting up of the lamp, please. आप थोड़ा आगे कर लीजिए. I request our physical speakers also to join. I'm not there. Ji ma'am, thank you. Moving on to our next session for the day, HIV and sexual reproductive health and rights. It's an honor to invite Dr. Rita Prasad, Project Management Specialist from USAIDS. Dr. Rita Prasad holds a degree in medicine with masters in public health and has a wide experience ranging from clinical, medical to public health. She has been involved in management and control of infectious diseases like HIV/AIDS, tuberculosis, maternal and child health, adolescents health, nutrition, and various research programs over the past 20 years. In her long years of service in public health, she has worked right from remote and backward districts of various states up to the national level. It's an honor to welcome her today to chair our session. We welcome you, ma'am. I hope she has joined us.
Yeah, thank you so much. Thank you. I'm here.
Right. I request and welcome Dr. Jyot Khosa, Senior Technical Advisor, International Planned Parenthood Federation, South Asia Regional Office, to co-chair and moderate this session. Harjot is currently working as Senior Technical Advisor at International Planned Parenthood Federation, South Asia Regional Office. She is a feminist who has long been working on health and human rights of communities. She is actively involved in civil society and community rights movement across South Asia. Her areas of interest and hard work include gender, sexual reproductive health rights, maternal health, HIV, TB. It's an honor for me to welcome her here today, and she is the co-chair and the moderator for today. We welcome you, ma'am.
Thank you so much, Tinu. Thank you so much for the warm welcome.
I welcome our chair and the moderator today, and handing over the session to them, please. Thank you.
Thank you, Tinu. And good morning, everyone. We really miss not being there physically, and we can see the vibrancy there and the all the beautiful faces. So hope that next year we will be there doing this conference and this annual extravaganza where we get opportunity to meet everyone and be there physically. So thank
seriously,
you.
Seriously, Rita ma'am, even we are missing you. The group photographs are being missed. The mementos are being missed. We are really, really missing you. But the positive point is that we are reaching to more than 1,000 people today. They have joined us.
Wow.
And they are listening to you. Your information is being shared with them. So it's a great honor for us. And it's really, really, really very pleasing that so many people have joined us today. I want to thank our virtual audience also for joining us, and handing over the session now to you. Thank you.
Thank you. Thank you. So we all move to this next session. We know, over the time, we realize that comprehensive sexual reproductive health is need for people living with HIV and also key population, and we have seen this within the program also under the revamped TI strategy and other care and treatment interventions. They have been addressed. Strengthen focus on sexual reproductive health rights and HIV linkages through multi-sectoral approach. It supports the achievement of both joint health outcomes. It promotes health outcomes, and it goes beyond the disease specific to a very holistic perspective. So we have got interesting presentation lined up today, and we'll learn more from it and see in our concentrated epidemic what are the learnings which can be adapted in country context. So with this opening remarks, I'll just introduce our first presenter. And our first presentation is Nisha Jaktish. She is Director Gender Rights with the Family Planning Association of India. She's a postgraduate in social work, and she has got over 3 decades of experience in development sector specialty, sexual reproductive health and HIV in India. And her areas of expertise include planning, designing, and implementing integrated gender transformative need-based community intervention for diverse groups, focused on addressing the sexual reproductive health needs of people living with HIV from all groups. So her topic, and she's going to talk about sexual reproductive health needs of young people living with HIV in India, and she'll share her experience from demonstration sites. And we all hope that this will give us much needed insights into the needs of young people living with HIV in India. So Nisha Jaktish, over to you.
Thank you so much. I'm going to present today our experience of working with the young people living with HIV from one of our branch side.
Next slide, please.
Just to give a background of the issue, we all know that 30% of all new HIV infections occur in the age group of 10 to 25. And in India, it comprises about 25% of our populations. Around 31% of AIDS burden in this age group, which indicates that these are at high risk of contacting HIV infections. Now, coming to the children infected at birth, they have to deal with their HIV status along with issues related to their sexuality. They are more vulnerable to STI, especially the girls, because of the gender discrimination, societal norms, and their dependency, economic dependency, which increase the risk to these infections. Also, in the absence of right guidance, information on SRH and CSC, they may land up in unprotected sex, may have repeated infections through sexual exposures. And coming back to women, young women living with HIV due to lack of access to services, they may be unplanned pregnancies, early marriages, because they have less power to exercise control over their sexual lives. I'm going to speak about our experience of implementing the project based on this context, optimizing sexual and reproductive health services for effective outcomes, which was implemented at one of our branch, that is Pune. This project was implemented in last year, April to December. The main focus is to strengthen women living with HIV with SRH response and provide screening and treatment for cervical cancer, and also work with the young people living with HIV and provide them comprehensive sexuality education to equip them with knowledge, skills, and efficacy to make informed decision about their sexuality and lifestyle, and also to develop champions to sustain our programs. Next slide, please. So what actually we did in this project is we partnered with the network of Maharashtra people living with HIV, collaborated with ART centers to establish SRH help desk. We have dedicated a day, that is Friday, to provide clinical services to people living with HIV. We also did a needs assessment to assess the SRH needs of our young people, build the capacity of young people and women living with HIV, and we conducted age-appropriate comprehensive sexuality educations and increased access to integrated HIV SRH services. And we developed the capacity of young people to provide these information to their peers and develop them as champions. We also promoted positive prevention strategies for young people to protect their sexual reproductive health. Next slide. So this is a small needs assessment study which was conducted with 97 young people who are living with HIV. And this is the Google form developed in Marathi, since Pune is in Maharashtra. So make it easy for the participant to respond. So 65 male and 32 female responded to this Google survey. And nearly 52% of the respondents were pursuing higher education or studying. So coming back to the main point, asked whether they have access to SRH information, nearly 53% respondents responded that they have access to information, and the source of information is through internet and friends. These are multiple responses. So when asked about their access to SRH services, more 63% of the respondents replied that they have no access to SRH services, and those who have responded yes, they said they know only that the services are available at the government facility, because they always go to the government facilities to access ART center. So that is the only one institute they are aware which provides SRH services. So this is about the knowledge about contraceptives, the source of contraceptive knowledge, from where they got this information. Both the respondents said, through the government and private facilities, they knew something about, contraceptive, though not all types of contraceptives. Mostly it is condom and oral pill. And some responded that through books and newspapers, they got this information. Few male responded, they got also this information through their friends. So this shows that the information about the contraceptive and the SRH knowledge among this group is not proper. Next slide, please. So this has already been explained. Can we go to the next slide? So then, in addition to this Google form, we also requested the participant the topics that they would like to know more about it. So these are some of the topics they express the desire, which clearly shows that they want more information on comprehensive sexuality education, which includes about the sexual health. Apart from that, the need to have more information on SRH, like, whether they can marry, whether they can plan a pregnancy, whether the delivery will be safe, breastfeeding options, and also on sexual orientation. Next slide, please. So what worked well for us in this project is that we created an enabling environment which is stigma-free and provided age-appropriate comprehensive sexuality education to the young people to enable them to make informed choice about the SRH, maintaining the confidentiality of their HIV status and the sexual orientations. We provided them counseling on sexual health, sexuality education, how to deal with the disclosure, condom promotion, treating them with STI, RTI services, arranging them, youth-friendly services, which include safe abortion, safe conception, counseling, breastfeeding options, and management of GBV, gender-based violence. So overall, what we achieved is we built the capacities of the network and the women living with HIV on SRH issues, set up a SRH desk at 2 ART centers, and screened more than 300 women for cervical cancer. We worked exclusively with 132 PLHIV families. The needs assessment done with 97 young people reflected what actually they want to have in the CSC. So around 15 CSC sessions arranged for these people, both online and offline. It was attended by 163 young people. Because of the COVID restriction and COVID lockdown, many people could not attend. And I wanted to stress here that this is a special group. The children are born with HIV. So the sessions has taken longer time because their understanding of various issues and the age, has taken longer time for them to, understand the issues than compared to other young people, who are not living with HIV. So in this project period, we developed 71 young people as champions who will sustain our interventions in future. The services accepted by the FPI, the integrated SRH and HIV services, were accepted by the young people and their parents because there is no stigma, and we also empowered young people to share the responsibility and not to take the blame on themselves because of the HIV status. Also partnering with NGOs that work with young people helped us a lot. And we have initiated a WhatsApp group of these champions to, help them to get instant support from us. We also try to help few young people who were interested to take on some professional course or start some business. So the branch has identified few donors who are ready to support these young people in whatever the area they wanted to take ahead, whether it's education or a vocational course they wanted to pursue. Next slide, please. So what are some of the challenges? As I've already mentioned, a lack of awareness is there about SRH and sexuality among this group. Understanding of the issues related to sexual orientation and gender identity is still there. Self-stigma related to their HIV status, due to that, they have fear of rejection by their friends and partners upon knowing their HIV status. Due to that, a lot of mental health issues faced by these young groups. And, we had to address a double stigma if their sexual orientation is different. And the challenge is that each age group and each, young people require different set of programs, age appropriate, so that will take a separate interventions for each young people in this category. Next slide, please. So what are the lessons we learned? We need to build the capacity of the staff to provide competent and non-discriminatory services. And we need to include CSE in our school, college programs, which provides a positive approach to the sexuality of young people who will come to know about the safer sex, sexual health, and safe pregnancy. We need to provide youth-friendly services in the clinic, including safe abortion services to young people whenever they required. Counseling will play a major role in working with young people because they need a lot of psychosocial support, and there is a need to develop community champions or support groups who will help them constantly to deal with their rejection and deal with the disclosure. And we should also empower them to disclose, when and with whom approaches with their sexual partners, so that they accept the rejection as normal, and also about the sexuality and serodiscordant relationships. We need to build partnerships for advocacy. We have to establish referrals for the cross-referral services and advocate for the integration of SIV and SRH for young people, especially living with HIV. Next slide, please. So these are some of the recommendations I would do. We need to promote positive prevention strategies for young people, because young people is a vast group. Each young people who comes into this bracket have different needs. The young people who are born with HIV may have different needs, and the young people who have infected HIV through other modes at the later stage have different needs. So we need to promote positive prevention strategies for everyone. Also to build the capacity of the mainstream SRH and HIV organization to include young people with HIV and to provide HIV and SRH services as and where as applicable. Young people needs to be involved in all decision-making process at all levels, ensuring meaningful representation and their views are taken positively. We need to promote comprehensive sexuality in schools and colleges and have to address the mental health issues. Next slide, please. So I would like to thank IPPF SARO for their technical support, NCPI and NMP Plus and all the networks for their support in implementing this project, to ART centers and all our young volunteers of Pune branch, and of course FPI, SMT and Pune branch who have implemented this project, to all the staff and volunteers. Thank you so much.
Thank you, Nisha. I think it was a very good presentation highlighting the needs of young population. I want to understand from you, you use the term of age-specific sex education. So why do you think, that age-specific sexuality education is needed now, So can you elaborate a bit more on that?
Yes, because when we say young people, it starts from 10 to 24. So the 10 to 14 age group children, have the specific needs. They may not, understand all the components of sexuality education. So we may start with the good touch, bad touch, acceptance, peer pressure, so those things. And when it comes to a little older age, like 15 plus and all, they may want to know about the attraction, whether the attraction towards the same sex is normal, or about the relationships, whether they should have a relationship with the sero, positive, or, how to disclose. So the components are different. So we need to develop age appropriate, interventions for different people. And I also say that since our intervention, participants were the children born with HIV, so their needs are different when we talk about young people or who have been, infected, got HIV infection from other modes of this thing. So these are our, learnings. So we need to have different set of interventions for different age groups.
Thank you, Nisha. I saw you gave a lot of good recommendations. So can you also tell us how within the scope of program, you can expand it to include the SRHR needs of young population. So do you have anything very specific, few things which we can, give as a recommendation of this? Yeah.
So I would, I would have, we need to promote the human right aspects, the confidentiality of their status and acceptance of their orientation is one of the things. They should have right to privacy and, supportive environment by the service providers. So we all know that in the healthcare setting, a lot of stigma is associated, so needs a lot of sensitization of service providers, especially they are more familiar with the service provider at the ART centers. So the ART center staff needs to be oriented about the other issues of the young people also. HIV is one part, but they need other, information, whether it is, growing up, whether about, the relationship, sexuality, family planning methods, how they can protect themselves. In case if they wanted any services related to safe abortion, where they can go, there are a lot of discrimination if they are living with HIV, if they are not married, the stigma will be different. So these are some of the recommendations. I would say that the service provider, whether they are SRH or HIV, they need to know about the other things, integration should be there. So especially the counselors or the service providers, along with providing whatever the services, like one example is ART center, where every month the young people go there, they need to be sensitized that these young people, may not have, got this infection from other modes, normally the perception is there in India, most of the infections are through the sexual route. So these children are born with HIV, so they should not be, felt that, how you got this information at this young age. So a lot of sensitization is, required. And also about the, mental stress they have, they take all the responsibility on themselves, so that shared responsibility needs to be, given to them, that they are not responsible for this thing. Both, the partners, whether they are non-HIV partners, also have the same responsibility like theirs. So the burden becomes less.
Thank you, Nisha. I think this was very informative. And we understand the need of our is to have more age-appropriate person-centric care and HIV care facilities. I'll also request Arjot to see if we have any questions from audience in chat.
No, Dr. Rita, we don't have any questions, but I would also like
Yes.
to thank Nisha. And I also firmly believe that serving the SRH and mental health, what Nisha was mentioning, needs of adolescent living with HIV in a responsive manner will definitely strengthen their use of the system and elevate it to a source of resilience. Like, this is what we envisage, and I think this is a very good model, Nisha. Thank you so much for sharing.
Thank you so much.
So thank you, Nisha. And
Yeah,
we will
thank you.
move to our next presenter. Our next presenter is Amita Dhanu. She is heading the program team at Family Planning Association India, holding the position of Deputy Director General. She's a master's in sociology from Delhi School of Economics with diploma in business management from Mumbai. She has worked for 28 years in Family Planning Association India, initiating several projects and managing programs in sexual reproductive health with a focus on adolescents, women empowerment, and HIV/AIDS intervention work. So she has been part of, I think, issues of sex workers and help improve their health-seeking behavior. And this particular project, which she's also worked with Bill and Melinda Gates Foundation, and in partnership with FHI 360. And she is going to talk about her experience of, implementing this work in Family Planning Association of India. And I'll hand it over to Amita. So over to you, Amita.
Thank you so much, Dr. Rita. And I also want to thank the organizers for giving me this opportunity. And of course, a big thanks to IPPF we are a part of the IPPF family. So big thank you to IPPF for giving me this opportunity. So I would like to share my presentation with you. If you can allow me a moment to share the screen.
Yeah, we can see the screen, ma'am.
So, yeah. So friends, the session that I would be talking about today is no debates about it, addressing sexual reproductive health needs of the LGBT community. Now, this was actually what we are talking about today is a situation analysis that we have done as a part of a project that we got from the IPPF that's called the Movement Accelerator Project, which was talking about or wants to kind of address the needs of the lesbians, bisexual women, and the trans-masculine persons. Now, now FPI has ample experience of working with, the Can you all hear me?
Yes, yes, very clearly.
We can hear you very
There was
clearly.
some tech issue. I couldn't hear anybody at all. Yeah. Okay. Anyway, so the Family Planning Association is one of the largest NGOs of the country, and we were founded in 1949. And as you can see, that we have a presence across 17 states in the country, and we impact almost 30 million marginalized populations annually. And we work in multi-sectoral partnerships with the government, corporates, and the NGOs. And of course, we are champions of gender equality and women empowerment and sexual reproductive health. We have our own clinics, and we work through multiple service delivery points. We have our own clinics across 39 locations. We are working in partnership with the government, and we have 14 urban family welfare centers. We provide services to mobile clinics, satellite clinics, and of course, to the frontline workers. And the stamp that you're seeing on the right was issued by the Government of India when we come to commemorate our 50 years. Now, coming on more specifically to the study that we conducted and the project at hand. Now, as I was saying earlier, that FPI has ample experience of working with, with the MSM populations, with the transgenders, and we have integrated services for these groups in our own clinics. However, we were also now wanting to get into a newer space, and that is to understand the sexual reproductive health needs of lesbians, bisexual women, and trans men communities. So this is how we kind of, and we realized that services for these groups need to be designed separately. We need to understand what are their SRH needs. And typically, most of the work that has been done with the LGBTI communities has focused primarily on gay and bisexual men, the MSM populations, and trans women. There is a gap in scientific literature regarding the SRHR needs and issues of this LBT community. And of course, they are invisible in the mainstream LGBTQ movements. HIV, STI awareness, and sexuality education curriculums, etc. They just don't mention these groups at all. And they face double vulnerability due to discrimination, homophobic, transphobic violence, as well as patriarchal violence. So this study that we undertook was undertaken with the objective to identify the felt SRHR needs within the LGBT communities and to identify how outreach interventions can be made more specific, keeping in mind the needs of these groups, and also to give them more visibility. So we had the methodology that we adopted was a mixed method, which included in-depth desk review of articles and media reports. We had about 20 interviews with the community, community level participants. We also had interviews with 50 stakeholders, such as the government, ministries, NGOs, public health experts, and so on and so forth. Now, I'm not dwelling too much on the desk review because it's kind of getting repetitive when we're talking about the stakeholders and the community views. Just quickly to say that the desk reviews threw up a lot of information around discrimination in schools, discrimination at the workplace, conversion therapies, mental health issues, and of course, gender affirmative surgeries. The data that we collected, I'm quickly taking you through what the community voices had to say. What came across very strongly was there was lack of acceptance from the families. The LBT populations lose financial support, have to discontinue education, and they have to be, sometimes they have to leave home because of rejection by the families. Now, LBQ plus women, couples, these women couples are harassed. Families involve the police, and there is sexual abuse in the form of corrective rape, forced marriages. Trans masculine persons, they are shamed for their gender identity and for wanting to alter their body. So they have to go through a lot of ridicule and bullying and harassment. Similarly, in the Education Institute, there was a lot of bullying reported for non-conforming gender expressions, and LGBTQ terms were used as insults and abuse. LBQ women are desexualized, they were assumed to be asexual if they're not interested in boys. So because this is a complete, binaries, gender binaries is what the world knows. So they were unable to kind of understand and relate to the specific needs of the LBQ women. Lack of gender neutral washroom for trans masculine students, that was another huge issue that came up. Trans people face hurdles while changing their name on education certificates. Almost all the respondents felt that education institutions have not been inclusive spaces for them. One respondent shared her difficulty that she wanted to join NCC as an extracurricular activity, but she was unable to do so because she heard her senior officials talk about not accepting gay populations and trans men, and so she was very scared of being singled out, so she did not opt for this extracurricular activity. Discrimination at the workplace. So trans masculine people fear being sexually harassed and discriminated against at various stages of transition. LBQ women get asked invasive, inappropriate questions. There's a dress code at the workplace which is not inclusive for general non-conforming people. For example, someone with a masculine gender expression may get discriminated against, and they are not able to kind of understand how do they even dress to be able to express themselves. One trans man also reported that had to leave school before even completing senior education and had to support the natal family. As a result, they had to work in a garment factory, which is a part of the informal and unorganized job sector that has no LGBTQ inclusive laws to protect them. Moving on, there is, of course, lack of access to safe housing for this community. LGBTQ age 18 to 25 usually don't have the financial stability to move out of unaccepting homes. LGBTQ women who cohabit with their partners are able to pass off as cousins, friends, etc. There's constant check by property owners, neighbors when LGBTQ plus couples are seen. They cannot apply for joint housing loans as they lack spousal rights. This is another very serious problem that is expressed by the community, that there is inaccessible gender-affirming binders or procedures for trans-masculine people. The cost of the binders were extremely high. HRT and surgical procedures were sometimes beyond their reach. And of course, binders are not available or are not well made in our country. Issues in intimate partner relationships. LGBTQ cannot adopt a child or access assisted reproduction. For married LGBTQ women, divorce process is tedious, traumatic, ridden with stigma, and women may be financially dependent or may already have a child. Lesbian women consider marriages of convenience to avoid family pressure, because there's so much of pressure on a girl to get married in our society that she would rather get into a marriage of convenience rather than be able to have the confidence or the wherewithal to confront the family. For trans-masculine people, intimacy is hampered by gender and sometimes body dysphoria. Coming more specifically to the unmet health needs of this group, for lesbian and bisexual women, what was reported is that many respondents from this category felt that their physical health needs are not different from straight women, like, for example, PCOD or other reproductive health issues. Respondents shared that their sexuality does not really come up in conversations with gynecologists, and they don't bring it up for fear of stigma and discrimination. So the respondents felt that, the doctors do not have the language or the understanding to be able to, ask questions which would make the lesbian comfortable to come out about her sexuality and be able to talk about what is really bothering her. There is general lack of awareness about non-heterosexual sex. For example, typically in the medical setup or in the clinics, they are asked, are you married? Instead of asking a simple question as, are you sexually active? There's denial of services like abortion, and they may adopt sometimes dangerous tactics of self-abort. Coming to the trans men, one of the respondents shared that feeling discriminated in a hospital while they were admitted for dengue. The nurses gave weird stares and indicated a hijra clap as a gesture towards them. Another trans respondent shared that the doctor asked discriminatory questions about the surgeries and why they were needed. Male and female categories on hospital registration forms exclude trans and non-binary people, scrutiny of those with non-conforming gender expressions. So, of course, there's a lack of awareness regarding safe sex practices and lack of barrier methods. There is very little awareness around dental dams or for women having sex with women. They are uncomfortable and are not easily available. Often condoms are cut and they are used by the women. Finger condoms are not easily available, and there's very little awareness about them also. Problems in managing partners, marriages and childcare. This emerged as another reality that the lesbians are facing. Finding companionship through online is common. However, those respondents who were above 30 were mostly either married to a man or were in a relationship with a partner who's married to a man and found themselves in isolated situations where they did not know with whom to actually share their problems. Mental health also emerged as a very important, unmet need. Almost all the respondents shared that they have mental health issues and they have not been able to express, or they have not been able to be addressed sufficiently because lack of affordable queer affirmative mental health care professionals. Mental health care professionals are seldom trained to be able to understand the mental health issues of this group. One of the respondents said that they are treating their mental health themselves by checking Beck's depression questionnaire to assess their needs. Another respondent said that they use Instagram and YouTube for queer affirmative mental health advice to find comfort. Now, issues of transmasculine people in health settings, they are, as I've already mentioned above, that they are asked invasive questions regarding transition procedures. There's misgendering, lack of dignity in the hospitals, being put in female wards, not allowed to identify it as they prefer. And of course, there is dysphoria while dealing with menstrual issues. Now, talking to 50 stakeholders, which included the government, corporate houses, NGOs, legal professionals, educational institutes, public health, mental health professionals. The government functionaries said a lot has been done, and there have been inclusive legal changes for the LGBTQ communities. But there is a need for providing horizontal reservations to have positive affirmations or a reservation quota for hiring LBT people in public and private employment or education institutions and so on and so forth. They also said that very often the community does not come out in the open. Their networks are hidden. So it's very difficult for people to identify and to come out and really ask for their rights. They also spoke about structural conflation of gender and sexual identities in labeling oneself within the LGBTQI umbrella, where identities are not mutually exclusive categories, and consequently, many affected people are missed out of policy interventions as they are not defined under specific categories. Other stakeholders, like when we spoke to the corporates, the corporates said that building safe spaces for people in places of work through active inclusion in employment hiring processes was required. It was also important to have representation of the community in the in the prevention of sexual harassment committees in their workplaces. It's important to use gender neutral language, and provision of gender neutral toilet facilities were seen as the major areas of concern. Of course, there was also discussion about restrictive dress code, which I've already mentioned about earlier as well. Going on to our interaction with other stakeholders. So the NGOs and the CBOs felt that there is more representation of cis gay men and trans women as compared to lesbian and bisexual women and trans men, individuals in queer representational spaces that shadows the voices and needs of LBT members in NGO CBO sectors. They felt that there was more representation of those from the higher socioeconomic background than those from the marginalized communities. They also expressed that, while young people from the urban areas had more wherewithal, they had more they had more understanding about being members of NGOs and CBOs. This is not the case in the rural areas, where there's very little known about what does a person do and where do they kind of turn to. Speaking to the legal experts, they said that laws have been instrumental in decriminalizing homosexuality, but citizenship rights for LGBT plus individuals are still lacking, as the existing legal framework excludes them from the same-sex marriage, adoption, Domestic Violence Act, and surrogacy rights. Despite the provision for transgender men to get their TGID cards, and also provisions for criminal punishments being added in for discriminatory behavior against them in law, it is difficult to translate the barriers in access to legal rights. Legislation are not updated according to the judgments, and hence no effective changes have come in place. This is in reference to the NALSA and the trans bills. According to the Transgender Protection Acts, only a provision of imprisonment of up to 2 years is being mandated for rape against trans persons, while for women it is 10 years. And somebody from the community said, which was a pathetic attempt at inclusion. Again, there are no rights for marriages or adoption. Looking at the education sector, there was no material available on LGBTQI in the syllabus. Awareness gap based on socioeconomic background, inculcating a good, so if this was recommended, it's important to have a good comprehensive sexuality education program that is inclusive of all gender and sexual identities. Now, coming to the public health, people that we spoke to, the respondents focus on the SRH needs of LBT community. Most stakeholders commented that reproductive health services for the LBT community and the general community seems to be quite similar and can be easily accommodated in their general practice. However, there is a lack of experience in facilitating disclosure of sexual orientation. There's a lack of specific knowledge and skills or the vocabulary to discuss health struggles of LBT communities or the clients. There's complete lack of privacy in SRH clinics. There's a need for inclusion of LGBTQ adolescents when the services are being designed. And there's a need for a toll-free helpline to provide information on SRH for LBT communities. Mental health services, there is a lengthy procedure for mental health evaluation before medically transitioning. There's ignorance from care providers. For example, there's misgendering, regressive practices of conversion therapy, and there's lack of standardized practice and checks. Coming to a very interesting part that was kind of covered up in our study. We spoke about the impact of the digital and the virtual access, and respondents in the age group of 18 to 25 were most aware of their rights and needs. This group had a large presence on social media and were an active part of many virtual peer groups and networks. Many had reached out to local NGOs and LBT solidarity networks to ask for help and guidance. They had multiple ways of associating with their identity in terms of plural, queer, affirmative terminologies like androgynous, non-binary, gender non-conforming, genderqueer, pansexual, and polyamorous. They had found partners through online dating websites and other digital platforms. But if you look at the slightly older age group that we spoke to, that's 26 to 35 years of age, there was mixed response in terms of access to virtual presence. They were still comfortable and found support only from Facebook and WhatsApp networks, while finding companionship. Respondents 36 and above used old terminologies of identifying themselves like dykes, lesbians, and were not aware of the new terms available on the internet to identify themselves. They were either married or had a partner who was married and to a man with childcare responsibilities. They were not a part of any LGBTQ networks or digital platforms and felt socially isolated. So now coming to the critical part, that what did the study really recommend for service providers such as FPI? It spoke about, for the policy levels, the recommendations emerged were that there's a need to strengthen existing policies for the LBT to improve our outreach with the groups. It also spoke very clearly about banning all forms of conversion therapy, including corrective rapes, form linkages with trauma and rehab centers to help the LBT communities. There's need to improve health communications and to start awareness campaigns and free camps for STI screening and safe sex practices. There's a need to have gender-neutral washrooms in public areas, which is coming up again and again, both in our stakeholder interactions as well as in the communities. LGBTQI cells need to be established for sensitization of students, college staff, and employees. There's a need for horizontal reservations for the LBTs, and there is definitely more research that is required to understand the health-seeking behavior of LBTs. Strengthening, coming to the systems, strengthening data is important within this transgender umbrella so that trans men, trans women, and intersex, groups can really be identified for the specific needs of the community. There's a need for research to identify needs and health-seeking behavior of women in India. There's an importance to create a dedicated fund to build capacity and training to conduct research. And of course, there is a need to propagate trans-inclusive menstruation campaigns to build more awareness regarding safe menstrual practices. And there is a need to have regular screening for access to HIV cancers for the LBT populations. Now, looking at recommendations for service delivery, it's important to have safe spaces and new digital platforms for intervention at the community, stakeholder, and international levels to be able to have a dialogue and communication from within the LBT community without having the burden of revealing their sexual identities openly. It's important to create awareness generation on SRH and encourage more free screening at safe centers. It's important to sensitize the gynec departments in colleges and in hospitals to have standardized guidelines to deal with problems faced by the LB groups, have special wards in hospitals, train the staff and the doctors and the paramedics and the attendants, increase access to safe abortions and awareness regarding options for termination of unwanted pregnancies, and provide a better, safe, and low-cost options for sex reassignment surgeries in India. And with this, I end my presentation. Thank you so much.
Thank you, Amita. I think in interest of time, I will have just one question. Harjot, you want to go ahead, or I just want to know? I think it's a very insightful presentation because we don't hear much into lesbian, bisexual group. So I think Amita, really kudos to you to bringing out those lot of details and insights which. We sort of somehow miss, when we largely talk about the LGBTQI communities. So thank you for a great presentation. I just wanted to know, like you also gave a recommendation for service delivery. Do you have any kind of an existing model where all this your recommendation has been translated into some kind of a service delivery platform for them?
Yeah. So Dr. Rita, thank you for bringing this up. FPI clinics have been inclusive in terms of working with the MSM population, the transgenders, for a number of years now. However, our current project is kind of giving us the experience to start working with the LGBT communities as well. Now, while we do understand that the lesbians have special needs, but we are right now in the process of kind of building capacities of our service providers. Particularly, we are in the process of building the capacities of our counselors, because the counselors become the pivot around which the services for the groups can be pegged. We are also looking in terms of expanding our service delivery package to include specifically mental health issues. So we are trying to get in, mental health experts at the, particularly at the project locations where we are working this on this project. And basis our experience and our confidence, we will be then expanding it across our 39 clinics gradually as we go on. So yes, we are in the process of devising specific packages, but it's still initial days for us right now.
So thank you. We look forward to hear more from you on this, Amita. Great presentation.
Yes. Thank you so much.
Over, yeah, thank you.
Yeah.
So I'll hand over to my co-chair, Harjot Kosa, to introduce the next panelist. Over to you, Harjot.
Yes, thank you so much, Dr. Rita. And I also, before I get into the next, I want to thank Amita. And I cannot agree more with her that we need to build, evidences by designing comprehensive SRH program for LGBT communities. And as program implementers, as donors, we need to understand and bridge these gaps. And we need to have some service delivery models. So thank you so much, Amita. And coming to Sonal, it's such a pleasure to introduce Sonal Gyani, a friend and an activist who needs no introduction. And Sonal is a co-founder of an LGBTQIA+ initiative called Yariyan, and a Mumbai-based support group called Umang, which is a safe space for LGBT women and trans masculine personalities. And you all must have seen her as when she was featured in 8 Inspiring Indian LGBT Individuals as a top 20 LGBT role models by Cosmopolitan. And we have seen her on television, whether it's Connected Humtum on Z TV and also Bollywood film W and Purple Skies. So thank you so much, Sonal, and please, over to you when you talk about the social inclusion in South Asia.
Thank you, Harjo. Thank you, Rita. First of all, thank you for having me on this panel. I'm very excited and also very humbled to be presenting alongside stalwarts like Nisha Jaktish and Amita Dhanu. So great opportunity. आज का presentation Harjot, I would like to do it in a mix of English and Hindi because मेरा presentation पूरी तरह से अंग्रेजी में है, and I would like to keep it simple, so that is okay. तो So basically मेरा presentation मैं ये बात करना चाहती हूँ कि currently जो HIV programs हैं हम उनको किस तरीके से बदल सकें ताकि वो उनका जो जिस तरीके से प्रोग्राम चल रहा है वाकई लोगों को इंक्लूसिव हो उनके लिए। और अगर हम ये जो प्रेजेंटेशन में जो मैं बताऊंगी ये कुछ अप्रोचेस हैं जो काम किए हैं इन मेकिंग प्रोग्राम्स इंक्लूसिव एंड अप्रोचेबल फॉर कम्युनिटीज। Essentially, I'm going to talk about a situation assessment जो हमने किया था डाइवर्स सोजिएसी इंक्लूजन पर साउथ एशिया रीजन में। तो जब हम SOGI-SC की बात कर रहे हैं, ये बेसिकली उन लोगों की बात कर रहे हैं जिनका डाइवर्स सेक्सुअल ओरिएंटेशन है, जेंडर आइडेंटिटी है, या सेक्सुअल कैरेक्टरिस्टिक्स हैं, या डाइवर्स जेंडर एक्सप्रेशन है। नेक्स्ट स्लाइड। Am I able to click?
Yes.
ठीक है. So actually I am representing the International Planned Parenthood Federation, the South Asia Regional Office. तो जिनको पता नहीं है, ये IPPF एक्चुअली एक तरीके का महासंघ है उन संस्थाओं के लिए जो काम करना चाहते हैं ताकि जो लोग हैं वो अपने चॉइसेस इंडिपेंडेंटली बना सकें अपने लैंगिकता को लेकर के, और उनको सर्विसेज मिले बिना कोई भेदभाव के। और ये एक IPPF एक फेडरेशन है जो एक तरीके का मूवमेंट है। तो हम लोग जो हैं IPPF फेडरेशन के साउथ एशिया रीजनल ऑफिस से हैं, और ये 6 देयर आर 6 रीजनल ऑफिसेस, उनमें से एक है हमारा जो रीजन है, जो साउथ एशिया रीजन है। इसमें हम अभी फिलहाल 7 कंट्रीज में काम करते हैं। बांग्लादेश में काम करते हैं, भूटान में, इंडिया, मालदीव्स, ईरान, नेपाल और श्रीलंका में। और किस तरीके से काम होता है, ये जो फेडरेशन है बेसिकली एक फेडरेशन है संस्थाओं का, मेंबर एसोसिएशंस का, जो IPPF ने एक्रेडिट किए हैं या फिर उनके साथ कोलैबोरेट किया है। तो जो डिफरेंट फैमिली प्लानिंग पे काम कर रही हैं एसोसिएशंस अक्रॉस कंट्रीज, वो हमारे फेडरेशन का पार्ट है। So FPI also, we also support FPI, and FPI supports building this federation. ये आई एम वेरी हैप्पी टू बी प्रेजेंटिंग हियर, क्योंकि HIV प्रोग्राम्स एक बहुत बड़ा हिस्सा रही हैं हमारे जो साउथ एशिया मेंबर एसोसिएशंस हैं, उनके कनेक्शंस बिल्ड करने के लिए, खास करके गे और बाइसेक्सुअल आदमियों और ट्रांस औरतें या ट्रांस फेमिनिन लोगों के साथ। सो आज जिसकी बात मैं करने वाली हूँ, एक सिचुएशन असेसमेंट करा था हमने, पता लगाने की कोशिश करी थी कि सिचुएशन क्या है इन कंट्रीज में जहां हम काम कर रहे हैं। क्या कोई पैटर्न है जहां पे हम देख रहे हैं कि एक्सक्लूजन दिख रहा है, या कोई पैटर्न दिख रहा है भेदभाव का, जो एक तरीके से बैरियर ला रहा है सारे 4 सर्विसेज में, सेक्सुअल हेल्थ सर्विसेज में, इंक्लूडिंग HIV। नेक्स्ट स्लाइड। राइट। सो ये जो सिचुएशन असेसमेंट हमने करा था, बेसिकली हम जानना चाहते थे कि उस रीजन में कॉन्टेक्चुअली क्या प्रॉब्लम आ रही है, स्ट्रक्चरली क्या चैलेंजेस आ रहे हैं, जिसकी वजह से हमारी जो संस्थाएं हैं जो IPPF की फेडरेशन बनाती हैं, वो चैंपियन नहीं कर पाती सेक्सुअल रिप्रोडक्टिव हेल्थ के बारे में। तो हमने इस पर्टिकुलर असेसमेंट के लिए क्वालिटेटिव रिसर्च का मेथड करा, जहाँ पे हमने MA के स्टाफ और सर्विस प्रोवाइडर से बात करी, साथ ही साथ हमने कम्युनिटी के साथ बात करी। और यहाँ पे हमने क्या करा कि we asked them questions dependent on 30 पॉजिटिव मार्कर्स जो इंक्लूजन की बात करते हैं IPPF स्ट्रेटेजिक फ्रेमवर्क में। ये जो डायग्राम आप बाजू में देख रहे हैं, ये हमारा स्ट्रेटेजिक फ्रेमवर्क है IPPF का। अगर आप इसमें देखेंगे आउटकम 3 में हम चाहते हैं कि ये स्ट्रेटेजिक फ्रेमवर्क यही होता है कि IPPF किस तरीके से जो जिसके बारे में सोच रहा है वो इम्प्लीमेंट करेगा, राइट। तो हमारा जो 3rd आउटकम है उसमें हम चाहते हैं कि राइट्स बेस्ड सर्विसेज मिले लोगों को, ताकि सेफ अबॉर्शन हो सके और HIV मिले। तो यही फ्रेमवर्क के चलते चलते ये हमारी मैनेजमेंट मानती है, हमारी फेडरेशन मानती है। इसी के चलते चलते हमने कुछ मार्कर्स बनाए थे कि अगर ये करना है तो क्या होगा, और ये 30 पॉजिटिव मार्कर्स थे। और मेनली अगर मैं आपको ऊपर से बताऊं तो ये पॉजिटिव मार्कर्स 4 चीजों के बारे में। सबसे पहली बात है कि क्या आप इन कम्युनिटीज के हकों के लिए किसी भी तरीके से लड़ रहे हैं, वो चाहे हो गया कि आपने कोई पॉलिसी के ऊपर बात की या इनके इश्यूज के बारे में पब्लिकली बात की। दूसरा है इंगेजिंग कम्युनिटीज, क्या आप कम्युनिटीज के साथ काम कर रहे हैं इस वक्त, और क्या लोग आपके अंदर आपके प्रोग्राम्स के अंदर आते हैं। जब आप जब आप अपना प्रोग्राम बनाते हैं CSC के बारे में, क्या आप सेक्सुअल डाइवर्सिटी के बारे में बात कर रहे हैं। तीसरी चीज हम ढूंढ रहे थे कि क्या वाज सर्विंग पीपल। इसमें हम देख रहे थे कि फिलहाल हमारा जो मेंबर एसोसिएशन है वो क्या क्या सर्विसेज कम्युनिटी को दे रहा है, क्या वो HIV रिलेटेड सर्विसेज सब लोग दे रहे हैं, क्या जेंडर आइडेंटिटी सर्विस दे रहे हैं, और जब ये सर्विस दी जा रही है क्या उनका लैंग्वेज वाकई इस तरीके का है जो समावेशन में विश्वास रखता है या उनको इंसानों की तरह देखता है, राइट। और चौथा है यूनाइट एंड परफॉर्म, कि एक हो गया कि आप इनके साथ काम कर रहे हैं, इनके राइट्स कर रहे हैं, बट चौथा है कि आप वाकई उनके साथ, वो हमारे फेडरेशन का पार्ट है और हम एक साथ जुड़कर अपनी रिक्रूटमेंट पॉलिसीज या अपने वॉलंटियरशिप प्रोग्राम्स के थ्रू मिलजुल कर ये आउटकम अचीव कर रहे हैं कि नहीं। सो ये 4 चीजें थी। आगे चलते हैं, नेक्स्ट स्लाइड। राइट, हमने क्यों किया? लाइक आई मेंशन्ड, वी वांटेड टू फिगर आउट द चैलेंजेस, वी वांटेड टू फिगर आउट की what is the limitation in our capacity so that we can build it later, and thirdly we wanted to know अब क्या अप्रोच है जो वाकई हमें कम्युनिटी बताती है, क्योंकि ये जो प्रॉब्लम का सोल्यूशन है उसका हल तो कम्युनिटी से ही निकलेगा। दोनों को मिलजुल के बात करेंगे उसी तरीके से निकलेगा। आगे नेक्स्ट स्लाइड। सो इसमें हमने ये करा कि वी डिड अ क्वालिटेटिव मेथड और हमने पर्पसिव सैम्पलिंग करी, यानी कि हमने उन लोगों को चुना जो इस इशू के बारे में जानते हैं या किसी तरीके का उन्होंने काम किया है। तो 3 लेवल पे हमने इंटरव्यूज किए। पहला जो इंटरव्यू था, हमने जो हमारे जो मेंबर एसोसिएशन है उनकी जो सीनियर मैनेजमेंट टीम है उनके साथ हमने बात करी। दूसरा, जो सर्विस प्रोवाइड कर रहे हैं हमारे मेंबर एसोसिएशन में, उन लोगों से बात की जो इन कम्युनिटीज के साथ सर्विस प्रोवाइड कर रहे हैं। और तीसरा, खुद कम्युनिटीज से बात की। तो टोटली हमने 23 इंटरव्यूज लिए थे और जो कम्युनिटीज के साथ फोकस ग्रुप डिस्कशंस हुई या की इन्फॉर्मेंट इंटरव्यूज हुई, इसमें कुछ 22 लोग इन्वॉल्व थे। नेक्स्ट। तो हमारी जो 9 कंट्रीज थी ये थी, जैसा कि मैंने पहले भी बताया, ईरान, अफगानिस्तान, पाकिस्तान, इंडिया, नेपाल, भूटान, बांग्लादेश, श्रीलंका और मालदीव। तो जब हम ये कर रहे थे तो चैलेंजेस ये आए कि एक तो था कि 9 की 9 कंट्री में सीनियर मैनेजमेंट टीम ने पार्टिसिपेट करा, लेकिन जब सर्विस प्रोवाइडर की बात आई तो सिर्फ 7 MA ये कर पा रहे थे। ये इसलिए भी था कि सर्विस प्रोविजन कुछ कंट्रीज में अलाउड नहीं है इन कम्युनिटीज के साथ काम करना। सो हमें दिखा कि सर्विस जो हमारे MA से प्रोवाइड कर रही है वहाँ पे अफगानिस्तान और पाकिस्तान इसमें पार्टिसिपेट नहीं कर पाए, और जो पार्टिसिपेट भी कर रहे थे वो सिर्फ श्रीलंका या इंडिया में थे जो ओपनली गे मेन थे, जो सर्विस प्रोवाइडर्स भी थे। अलावा इसके जो हमने एक फोकस ग्रुप डिस्कशन करने को कहा था हर MA को, लेकिन सिर्फ इंडिया, श्रीलंका और बांग्लादेश ये फोकस ग्रुप डिस्कशन मैनेज कर पाए। ईरान और अफगानिस्तान और मालदीव्स में ये नहीं हो पाया क्योंकि अभी भी वहाँ का जो लीगल और सोशल इन्वायरमेंट है, अभी भी वहाँ पे बिकॉज ऑफ दीज काइंड ऑफ लीगल रिस्ट्रिक्शंस एक स्ट्रॉन्ग कनेक्शन नेटवर्क्स नहीं है विच इज सेफ टू डू दिस काइंड ऑफ एक्टिविटी। पाकिस्तान, नेपाल और भूटान में इवन दो लीगल एनवायरनमेंट फेवरेबल है इस वक्त, ट्रांसजेंडर आइडेंटिटी की लीगल रिकग्निशन है पाकिस्तान में, फिर भी हम कम्युनिटी ग्रुप्स के साथ लाइक एज अ ग्रुप जो संगठन है उनके पास नहीं पहुंच पाए। तो वहां पे पाकिस्तान में हमने की इन्फॉर्मेंट इंटरव्यूज किए। नेक्स्ट स्लाइड। तो दीज आर द थिंग्स जो मोटा मोटा जो कम्युनिटी से बात करके और प्रोग्राम्स एक साथ बात करके निकल आई, जो इम्पोर्टेंट है हमारे लिए समझना कि सबसे पहली चीज ये थी कि ये खुलकर आ रहा था दैट कम्युनिटी वाज सेइंग कि हम CSE प्रोग्राम चला रहे हैं, लेकिन इसमें देयर नीड्स टू बी मोर, देयर नीड्स टू बी ईदर इज कम्प्लीटली मिसिंग या फिर जो इंफॉर्मेशन है वो लोगों के बारे में होनी चाहिए, खास करके डाइवर्सिटी ऑफ क्वेयर पीपल के बारे में। कभी कभी एंड खास करके पहले प्रेजेंटेशन में भी आप देखेंगे जब हम बात करते हैं हम खाली गे या ट्रांसजेंडर वुमेन की बात कर रहे हैं, लेकिन लेस्बियन औरतें हैं, बायसेक्सुअल औरतें हैं, ट्रांसमेन हैं, और भी बहुत सारी नई नई आइडेंटिटीज आ रही हैं। तो ये जो डाइवर्सिटी है इसके बारे में बात करना है। दूसरी बात यह है कि जब हम सेक्सुअलिटी एजुकेशन के बारे में बात कर रहे हैं हम बात करके छोड़ देते हैं लेकिन कि हाँ स्टिग्मा होता है, डिस्क्रिमिनेशन होता है, लेकिन जब मैं एज अ क्वेयर पर्सन ये सुन रहा हूँ मुझे या सुन रही हूँ, मैं चाहती हूँ कि आप मुझे ये भी समझाएं कि मैं अपने घर में जो मेरा स्टिग्मा हो रहा है, जो मेरे साथ भेदभाव हो रहा है कम्युनिटीज में, इसको मैं हैंडल एक्चुअली कैसे करूँ। और खास करके ये एक बहुत बड़ी नीड आ रही है जो यूथ में आ रही है क्योंकि वो लोग काफी सारा बुलिंग खास करके अपने स्कूल्स में उनको फेस हो रहा है। दूसरी बात है कि एक अप्रोच जो है उसमें आपको इंटरसेक्शनैलिटी देखना बहुत जरूरी है, राइट? कि सिर्फ एक गे इंसान जो कम्युनिटी के स्पेस में आ रहा है, जो एक कॉर्पोरेट से है, और एक गे इंसान जो उस तरीके के कॉर्पोरेट से नहीं बिलोंग करता, उस तरह की कमाई नहीं है, उनके नीड्स और उनके साथ जो इश्यूज होंगे वो बहुत बहुत अलग होंगे। अगर लैंग्वेज का एक्सेस नहीं है तो हम जो मटेरियल बना रहे हैं वो उनके पास पहुंचेगा नहीं। तो जैसे फॉर एग्जांपल सर्टेन कंट्रीज लाइक से श्रीलंका, they didn't have language enough access to material which was say in Tamil in the way or in the Sri Lankan language. तीसरी बात है कि जब कुछ कंट्रीज में क्योंकि लीगल और सोशल एनवायरनमेंट ही नहीं है, तो हम अपने खुद के स्टाफ को भी ट्रेन नहीं कर पा रहे हैं, या स्टाफ ट्रेन इतनी ओपनली नहीं हो सकती अबाउट दिस इशू व्हिच इज सेफ. Another big point, right? This is the fourth point, right? And this is the important one, I feel like, for HIV programs to sort of understand. A lot of times, the community is seen as a project model. हम उनको या तो देखते हैं एज अ बेनिफिशियरी या एक विक्टिम की तरह देखते हैं, ना कि हम उनको इस तरीके से देखें कि ये इक्वल राइट्स एंड डिग्निटी है. एंड इक्वल राइट्स एंड डिग्निटी में देखेंगे तब जब हमारा नजरिया बदलेगा, तब वो आप उनके साथ किस तरीके से वॉलंटियर कर सकते हैं, वो नजरिया बदलेगा, राइट? Other thing is that what was a important event was that visibility events में opportunity मिली लोगों को खुल के आने में, और ये movements को help करा. दूसरी बात है, अगर आप collectives बनाने में support करते हैं, ये overall programs को help करता है. और health concern में खुलकर आ रहा था कि they need a private space which is dedicated to them, and also something like a health corner, and also there needs to be a particular attention to their mental health. Also when we were talking about say family planning associations, एक impression था कि ये सिर्फ औरतें और बच्चों के लिए है. ये across 9 countries में आ रहा था, और ये था कि जो gender identity services हैं वो community मांग रही थी, और बहुत बार ये connection नहीं बना रही थी HIV programs की. अगर मैं transition नहीं कर सकता, मैं औरत हूँ और मुझे transition करना है, I want to be a man, I want to take hormone therapy, अगर मैं ट्रांजिशन नहीं कर पाऊंगी मेरे शरीर के वजह से और मेरे पहनावे और या मेरे रियलिटी की वजह से, मेरे ऊपर सेक्सुअल हार्म हो सकता है, और दैट सेक्सुअल हार्म कैन लीड टू द सेक्सुअल वायलेंस इज व्हाट विल लीड टू infection or diseases, right? Because I am at the risk of either familial violence like corrective rape that has happened, and generally in public spaces I am somebody who is at risk of violence. बट ये कम्युनिटी इतनी हिडन है और कोई इस पे काम नहीं कर रहा है, उसकी वजह से ये जो पर्टिकुलर पॉइंट्स है, इस तरीके की पॉइंट्स खुल के नहीं आ रही हैं. दूसरी बात है कि जैसे हम चाहते हैं कि वॉलंटियर्स क्या करें, बट एक तरीके से अगर जैसे मैंने पहले आपको पॉइंट बताया कि अगर आप उनकी डिग्निटी में या उनके वाकई बिलीव करते हैं कि दीज आर एम्पावर्ड, तो जिस तरीके से वो वॉलंटियर करेंगे वो अलग तरीके से खुलकर आएगा. फाइनल स्लाइड हरजोत. राइट. सो नेक्स्ट स्टेप्स हमारे ये हैं कि हम अपने HIV प्रोग्राम्स में किस तरीके से इनको इंक्लूड करना है वो देखेंगे. एक हम स्पेसिफिक रिकमेंडेशंस इसके बाद लेके आए हैं हर MA के लिए कि आपको एक्चुअली क्या क्या करना चाहिए. और हम चाहते हैं कि ये जो सोशल लीगल सिचुएशन है डिफरेंट कंट्रीज में, जो हमारी सर्विसेज को बेहतर करने में प्रिवेंट कर रही है, उस पर काम करें. नेक्स्ट. थैंक यू.
Thank you so much, Sonal, and wonderful presentation. And now I request Dr. Rita, if you have some remarks.
Thank you, Sonal. I think we saw your recommendation also. Would you like to elaborate a bit on, how do you look at, including the SOGIESC in our programming, So
Yes.
Yeah.
So first of all, Rita, what is coming up across from the situational assessment is definitely the capacity of our staff and volunteers, and something that was coming up in the presentations as well, that what does inclusion really look like? I think a lot of times, I'll give you a simple example, right? Our programs, we call transgender persons and queer people like PG, MSM, okay, instead of people. If I address you as heterosexual agi, and that's all I saw you as, if I reduce you as that, you're not seeing the wholesome picture of what is the kind of gender bias you face as a woman. What does your class bring up? What is your social status or your marital status? What kind of discrimination it brings up? So it's important to look at inclusion differently, and for bringing that lens, you have to train staff and volunteers on inclusion. Secondly, when we are doing recruitment, at that stage itself, this gender lens has to come so that we actually hire people from the community who can lead this. Thirdly, data is so important because of the research, which will come in. Fourthly, gender identity services is very, very important. So is SGBV services, because I'm not just a homosexual, right? I'm a gay person who is in this social legal situation which is not supportive. I'm at the receiving end of violence. I'm at the receiving end of all of these things. If you will not handle it, you can never take care of my health and you cannot build trust. So, you know, SGBV and gender identity services and SRH, which are specific for diverse SOGSE, need to be there. And you need to engage queer women and trans men in the programs right now. You know, at this point, I often want to say, like, sometimes as a queer person myself, Rita, I feel that, you know, it is sometimes forgotten, especially by the, MSM transgender gay men movement, that initially when the epidemic hit, nobody was standing next to MSM or, gay people to support them. The governments were very negative. It was lesbian women and bisexual women who were the nurses who helped these communities. And आगे चल के भी अगर ऐसी situation आती है जहाँ पे कोई ऐसा disease आता है, it is really these women which will stand you, and these allyships and the support should not be forgotten in the long run, and we should not be holding these communities back, and we should not be dividing the community like that. Other than that, meaningfully engaging people in program design at every level, you have to include people so that, you know, one, of course, design में आपको help करेंगे, second, delivery में करेंगे, thirdly, आपको reflection में support करेंगे, और learning में करेंगे. तो ये मेरे key recommendations है, Rita. I hope they make sense.
Thank you, Sonal. I know that program is listening carefully. I think we need more voices when we do, and we know, like, you know, program as it's so inclusive. We have do believe in taking communities all along, but I think we need more voices from these group, and which has to go more in, go beyond, like, and talking about diverse sexual orientation. I think we need more voices. Sonal,
thank you, Rita, for
more power
giving
to you.
me the, thank you for the platform for, you know, amplifying the voice. So I'm very grateful.
So big shout out to Sonal Gyani for raising such a important and meaningful recommendations, and we hope the program is listening. So over to Harjot for introducing the next panelist.
Yes. Thank you so much, Dr. Rita. And I feel so proud to introduce and welcome Prathmesh. Prathmesh एक young leader है from Pune, Maharashtra. Prathmesh has been advocating for health and human rights of young people living with HIV. He has been striving that the sexual reproductive health rights of young people are considered. We have inclusive programs. We design by not for them but by them. Programs should be designed. So Prathmesh, over to you, and please आप बताएं आप हमें क्या बताना चाहते हैं आज. And seriously, I cannot be more proud of you. Please.
Thank you so much, Harshut, ma'am. I'm feel lucky, like कि मुझे आज मौका मिला है इतने बड़े पैनल के साथ बात करने का. मेरी आवाज आ रही है?
बिल्कुल क्लियर आ रही है.
Okay, so मैं प्रथमेश हूँ. मैं पुणे से बिलोंग करता हूँ, and I was born with HIV. And मैं एक अनफॉर्चुनेटली फॉर्चुनेट हूँ कि मुझे HIV है और जन्म से. क्यों अनफॉर्चुनेटली फॉर्चुनेट बोल रहा हूँ मैं? क्योंकि बहुत सारे लोग हैं मेरे जैसे दूसरे जिनको ये सारी इंफॉर्मेशन जो जेंडर इक्वालिटी है, ओरिएंटेशन, जो डाइवर्सिटी, ये बहुत बड़ा टॉपिक पता नहीं है. और ये जो क्वालिटी ऑफ लाइफ, मुझे अभी जो इंफॉर्मेशन पता है कि ये सब चीज़ें हैं, आई फील लकी अबाउट कि मैं एक कनेक्टेड था कि कुछ ऑर्गेनाइजेशन, कुछ नेटवर्क से कनेक्टेड था कि मुझे HIV है, इसलिए मैं कनेक्टेड था और मुझे ये सब इंफॉर्मेशन जो है, ये सब जो एक्सपोजर है मिल रहा है. एंड आई फील वेरी फॉर्चुनेट बिकॉज ऑफ दैट. एंड टुडे मैं ये बात करने जा रहा हूँ. मुझे ये बात करनी है कि जो कॉम्प्रिहेंसिव सेक्सुअलिटी एजुकेशन जो था, जो हमें मैं NMP प्लस से जुड़ा था और उधर FPA जो था उन्होंने कोऑर्डिनेट करके हमारा एक प्रोग्राम लिया था. 90 लोगों का एक ऐसा प्रोग्राम था. उसमें जब हमको पूछा गया कि आपको कितने लोगों को पता है कि सेक्सुअलिटी और ये जो सारी चीज़ें हैं, 90 में से कुछ 5-6 लोग होंगे जिनको पता था. जब मैंने पूछा दीदी और भैया को कि आप कहाँ पर सिखाते हो, कहाँ पर आप सेशंस लेते हो, तो उन्होंने बोला कि कॉलेज में, स्कूल्स में, तो हम भी तो कॉलेज में और स्कूल्स में जाते थे, पर वो कहाँ पर कनेक्शन नहीं बैठ रहा था कुछ चीज़ों के कारण। सो दैट वाज द थिंग कि मुझे लगा कि 12,000-14,000 लोगों को ये सिखा रहे हैं, पर हम HIV के साथ जी रहे हैं, बट स्टिल वी आर नॉट गेटिंग इट, स्टिल वी हैव सम कम्युनिकेशन इश्यूज। दैट्स व्हाई आई फील लकी कि मैं कनेक्शंस नेटवर्क्स के साथ जुड़ा था, और मेरे जैसे बहुत सारे लोग हैं जो नेटवर्क्स के साथ नहीं जुड़े हैं, अभी भी जुड़ रहे हैं, या फिर FPA जो है उसके साथ नहीं जुड़े हुए। क्या था ये सारा जो एजुकेशन का प्रोग्राम? इट वाज अबाउट कि जेंडर इक्वालिटी, कि सिस्टमैटिकली कैसे हमारे जो वल्नरेबल जेंडर्स है उन पे कैसे वायलेंस होता है। जैसे लेट्स से कि एक महिला है, हमारे गांव में देखते हैं हम लोग कि खाना पहले बूढ़े लोग खाएंगे, फिर बच्चे खाएंगे, फिर मर्द खाएगा, एंड देन द फीमेल विल ईट वट एवर इट्स लेफ्ट। सो ये जो सिस्टमैटिकली होता है, लेट मी गिव एग्जांपल कि फैमिली प्लानिंग जो इम्पोर्टेंट इशू है हमारी बूमिंग पॉपुलेशन को कंट्रोल करने के लिए, एक एग्जांपल है कि 0.4% जो है मेन स्टेरलाइजेशन, महाराष्ट्र का डेटा है, 0.4% मेल्स ने स्टेरलाइज किया है खुद को, और 49% फीमेल्स है। दैट शोज कि हमारे जो ये पेट्रियार्कल सोसाइटी है वो सिस्टमैटिकली कैसे अलग अलग कर रही है कि फीमेल अलग है और मेल अलग है। मैं मर्द हूँ तो मैं स्टेरलाइज कैसे करूँ, मैं क्यों करूँ? जब मैं ये इन सारी चीज़ों से जुड़ा था, उससे पहले मैं हंसता था कि यार लड़कियां है, उनका काम है वैसे करने का, इट्स जस्ट देयर ड्यूटी, एंड हम मेल्स है, हमारे पास कुछ और है, हमारा प्रिविलेज है। सो ये जो एक पर्सपेक्टिव होता है कि दिस इज अबाउट मेल एंड फीमेल, ये पर्सपेक्टिव बदल जाता है ये सारी इंफॉर्मेशन, ये सारी एजुकेशन से, और वक्त लगता है। एक बार में होगा, फिर दूसरी बार दूसरा सेशन, so it takes time, it takes 4 or 5 times to learn about these things. It is very difficult. I was from government school, and we used to laugh at gay people. Like we had only 3 or 4 names, Chakka, Hijra और मामू। हम लोग हंसते थे कि यार ये कैसे है। बट नाउ आई फील बैड अबाउट माई पास्ट, कि मैं क्यों हंसता था, मैंने रोका क्यों नहीं मेरे दोस्तों को कि ये गलत है या फिर ये सही नहीं है। नाउ वी फील एम्पैथेटिक अबाउट देम। इट्स नॉट अबाउट कि बुरा हुआ उनके साथ, या फिर इट्स नॉट अबाउट एंगर कि क्यों है ऐसा। इट्स अबाउट एम्पैथी कि उनको कैसा फील हो रहा होगा, उनको अंदर से कैसा लग रहा होगा जब हम लोग ऐसे चिढ़ाते हैं, हम जब बुली करते हैं। इट्स अबाउट दैट कि ये जो इंफॉर्मेशन है वो अवेलेबल नहीं होने के कारण है। वैसे ही और एक टॉपिक जैसे है कि हमारी एज में जो 16 से 14, 15, 16 इस एज में अट्रैक्शन होता है, अफेक्शन होता है, बहुत सारी चीजें होती है। मेरी आवाज बदल गई, दाढ़ी आ गई, मुझे दाढ़ी पसंद है। सो इट्स अ पीरियड ऑफ चेंज, राइट? उस टाइम पे बहुत सारे क्वेश्चंस होते हैं, और जब हमको क्वेश्चंस के आंसर, किधर जाए हम लोग, हॉस्पिटल में जाएंगे तो कॉन्डम दिखेगा, और हम लोग हंसते थे कि कॉन्डम लगाया है। और जब हमने हमारे पेरेंट्स को नहीं पूछ सकते हम लोग, इट्स नॉट पॉसिबल टू आस्क अबाउट दीज थिंग्स। मैं नेटफ्लिक्स पे सीरीज वगैरह में पायरेटेड करके ब्लैक से डाउनलोड करता हूँ और देखता हूँ, तो वो कितनी कम्युनिकेशन उनका अच्छा है कि पेरेंट्स के साथ बात करते हैं, मेरा गर्लफ्रेंड है और मेरा पीरियड शुरू हुआ। बट हमारे पेरेंट्स जो है वो अपने अपने ही चीज़ों में बिजी है, और वो नहीं कर सकते। इट्स तो ये जो लोग हैं, उनको कौन मतलब ये इंफॉर्मेशन देगा, या सही सेक्सुअल एजुकेशन देगा, जो एक पर्सपेक्टिव के लिए, जो इंसान की बिल्डिंग होती है, जो एजुकेशन का जो एक पार्ट होता है कि आप पर्सपेक्टिव बिल्डिंग, आपको सोचने का तरीका बदल देना एजुकेशन का पार्ट है, और एजुकेशन सबका राइट है। स्टिल वी आर नॉट गेटिंग दिस एजुकेशन एवरीवेयर। which I feel कि बहुत important है. और एक दो points है कि एक और चीज हुई. I was it's my example only कि मैं एक लड़की से attracted था 8th standard में. So I was like कि मैं कैसे बताऊं, डर था कि rejection, मतलब अगर उसने ना बोला तो क्या होगा, मतलब उसको हैंडल कैसे करा जाए, या फिर मतलब मैं खुद को कैसे संभालूं, या फिर उसको कैसे इंफॉर्मेशन बताऊं कि यार ये ऐसा है और ऐसा ऐसा है. मतलब इसकी इंफॉर्मेशन, मतलब ये इतना बुरा नहीं है कि जितना आप सोसाइटी बना रहे हो कि ये गंदी चीज है, ये सेक्सुअल वर्कर्स के पास ही HIV आता है, या फिर जो गे है, या फिर जो LGBT कम्युनिटी है उनके पास ही HIV आता है. ये जो एक पर्सपेक्टिव बना है सोसाइटी में कि यार ये गलत, HIV गलत है. मतलब it's not about good people, it's not about you will never get HIV if you are good. ये जो है, इसके कारण एक फेयर होता है कि यार मैं कैसे बताऊं उनको, जो मेरा पार्टनर है. और ये भी है कि अगर मेरा कनेक्शन हो गया, कम्युनिकेशन हो गया, वो अगर उनको मुझसे कम्युनिकेशन करना है, सो उसके बाद एक जो रिस्पॉन्सिबिलिटी होती है कि कॉन्ट्रासेप्टिव्स, प्रेगनेंसी प्रिवेंशन, ये जो सारी चीजें हैं, इसमें डीप का नॉलेज मुझे लगता है बहुत सारे लोगों को अभी तक नहीं है. सो उसकी जो गहराइयां हैं कि सिर्फ कॉन्डम लोगों को पता है, वो भी लोगों को इतना पता है कि वो जो स्पर्म्स का कनेक्शन है वो रोकने के लिए होता है, बाकी उनको कुछ नहीं, बाकी उनको स्टेरिलाइजेशन नहीं पता, उनको कॉन्ट्रासेप्टिव दूसरी चीजें जो है, वो एंटी प्रेगनेंसी पिल्स जो है, उसके बारे में इतनी ज्यादा जानकारी नहीं है. मैं भी अभी सीख रहा हूँ, मेरे लिए भी ये सारे नए टॉपिक्स है. इट्स एंड वी स्टिल लर्निंग, वी ऑल आर स्टिल लर्निंग. हम लोग फिर और सीख रहे हैं और जान रहे हैं इन चीजों के बारे में. सो आई फील कि ये सारी चीजें इम्पोर्टेंट है सबके लिए, और ये सबके लिए अवेलेबल होनी चाहिए. और एक इम्पोर्टेंट चीज है कि इम्प्लीमेंटेशन. आई वॉज लकी कि मैं NMP और FA के साथ जुड़ा था, बट क्या होता है, अगर किसी ने कुछ सेशन लिया तो कुछ लोग बोलेंगे कि यार मैं जाऊं कैसे वहां पर, हाउ विल आई गो देयर, मेरे पैसे जाएंगे, मैं दूर रहता हूँ, मैं दौड़ में रहता हूँ, और मुझे स्वारगेट आना है, तो हाउ विल आई गो देयर. ये सारी जो इम्प्लीमेंटेशन के पार्ट में जो चीजें है, उसमें मतलब हमको पूछना चाहिए कि हमको क्या चाहिए, मतलब व्हाट डू वी वांट. मतलब हमसे जानना चाहिए कि क्यों नहीं लोग आ रहे, क्यों नहीं लोग मतलब उनको जानना है, बट स्टिल दे आर नॉट गेटिंग देयर वेयर दे कैन लर्न अबाउट दीज थिंग्स. सो एक्सेसिबिलिटी का बहुत बड़ा प्रॉब्लम है, वो थोड़ा सा सॉल्व होना चाहिए. एंड इफ यू ऑल आर थिंकिंग अबाउट दिस एजुकेशन, प्लीज हमसे और जो एक्सपर्ट लोग हैं, जो दीदी भैया है, उनसे थोड़ा सा इनपुट्स लेना. और दैट्स इट. आई एम स्टिल लकी, और मैं लकी रहना चाहता हूँ. थैंक यू सो मच रीता मैम एंड ज्योत मैम. थैंक यू सो मच.
थैंक यू सो मच प्रथमेश. एंड मतलब आपने इतनी खुल के बात की, आपने अपना सारी बातें हमें इतनी खुल के बताई. एंड एट टाइम्स आई फील दैट एज प्रोग्राम इम्प्लीमेंटर्स, एज प्रोग्राम डिजाइनर्स, पॉलिसी मेकर्स, वी फेल यंग पीपल. लेकिन आपने जो इतनी लंबी लिस्ट दी है, एंड लाइक थैंक यू सो मच. हम इसके ऊपर काम करेंगे, हम सब काम करेंगे. एंड इसी के साथ मैं डॉक्टर रीता से रिक्वेस्ट करती हूँ कि आप प्लीज कुछ कहना चाहते हैं.
तो प्रथमेश, पहली बात तो बहुत अच्छा लगा आपकी बातें सुन के. आपने जिस तरीके से ये हाईलाइट किया कि कैसे समाज की पारिवारिक दायरे और जेंडर के दायरे में बंधकर जो युवा लोग हैं, वो अपनी जो सेक्सुअल या अफेक्शन की, जैसे आपने बात की, उसके झिझक होती है, और वो कुछ भी नहीं पाते और उनको पता नहीं कहाँ से सर्विसेज ले. तो आपके अनुसार एक यंग पर्सन के लिए होलिस्टिक केयर की अगर हम बात करते हैं, तो वो कैसा होना चाहिए? क्या आप कैसे देखते हैं होलिस्टिक केयर?
होलिस्टिक केयर मैम, वो शुरू से होना चाहिए. मतलब जब क्वेश्चंस आना शुरू होते हैं मैं जब 10-12 साल का था तब क्वेश्चंस आने शुरू हो गए कि HIV क्यों हुआ मुझे, क्योंकि अगर आप दोस्तों से पूछोगे तो नेगेटिविटी आती है बहुत ज्यादा कि ये बुरा है, ये गलत है, और मतलब हम नहीं बताते कि यार मुझे है, बट वो हंसते हैं कि HIV है या फिर नहीं है ऐसे। तो ये इंफॉर्मेशन अवेलेबिलिटी और एक्सेसिबिलिटी होनी चाहिए शुरू से ही, जब 10-12 साल के होते हैं, जब क्वेश्चंस आने शुरू होते हैं कि मुझे क्यों है, इस सब का क्या मतलब है। और अगर इसके रिलेटेड चीजें अगर पता चले कि कॉन्डम यूज करना, कॉन्ट्रासेप्टिव, मतलब जो रिस्पॉन्सिबिलिटी की बात आती है बाद में की, और मतलब अगर मैं कांटेक्ट में आ गया किसी फीमेल के साथ तो उसके बाद क्या करा जाए, इसकी इंफॉर्मेशन, या फिर जो मेंटल स्ट्रेस होता है कि यार अगर रिजेक्शन हो गया या फिर अगर किसी दोस्त ने नहीं बोला, नहीं बातें करी, तो वो हैंडल कैसे करा जाए, इसका थोड़ा सा एक गाइडेंस होना चाहिए, ये मुझे फील होता है अंदर से शुरू से ही। मतलब जब हमको क्वेश्चंस बच्चे क्यूरियस होते हैं, पर हमारा स्कूल जो है वो क्यूरियोसिटी पूरा निकाल देता है। बच्चे क्यूरियोसिटी नहीं, मतलब हम जब बड़े बड़े होते हैं वो क्यूरियोसिटी उतनी नहीं होती है, बट जो छोटे होते हैं, जब पहले पहले जानने लगते हैं, तब क्वेश्चंस के आंसर वहां पर होने चाहिए, आई फील।
Thank you, Prathmesh.
Thank you.
Yes, Dr. Rita, you want to give some concluding remarks?
So I will just conclude. I think this is a great session, and I really feel privileged to be a part of hosting this session. Thank you, everyone. Each one of them, highlighted the issues of underserved population, and we know, like, the need is for comprehensive HIV SRH services, and this will actually improve the access of services for this underserved population, be it of young people living with HIV, be of lesbian, bisexual, or transgender group. And Nisha also brought about gender identities, the need of looking beyond those what we have been looking at the program. How can we include them in the services? And if we do look at this individual persons and look at their sexual reproductive health needs, also I think it will bring in more focus into person-centric care. It'll also address the issue of stigma and discrimination. I think each of them highlighted how the stigma and discrimination is still a major force even after so many years. And each population is how they're struggling with it. And I feel like, along with bringing more programmatic efficiencies, it will also address these access issues. And very insightful presentation by each of them. And I'm thankful that clear recommendations were given under each presentation. And we are very hopeful that learning from this session will be will go in a way, and some of the recommendation can be seen in coming years in forming more inclusive policies for all this diverse group. So thank you all the panelists and Harjot for this great session, and all my audience for listening into this. And over to you, T2, for closing this.
Thank you. I think, yeah, Dr. Harjot.
Thank you so much. Yeah.
Yeah, Dr. Harjot, you want to say something?
No, I was just saying thank you. Thank you so much, Chandigarh SAGS. It's always a homecoming for me.
Thank you, Dr. Rita, and thank you, Dr. Harjot. Thank you all the speakers, Ms. Nisha, Ms. Amita, Ms. Sonal, and Ms. Shri Chaudhary. Thank you very, very much for joining us today here. Thank you. Moving on to our next session, Diagnostics and Management of HIV. It's an honor to invite Dr. Ishwar Gilada, consultant in HIV STD and President AIDS Society of India, ASI. We welcome you, sir. Sir, are you there?
Sir is busy right now.
Sir is busy. Okay.
Yeah, this is Dr. Kumar Sami. Hi.
Okay. Hello.
Hi.
Hi, sir. Welcome.
Yeah. Ishwar might join. Dr. Gilada might join us. He's been traveling. So
okay.
We have the other co-chair, Dr. Mathai, who's our senior vice president here.
Okay.
So we can go session.
Yeah, Dr.
We can.
Dr. Dilip Mathai, I welcome you. He's the Vice President of ASI, AIDS Society of India. We welcome you, sir.
Yes, morning. Good morning. Yeah.
Good morning. How are you doing, sir?
I'm fine, thank you.
And thank you very much, because the ASI has been associated with us since, I think, long now, and it's the 11th conference together. And it's really, Chandigarh SACS is really grateful to ASI for joining every time with us for useful sessions. And handing over this session to you now.
Yes.
Thank you.
Thank you very much. And it is the privilege of ASI to participate in this wonderful congress that you have organized over the last 2 days. I was only witness to this morning's presentation. I really enjoyed the preceding ones. Now for the session number 9, which is diagnosis and management of HIV, we have 3 panelists who will serve as speakers. Now the topics that have been given to them, one is the newer technologies for diagnosis and management of HIV. For this, we have Dr. Prapti Gilada. She's there. I'm not able to see her. Are you there, Prapti? Yes.
Yes, I'm there. Yes.
Yeah. Thank you.
Can
Good
hear me?
morning. Yeah, I can hear you. Good morning, Prapti.
Good morning.
Yeah.
Good morning, everyone.
And she's a consulting microbiologist at a hospital in Mumbai. She's been involved with HIV AIDS care ever since I think she graduated from this in her MD microbiology. So Dr. Prapti, you have got 20 minutes to extol the newer advances for the diagnosis and management of HIV. Okay, thank you.
Good morning, everyone. Thank you. At the outset, I would like to thank the organizers of AIDSCON for inviting me for this session. I would be covering the topic of newer technologies for diagnosis and management of HIV. In the next 15 to 20 minutes,
I think
I will be covering...
Dr. Prapti, sorry to...
So yeah, this is actually a pre-recorded version that they're showing. So I think they're playing that. Yeah.
Okay, thanks.
On what are the newer technologies for early diagnosis of HIV, for monitoring, as well as what are the other co-infections for which newer technologies are there in the market. The UNAIDS 1990 target to end HIV by 2030 talks about how 90% of the people who are HIV positive should be aware of their HIV status, of which 90% should be on HIV treatment, and 90% of those on treatment should be virally suppressed. Now, for those to be aware of their HIV status, the first and most important step here is diagnosis. And the newer diagnostic technologies here come into play, where what are the newer technologies that we can use, or what are the most sensitive methods we can use so that these 90% can be diagnosed very easily. And also another goal in this whole 90-90-90 target is to have fewer than 5 lakh infections annually, like fewer than 5 lakh new infections annually. And to achieve these reduction in new infections, it is very important that people are diagnosed, put on treatment, and virally suppressed. Because several studies have shown that around 80 to 90% of the transmission actually takes place in this period when people are unaware of their HIV status, they are not on treatment, and therefore not virally suppressed. And as we know, once the patient is virally suppressed, the transmission risk is 0. So achieving this first 90 is very important. And what are the tests that we can do? So the exposure to HIV on day 0 to about 10 to 14 days, where a RNA test detects positivity, is called the eclipse period. And no diagnostic test can actually detect HIV during this period, which is called the eclipse period. The P24 antigen tests positive around day 16, and our 4th generation test that we are using right now, commonly being used, detect the HIV status by around 28 days post exposure. Now, if the patient, and the sensitivity usually is set to be 95% with these 4th generation tests. Now, if the patient tests negative with these 4th generation tests, but has a high risk, it is always advised that a repeat test is done at 90 days, because our 90 days period, the 3 months period, is actually known to be the window period, not only for HIV, but also for other sexually transmitted diseases. And tests that detect this HIV status at about 90 days have a sensitivity of almost 99.9%. So, like I said, most of these fourth generation tests that are available, or even the third generation tests that are available for diagnosis, are point of care tests with great sensitivity and specificity. The fourth generation tests, like I said, reduce the window period. And I will just roughly scan through what do we mean by the first, second, third, and fourth generation tests. So the first and second generation tests were used earlier, and they used to detect the IgG antibodies to HIV-1. The third generation tests are tests which are used even right now, which detect IgG and IgM antibodies to HIV-1 and HIV-2. And the fourth generation tests detect the antibodies IgG, IgM to HIV-1 and 2 along with the P24 antigen, therefore reducing the window period of diagnosis. Another important test that we have to talk about when we talk about diagnosis is self-testing. And there had been concerns whether these self-test kits were really reliable as the normal kits that were used in the laboratory. And this was a study that was published in the Lancet, and it talks about how these rapid diagnostic tests used by self-testers perform just as well as other diagnostic tests which were interpreted by trained healthcare workers. And they said all this was easily achievable if the kit's quality is good. That means the sensitivity and specificity of the kit by itself is good, the product is good, and also if the instructions to the users is very clearly displayed. WHO in December 2016 actually released a policy statement where it recommends HIV self-testing. It says that if your test is reactive, then further confirmation testing should be done by a trained provider using the national testing algorithm. If the test is non-reactive, but the patient is at high risk, a retest should be done to be sure of the result. And it should not be used for those who are already on antiretroviral drugs, because it might just give you a false negative result. And it also calls for supervision for those who are young, who probably cannot read, write well. So a peer guided or an app guided HIV self-testing strategy. And also making sure that all those who are tested, and if tested positive, are linked to care. Now, what is the status of these self-test kits in around the globe? So several countries in Africa, America, and Australia have actually approved and implemented HIV self-testing. India is still under the developmental phase, and we have not approved it. So though it is being used, it is not approved by our guidelines. And there have been studies that have been done where even NACO is involved. And there was a recent study which was published, which was spoken about in the CROI 2022 by Johns Hopkins Institute, which talks about how these self-testing kits have actually helped improve, the diagnosis and linking them to care. So this is a very challenging and I think a wonderful test that is there in the market. It's just about time that our national policies actually implement it. Now, another important thing in diagnosis is early infant diagnosis, because they say that 58% of those who received their results were put on treatment, but there was always some gap, which is around 42%. They did not receive their results in time, and there was poor linkage and therefore high infant mortality. And this was mainly because the diagnostic tests that are usually involved for early infant diagnosis take about 3 days to 4 days, or sometimes even a week, depending on the facility, to actually get the result. So there's a lot of loss to follow up. Now, there are newer diagnostic technologies for early infant diagnosis, and a lot of them are point of care tests which are available in the market. Some of them are under the developmental stage, Some of them have been released in other parts of the world, but not yet available in India. But I will just scan through about 2 or 3 important ones and tests that are being used and probably will really help early infant diagnosis. The PIMA HIV 1 and 2 detect by Alere is already in the market and it gives results within 52 minutes. The Cepheid Expert HIV 1 qualitative test has been used in different other parts of the world. It's still to get its approval in India, and hopefully by this year we will also be using this kit, and this would give you the results in about 90 minutes. And the diagnostics for real world Samba HIV 1, again qualitative test, gives you result in about 120 minutes. And the TrueNat HIV, again like PIMA, gives results in about 55 minutes. So these are tests that can be used. These are point of care tests with very rapid turnaround times. So can actually give results early and can actually link the patients to care probably on the same day or the next day. And this has been, and these effects of introducing point of care early infant diagnostic tests has actually been seen, where same day results return in when these tests were used was extremely high. So in different countries, it was between 70 to 100%, and ART initiation within 60 days was almost 90% in these studies that were done in these 3 countries. So definitely early infant diagnosis with point of care tests is going to diagnose infections faster and help link to care. The next thing that we would like to talk about is what are the newer CD4 technologies. So even though we've moved to test and treat, and we are more towards doing viral load testing to look at viral suppression, CD4 tests are still done to look at immunosuppression and to look at whether if the patient is really prone to some opportunistic infections. So several technologies again are available. I will just like to highlight a few, like the Alere PIMA, again CD4 test, BD Fax Presto. So some of these tests take as little as 3 to 5 minutes, and some of them take about 20 minutes, but still these are real rapid diagnostic tests which can give you results within 15 to 20 minutes. And one of them, which I think is going to be a good test, is Omega Visitech, which is a lateral flow assay. So even though it's not going to give us the actual CD4 count, it's going to be a semi-quantitative test, but it's going to be instrument-free. So this can actually be done in any of the small centers without really needing an instrument. So you would know whether the viral load is above a particular level, so that the management can then vary from there. Next, coming to the viral load testing and how these point of care viral load testing in different parts of the world has actually improved viral suppression and retention in HIV care. And this was a study that was published in Lancet, where they have spoken about how it significantly improved viral suppression. And this was also later on spoken about in CROI in 2019, where they actually saw 14% increase in viral suppression and retention in care. So all these tests, which the newer diagnostic tests, are definitely helping us get better results and link patients to care. This was another study that was published in January 2021, where they do talk about how the result has improved linking to care, but they also have raised concerns of how the some of these gaps of linking them to care could not be met. And these systems need to be strengthened, of how once a viral load report is available, how it should be linked to the clinician, and further treatment and further management of the patient should be, like a proper process flow should be set into place. So I think these are challenges that we are facing and we will be facing, but I think with time we will learn how to get into flow and link them to care immediately. So again, there are several point of care tests that are available, and also newer tests are going to be coming into the market for viral load testing. we already know, and several of us are actually using the Gene Expert, which is a multiplex real-time PCR technology, gives us results within 90 minutes. Again, the Abbott MPIMA gives us results within 52 minutes. The MolBio TrueNat Diagnostics, again, around 1 hour of turnaround time. And Samba and EOScape is still to come in India, but definitely just trying to say that several of these tests are going to come and all of them perform really well. Like I'll just show you these studies which have studied the expert concordance with our conventional PCR technologies like Roche, Takman, and Abbott, and the bioMérieux Nucleosense have said that expert has excellent concordance, and the results were wonderful, and there was probably nothing to worry while using these point of care tests. And what is the actual advantage of using something like Expert, which also is being used in several government setups under the national program, is the range of detection is about 40 copies to 10 million copies per ml. Very easy to perform once the technician is trained, maybe say in about half an hour to 1 hour, anyone can perform this test. And the same Gene Expert equipment can be used for multiple other tests like TB, which we actually started Gene Expert for TB, and HPV, chlamydia, gonorrhea, HCV viral load, hepatitis B viral load. So the same instrument can be used for multiple tests. Another test that I think is going to be very exciting once it's released into market is monitoring of ART adherence. So even though we know we have diagnosed 90% of the patients and 90% of those have been put on treatment, we probably struggle with getting viral suppression, and to actually see whether the patient is having the drugs on time and is having the drugs regularly, I think this ART adherence monitoring is going to play a very important role. And this was a study that was done and published in 2020, in February 2020. And Abbott has provided these kits where urine levels of tenofovir are being tested on lateral flow assays. And so usually it is the liquid chromatography that was being done to test drug levels in blood and urine. But these are antibody based tests and have lower costs, and obviously because they are lateral flow assays, these can be used as point of care tests. But this is still not being released into market, probably still into the evaluation phase, and hopefully in the next few years we will have these tests available for ART adherence monitoring. The other tests that we would like to talk about is tests for detection of co-infection. One of them very important is TB. We know a lot of HIV positive patients are infected with TB, and like I said, Expert NTB ref assay has been a wonderful test to detect tuberculosis. So even though we were doing sputum smear microscopy, the sensitivity of Expert is much higher, very, very close to culture. But again, we know that TB culture is going to take very long to give results, with anywhere between 4 to 8 weeks. So, and now with Expert detection of just MTB along with ref resistance, we also have a new XDR cartridge with Gene Expert, which also gives you the resistance status of other second line drugs, including the second line injectables and fluoroquinolones. So I think this is a wonderful technology. Also, like to mention here is about the LAM test, where you do urinary detection of lipoalbuminomannan antigen in HIV positive patients. This is an antigen which is released in the urine in patients who have active tuberculosis and low CD4 counts. So again, a lateral flow assay, which is going to give you results in 20 to 25 minutes with a lower sensitivity, but still would be wonderful, because at least there will be a few of the patients that we will be able to detect by this test, by a simple urine test. Again, this test is not yet available in India, but there have been few countries that have been using TB LAM. And just like the Gene Expert, we also have the TrueNat, which is again a PCR-based technology, gives rapid results within 60 minutes. And this is basically for pulmonary samples. So these are the basically all the tests that are available for tuberculosis. And the other co-infections, so hepatitis B and hepatitis C, again, sexually transmitted. We have the rapid tests for diagnosis, and also the expert cartridges for the viral load testing of hepatitis B and hepatitis C. HPV, chlamydia, gonococci, again, can be done on the Gene Expert platform. A special mention here about cryptococcal antigen. So there are lateral flow assays that have been developed where patients who are HIV positive patients who are having a low CD4 count, this is for screening of cryptococcal meningitis. So basically just serum based tests, and you can actually detect whether the cryptococcal antigen is present, and once the lateral flow assay is positive, a further evaluation by a CSF can be done, and the patients can either be put on treatment or be put on the if the test, the CSF is not positive for cryptococcal, then probably they just have the antigen, and the treatment with fluconazole can be initiated. So another important test like HIV drug resistance, we know when we send it outside, very expensive, and obviously the results are available to the patient only in about 2 to 3 weeks, and very few laboratories are actually doing HIV drug resistance testing. Now, Panda is a very novel platform technology which was developed by Aldatu, which is going to deal with low cost and extremely sensitive diagnostic method for HIV drug resistance testing. It has already been validated for NRTIs and NNRTIs, still being validated for PI and integrase inhibitors. But again, this technology is yet not available in India, but hoping that in the next few years, all these newer technologies are actually available and will really help us to provide care to our patients. So my conclusion here is that point of care diagnostics are crucial to achieve the 90-90-90 goal, and these tests are and will need to be inexpensive to do so. We already have a lot of pharma companies that are doing well in India. We probably need a more local and national industries to work on these point of care tests, diagnostic tests, so that these tests can be provided to our people at very affordable costs and are accessible to all these low and middle income countries. The time is ticking and we will have to act fast. And that's why all these newer technologies that have been developed, all the point of care tests where your turnaround time to diagnosis is reduced, will really help us do well for patient care. Thank you so much.
Thank you. Thank you, Dr. Prapti. That was wonderful. You really walked us through from 2016 to 2022. Wonderful. And your slides talked as you walked through the slide. Very nice set of slides. It was very informative, and you capturing it from the diagnosis, an early diagnosis in infants, and then going on to the CD4, and then the viral load measurements, and then going on to co-infections and tackle the important co-infections, and then the final thing about HIV drug resistance. Wonderful, really wonderful. Now, as you have stated this, I know that we have some special time for discussions with the group later on, but before I just wanted to put this into a perspective. I did a quick mathematics and arithmetic and found that 1,400 people are infected every day in India. In the world, I know it's 7,000. Okay. But my problem in India is, how do I find out who this 1,400 are? There may be many more. So unless the patient comes to me, then I am not able to, because as you know, in a matter of a personal sexual encounter and things like that, then frequency depends on the frequency. So the precise question is, what should an ordinary, let's say, person who doesn't really want to go to a physician, and you have very rightly alluded to the saliva-based test. Would you say that for a common man, you would recommend that as a first step? Because my concern is by the time they reach treatment, it is 60 days. You have
Right.
shown it. Yeah, yeah.
Right.
Can I bring it down sooner? In TB, if you realize, it is by the time the sputum becomes positive. In other words, people travel with the symptoms of TB, and it is 56 days by the time they get onto the TB program. So what would be your recommendation? Can I recommend it as a, when I see my patients eyeball to eyeball?
So I think we can at least, initially, and probably with time, the sensitivity of the kits will improve. Like I think all of you know how we used to use our rapid tests for HIV. Earlier, the sensitivity was lower, and with time, probably over the past 15 to 20 years, we've reached a sensitivity where, it's almost 99.9%, almost 100% sensitivity. So I think right now it would be good. We can always recommend these tests. I think a lot of the youth are also aware of these tests because these tests are available online. And like, everyone, of our generation is always on social media. They know these tests are available. They've heard about them from their friends. So I think initially it would be okay. Our major challenge, like you said, is linking them to care. Whether once they've done the test, they should have those platforms where they know where they should go next if they test positive. And even if they test negative, still go in for a counseling so that, that risk mitigation or if they need a post-exposure prophylaxis, that can be provided to these patients. So I think, yeah, we can definitely recommend them. And with time, we will probably have better tests and more sensitive tests.
Yeah, that's, thank you. Thank you so much, Prapti, on that. But stay on, be alive. We'll get back to you. I just used my privilege as a chairperson to ask you this question, okay?
Yes.
Now we move on to Dr. Kumaraswamy. Who is the Secretary General of our society. I see Dr. Gilada also. He has also come out alive now. Okay, and Dr. Kumaraswamy has been educating me as well. He's one of the practicing physician who really practices his talk. And he is somebody who has got a wide experience in this field of HIV. And I'm so glad that Dr. Kumaraswamy could take his time off to be with us. Dr. Kumaraswamy, your CV is very well known, but people can read it. So I wouldn't waste too much time. So would you be kind enough to speak to us on how you manage COVID at your center, where you predominantly manage HIV? And I think you would have the best experience because HIV is well known in your center, care is well known in your center, and then access to COVID. Truly an infectious disease combination.
Sure.
Over to you.
Thank you. Thank you, Dr. Mathai, and thanks the organizers for the opportunity. So good morning, everyone. So this is going to be a recorded presentation. So I think the organizers can start my talk on HIV and COVID.
There is no audio, Karan.
Good morning, everyone. Today, I'm going to speak to you on managing COVID in people living with HIV. As we all know that the numbers of COVID changes rapidly every day. So till a day back, we have 448 million people globally being infected and with more than 6 million deaths. India being ranking number 2 with 42 million, and we lost more than 500,000 people to this deadly COVID disease. So having said this, but we also have other lower and middle income countries, especially in sub-Saharan Africa, with much lower numbers as compared to India. So that means we can't write off that they don't have infections. This is also related to testing. So we did a lot of testing in India. So we are able to find people and we are able to diagnose 42 million people. There are many regions and different parts of the world, particularly in lower and middle income countries, they do not have access to testing. Hence, they are not able to, see that many numbers to be reported in the, COVID database. When you look into those daily new cases, as we all know that we had 3 waves. We had the first wave, second deadly wave, and recently we had a Omicron wave, which is now, fading away. Also, we had seen, daily deaths over a period of last 18 months with a huge peak sometime in middle of last year in May and June with the second wave. And again, in this third wave, we saw, less mortality. But again, people were not that sick with the, third wave with the Omicron, variant. So next, few minutes, I'm going to walk you through the COVID pathogenesis and how we can aim our treatment and people who have been infected, with COVID. As we all know that this SARS-CoV-2, which causes this COVID, which has been spread through aerosols, when someone acquires it, it enters either through the pneumocytes or through the enterocytes, where there are plenty of AC2 receptor and TMCAR SSR2 receptors are present. So the spike protein of this virus, SARS-CoV-2, identify receptors and facilitate this viral entry and the pathogenesis. So there is a process of viral entry when the spike protein gets attached to this receptor, and that's a time viral host interaction happens. And the next step, there is an endozyme maturation happens. The next starts a typical viral pathogenesis starting from translation. There is a viral protease cleavage with the help of an enzyme protease. And the next step, it translates and RNA replicates with the help of an enzyme RNA-dependent polymerase. And in the next step, there is maturation happens and the packaging happens with the help of endoplasmic reticulum and Golgi apparatus and maturates. And these virions are being released and the cycle being repeats. When you have been talking about treatment, we have to follow these pathogenesis to aim our therapy to halt this viral replication and this SARS-CoV-2 disease progression. As all of us know that 80 to 80% of the people with COVID disease present very mildly, including in people living with HIV. Again, majority of the symptoms were fever, cough, and sore throat, and malaise and myalgia. Few had gastrointestinal symptoms. But one of those striking things we have seen in the wave 1, 2, as well as 3 has been taste and smell disturbances. And we also have saw that in people living with HIV when they develop COVID. And around 5 to 10% of them, when they develop a moderate or severe, they complain of shortness of breath. And when we did the simple blood examination of CBC, we were able to see lymphopenia in COVID-infected people, which we also see a lot in HIV-infected people. Hence, for this reason, HIV itself can be a cofactor for COVID disease progression because of this factor of lymphopenia. Also, when this COVID disease progresses and people who have been infected have been developing various types of pro-inflammatory cytokines, and as well as many of those inflammatory markers like D-dimer, CRP, LDH, ferritin, and interleukin-6 have been altered. Now, we have seen this alteration of these immunological markers and inflammatory markers have been seen even in active HIV disease, as well as when these HIV-infected people develop tuberculosis and other opportunistic infections. But that time we have seen minimal changes in inflammation, but in COVID, it's been massive, and because of that, this disease progresses. Majority of the people, it's typically a respiratory infection, but in a small proportion of the people, it can also produce acute respiratory distress syndrome, and which as a result, patients can develop severe hypoxia, can also lead to sepsis, septic shock, multi-organ failure, and acute kidney injuries and cardiac injuries. And what's a typical pathogenesis what we've seen in COVID and been understood from various basic science studies is the typical release of these cytokines, starting from TNF-alpha, interferon gamma, IL-6, IL-12, which we also have seen in tuberculosis as well as certain other co-infections as well as in HIV. But the amount of inflammations which are released are being minimal as compared to COVID. So these pro-inflammatory cytokine causes various organ damage, which lead to organ failure and severe and critical COVID disease. In wave 1 and wave 2, we found significant number of patients with COVID also developed severe COVID pneumonia. That's again being characterized with the clinical manifestation of shortness of breath, with dry cough. When we do a X-ray chest or a CT scan, it's been reported more like a ground glass appearance, mostly in the periphery with a rounded morphology, as shown in this CT scan. We had also seen similar ones with pneumocystis pneumonia in the past in someone with HIV, with advanced HIV disease with a low CD4. Hence, when you have been handling people with HIV and they develop a COVID, you need to be very careful to differentiate between COVID and pneumocystis when the CD4 has been very lower. Also in COVID, they can also present with a variety of extrapulmonary manifestations with the cardiac, with renal, hepatic, various neurological manifestations, and gastrointestinal disease. The typical pathology based on the autopsy studies been seen as shown by the lung tissue. Here is been these various endothelial injury, which have led to widespread thrombosis with alveolar microthrombus. So this is a typical pathogenesis of SARS-CoV-2, which causes a huge hypoxemia because of the microvascular thrombosis and hemorrhage, which have been very extensive in the alveolar and intestinal inflammation that ultimately result in COVID-19 vasculopathy, pulmonary intravascular coagulopathy, hypercoagulability, ventilation perfusion mismatch, and which leads to ARDS. Hypoxemia, because of this thrombosis, can also activate the coagulation in a cascade, leading to severe respiratory failure. There are various cofactors which are responsible and act like a typical factors for the SARS-CoV-2 disease progression from mild to moderate to severe. Based on the epidemiological studies in the last 18 months, it's been recognized that advanced age, when someone has got any comorbid conditions like COPD, cardiovascular disease, diabetes, obesity, kidney disease, and immunosuppression from any factors, including from HIV, and as well as in pregnancy, all being act like a risk factors for severe COVID. So among these, there are various studies being published on that, but there are limited data, particularly in people living with HIV when they acquire COVID. Our group and others have done various analyses on the impact of COVID-19 on people living with HIV based on the various literature published from the developed world as well as from the developing country. One such review, I'll be presenting the next few slides on what happened to HIV-infected people when they develop a COVID. So there are various studies which have been published from North America as well as from Europe on people who are living with HIV with an undetectable viral load and with a good CD4, and they found that there is no major worse outcomes with COVID when they have HIV, when they have an undetectable viral load. Patients are adhering to antiretroviral treatment and they have a good CD4. Also, there are studies done in North America as well as in Europe and UK and as well as in South Africa has shown when someone who's not adhering to antiretroviral treatment, if they are being viremic with a low CD4, there is a higher chance of worse COVID outcomes. Particularly, there is a study done in Cape Town, South Africa, have shown, as seen in this slide, there is a high risk for progression when someone who has been HIV positive, when they are being more than 50 years of age, also when they develop have multiple other comorbid conditions like diabetes and hypertension. As many of you as providers on HIV care, we all know a significant number of patients who are on our regular follow-up are now getting aged. They are becoming 50 plus. And also anything around 25 to 30% of our patients, people living with HIV, they also have one or more non-communicable diseases like diabetes, hypertension, or renal disease. All these act like a major cofactors for SARS-CoV-2 disease progressions. Hence, not just on HIV per se, but many of those other factors which our people living with HIV have, like in advanced age and as well as other comorbid conditions, can act like a disease progressions when they acquire COVID. So this is one of our very earliest studies, which been published many years back, which has shown these are the various opportunistic infections act like a cofactor of disease progression, like tuberculosis, pneumocystis, cryptococcal toxo disease, and as well as hepatitis C. So now this is time that we need to study what happens when people living with HIV, when they have an undetectable viral load, when they develop a COVID, what happens to them over a period of time. And also someone newly diagnosed HIV will still be in viremic if they develop a COVID, whether this virus act like a cofactor for HIV disease progression. In Chennai, we have set up an ongoing cohort study called COT cohort studies. Some of you have been aware of that, which we have been doing, trying to understand the impact of antiretroviral therapy in lower and middle income countries, where now we have added this new element of COVID, where people who have been diagnosed with COVID and HIV, they have been enrolled in this cohort study. So this is a report of 171 persons who are diagnosed with HIV and COVID in the last 18 months. Among them, 165% were on antiretroviral therapy, 92% of them on combination of tenofovir, lamivudine, and dolutegravir. And our preliminary analysis shows none of those antiretrovirals prevented COVID. So that means these ART, what we have been using in our patients, will not prevent the acquisition of COVID. We lost 3 persons to COVID. These are the individuals who have been viremic, very low CD4, and also they had one or more other opportunistic infection like tuberculosis, and one had cryptococcal disease. Our hospital had also managed a very large number of non-HIV COVID patients. So when we compared with the data from people who were living with HIV who had COVID versus who did not have HIV and COVID, we did not see any disease progression significantly on the rise among people with HIV as compared to non-HIV when they have a controlled viral load and good CD4. So on reviewing all this data and our own data here in Chennai, at present, there is no evidence to suggest that there is no increased risk of infection and increased severity of illness of people living with HIV. However, people living with HIV who are not on treatment or who are not virally suppressed may have a compromised immune system that makes them vulnerable to opportunistic infections and more severe COVID illness. And also it is thought from various studies that people living with HIV who have achieved viral suppression through antiretroviral treatment and who do not have a low CD4 will be affected by COVID in a similar way to what a person not living with HIV. So that means the carry-home message is people living with HIV should make sure that they should adhere to the antiretroviral drugs, make sure that they should be virological suppressed and good CD4, since COVID may not do much damage to them. How do we manage them? So we have different criteria to stage this. So this is NIH guidelines for staging the severity of the COVID. So we have asymptomatic and mild illness where almost 80 to 80%, 85% of the people present with this asymptomatic or mild stage in COVID, and remaining 15% either moderate, severe, or critical, again, based on their oxygen saturation and other clinical manifestation related to COVID. So as we all know that people with moderate, severe, and critical, they are being hospitalized because they need supportive oxygen and various other medications. And in those conditions, antiviral drugs have very limited value based on the Solidarity clinical trial. But on the other hand, anti-inflammatory drugs like steroids and anticoagulant have an enormous benefit in preventing mortality based on different clinical experience and as well as the recovery clinical trial. So today, the standard of care in India for managing moderate, severe, and critical COVID is you manage them with steroids, with anticoagulants, supportive oxygen, managing comorbid conditions and supportive medications. Intravenous remdesivir has got a limited benefit based on different clinical experience as well as from the Solidarity trial. If you give at the early stage, it works. At the later stage, it has got very limited benefit. Also, other anti-IL-6 inhibitors been beneficial when someone has got a very severe COVID, has not been responding to other anti-inflammatories, and of course, prone ventilation. Again, we manage people living with HIV, when they develop a moderate or severe COVID, in the same way like someone, who do not have, HIV. There is no difference in using different medications for managing people living with HIV when they develop a moderate or severe COVID. Again, when we used all those antivirals when there are been moderate, severe, it had a very limited benefit. But on the other hand, today we do have medications, antivirals available when someone who has been early infected, which can halt SARS-CoV-2 disease progression, which I'm going to walk you through soon. So as I said earlier, 80 to 85% of the people, when they develop a COVID, including people living with HIV, say in mildly symptomatic. And among them, 5 to 15% can progress to moderate or severe, depending upon the background illness. So if they have an HIV positive, based on the review I said, if they do not have a good CD4, they have uncontrolled HIV viral load, then they have a higher chance of disease progression. So today, we do have antivirals and monoclonal antibodies, which are approved for use, which can halt the disease progressions. The next few slides, I'll be walking through some of the new oral antivirals, which are being recommended for use among people who are early infected with COVID, which can also be used and should be used in people living with HIV, including monoclonal antibodies. There are various other drugs which are being validated, starting from Camostat, hydroxychloroquine, and lopinavir, but they all had very limited or no use in preventing this viral replication or the disease progression. Remdesivir is a drug which has been used a lot, particularly in severe and critical disease, which have got a limited benefit. But now this remdesivir is repurposed for early disease. So this is a trial which has been conducted very recently and been published now. This is a trial called Pine Tree. So where remdesivir has been used in non-hospitalized patients who come to the outpatient clinic with mild disease, who had a high risk for COVID disease progression. They're randomized into two different groups. One group received 3-day course of remdesivir. The normal course is 5 days in hospitalized patient. This is an outpatient 3-day course, which has been compared against the standard of care with the placebo without any antivirals. So in this trial, it's been found that someone who received 3-day course of remdesivir, which prevented COVID-related hospitalization and death as compared to placebo. So that means remdesivir acts as an antiviral if you give a little early in the course, particularly in people with mild disease. But again, the logistics being, you need to bring these COVID-infected people to the hospital 3 different days to give these infusions. That's a major issue in terms of isolation and as well as bringing them to the hospital when they have been home isolated. To combat this, now we have newer oral antivirals. There are 2 new drugs recently been approved for use by the FDA called Paxlovid, which is a combination of nirmatrelvir with ritonavir, which boosts the nirmatrelvir. This inhibits the SARS-CoV-2 protein, which stops the virus from replicating, and ritonavir, which slows down the nirmatrelvir breakdown to help it remain in the body for a longer period at a higher concentration in the process of boosting. Similar like how ritonavir boosts some of those protease inhibitors in HIV. Another oral antiviral is molnupiravir, which is a nucleoside analog that inhibits SARS-CoV-2 replication by viral mutagenesis. There are different studies being done to show the efficacy of this drug. So this is a trial which they use this Paxlovid, which is a combination of nirmatrelvir with ritonavir in non-hospitalized COVID patients, where they are being randomized into 2 different groups. One group received this Paxlovid 5-day course, and another one received just a placebo. So it's been very clearly shown that it reduces the risk of hospitalization or death by 89% when those patients who receive this Paxlovid, which is a combination of nirmatrelvir with ritonavir. But again, safety analysis shows this drug has been very safe, and Data Safety Monitoring Board terminated the study earlier because of the huge benefit following this study drug of nirmatrelvir with ritonavir that's called Paxlovid. So following these results, the FDA approved for an emergency authorization among patients with COVID with early disease, with 300 milligram of nirmatrelvir, with 100 milligram of ritonavir, and which should be taken twice daily for 5 days. There should be a dose reductions, especially patients with moderate renal impairment. There is another drug called molnupiravir, which again been tried in early COVID disease patients in a very large clinical trial, move in and move out, which very clearly shows in the interim analysis, showed reduction by 50% in hospitalization or death. And in the final analysis, that reduced to 30%. Again, the drug has been very safe. And we conducted this large multi-site clinical trial in India using a generic preparation of molnupiravir, and was being presented at the retrovirus conference 2 weeks back. And now it is under press in a journal, where we recruited a large number of people with COVID and early disease of 1,218 patients. So randomized 2 different groups. One group received molnupiravir 800 milligram twice daily for 5 days, which has been compared against the standard of care of just supporting medications. And in this large Indian multi-site trial, we found that patients who received molnupiravir have reduced hospitalization as compared to people who had been on standard of care at the end of day 14. So this has been seen across different endpoints at day 5. We're again seeing statistically significant reduction in the hospitalization and the clinical improvement, and as well as on day 10 and day 14. And again, time to clinical improvement was statistically significant among patients who received molnupiravir as compared to standard of care, which has been shown in this Kaplan-Meier curve. When we looked into the SARS-CoV-2 RT-PCR negativity, again, quicker viral clearance been seen among patients who received molnupiravir as compared to the standard of care at day 5, day 10, which has been hugely statistically significant. And also when we compared the cycle threshold CD value, which has also been significant among patients who received molnupiravir as compared to standard of care. Very limited adverse events been reported, nothing been significant to disrupt therapy. And we concluded this large Indian multi-site clinical trial using molnupiravir in early COVID disease, stating that twice daily 800 milligram for 5 days with molnupiravir reduced hospitalization and reduced mortality. There is a quicker viral clearance, which will have a huge impact in India, particularly in preventing community transmission, and it's been very safe and should be recommended for early COVID disease among people who have got a risk for progression, including in people living with HIV. So following this, FDA approved this as an emergency authorization, and today it's been recommended as 800 milligrams twice daily, for 5 days. It's been available from India from our generic manufacturers. There are very limited data been available among people living with HIV. In fact, there is no randomized clinical trials been carried out among people living with HIV when they develop a COVID using this drug. So we had uses in patients with HIV in our cohort of 15 patients till now been treated with this, who had HIV, all recovered very quickly, have been symptom-free. We did not see any drug-drug interactions with antiretroviral drug. It's been very safe, and we strongly recommend to of molnupiravir therapy for early COVID disease in people living with HIV, since it will prevent COVID disease progression in people living with HIV. There are various monoclonal antibodies now been approved by the FDA and not been widely used in lower and middle income countries. These are the various monoclonal antibodies which can be used, even including in people who have been immunosuppressed. Again, among them, Sertramib is the only one which has been recommended for Omicron variant. The other two have got a very limited activity. So if you put all those various interventions like monoclonal antibodies, oral antivirals, and IV antivirals, all have resulted in reduction in the hospitalization and mortality, but very limited data available in unvaccinated people as well as among people living with HIV, but all being expensive. Cost is a major concern. But if you put these scientific results, this all prevents disease progression. It's time that, so these interventions should be studied in people living with HIV, and the outcome should be immediately translated, since HIV itself can act like a cofactor for disease progression if they are not being controlled with the viral load and they have a low CD4 and if the patients are not adhering to antiretroviral drugs. So moving to this post-COVID sequelae, particularly in HIV, we have seen this in non-HIV, we have seen in HIV-infected people too, after the COVID became negative, patients complaining of fatigue, arthralgia, and myalgia, persistent cough and dyspnea, sleep disturbance, mood disorders and anxiety, and also worsening of some of their comorbid conditions. We had also seen patients developing tuberculosis in the post-COVID follow-up, and as well as a couple of cases with the mucormycosis, again because of those immunosuppression. So again, worsening of the comorbid condition can be bothersome, particularly in HIV when they have diabetes or hypertension. Hence, close monitoring for these conditions is very important among people living with HIV if they have developed COVID. I like to conclude stating that what advice we can provide as a provider for people living with HIV, along with this public health message of hand washing, mask, and avoid gathering. We should counsel them to make sure that they should strictly adhere to antiretroviral treatment and to other opportunistic infection medications. Don't change the current effective non-PA-based antiretroviral treatment to a PA-based therapy, because initially there were reports stating that lopinavir can prevent COVID, and some of the clinicians are changing the medications. Please don't do that, because the trials have shown that it's not been effective. So whatever regimen they are taking, if they have been very effective, continue the same regimen at the time of COVID treatment. And also counsel the patients to make sure that they should adhere to those comorbid condition medications for hypertension and diabetes, which we all know that these act like a major cofactors for SARS-CoV-2 disease progression. Today, we have a COVID vaccination available, which prevents COVID disease progression. All our people living with HIV should be vaccinated, including with the booster. Now, there are also more and more data coming up among people living with HIV that there is a need for booster over a period of time. With this, I'll stop my presentations and happy to take any questions during the discussion. Again, thank you again for the organizers for giving this opportunity to this presentation on managing people living with HIV with COVID. Thank you very much.
Thank you. Thank you, Dr. Kumar Swami. That was an excellent presentation, starting from the recent epidemic that we all witnessed and that created a havoc in our practice, as well as not only for our practice, but also for patients. You traced it very well, and you have covered the entire aspect that is required and for the HIV infected. But one of your slides really brought into focus a thought process that I have been having for some time. Everybody says diabetes is risk factor, diabetes is risk factor. I just like saying you're older, it's a risk factor, not for acquisition, but more for the severe symptoms or even death. If you look at your slide where you showed the hazard ratio, but not getting into the numbers, it is 3 times less if your blood sugars are controlled. So advancing age, 50 years. Secondly, keep your blood sugars less than 7. The problems that we saw with this dexamethasone therapy was that, probably you were intending to allude to that in the discussion, was this aspergillus. The reason why we got this aspergillus as a nightmarish problem was because of the uncontrolled blood sugars. So the fundamentals there was to control the blood sugars and not to call you a diabetic and your guys, the problem is with you. Not really. We doctors have to control the blood sugars very well. And you have very clearly shown that your patients, and your final comment was that there is no change in your regimen. You don't have to be worried about worsening COVID-related disease. And my concern here was, and you have also shown that your ART adherence rate was good. In my center, it was honestly not really good. My TB patients fell, out of sight for some time. Perhaps I didn't chase them well. What was your opinion? What was your response to that? Did they come very regularly? ART adherence, you showed it. But did they really miss any dose in this COVID period? Because I was thinking that there would be a lot of, what shall I say, psychosocial support that they needed during this pandemic, and whether they would really come to you for your drugs.
Sure. Thank you, Dr. Mathai, for the nice comments. So I think as I walk you through the data, both from India as well as from other countries, adhering to the antiretroviral drugs in this pandemic has been very, very important. And we have seen there are huge disruptions of antiretroviral therapy happen, both in the public sector as well as the private sector because of the lockdown, restricted movements. and several other issues. Even many of the HIV care providers been repurposed to do COVID management, and the HIV centers became COVID hospitals. Is all resulted in the disruption. I think this is time that now we need to follow all our people living with HIV. How many of them have developed a COVID? How many of them have disrupted? What happened to them in the post-COVID era? Of course, we did not see much deaths in HIV, either in our center or even other centers, what we network. But on the other hand, this uncontrolled HIV, where they develop a COVID, whether it had resulted in future HIV disease progression, or it has brought in other newer onset of non-communicable diseases, or other post-COVID, long COVID complications. This is something what we need to study. Now we have set up an ongoing observational database, not only in India, but also in other lower and middle income countries, which may give us some data, maybe in the next few months also on that. You brought a very important point that there are patient disrupted, yes. So what we did from our center is we did a lot of telecounseling, video counseling, WhatsApp counseling, and so many other types of counseling to make sure that they adhere to the medicines. If they don't have the medicines, we even couriered them. We even told them, we have spoken to the local police and other restricted areas, how to reach this medication to a patient. In fact, government was very supportive to deliver this medicine to the home, even in containment zones where people couldn't move when we had this, this pandemic. I think this is, again, varies from region to region. They'll have a different experience by different clinicians, depending upon the area where they had the magnitude of the COVID pandemic.
Thank you. Dr. Gilada is now, is there. Dr. Gilada, would you like to share some comments, and then we'll go for the discussion later, and kindly introduce the next speaker as well, Dr. Ruby Bansal. Please give your comments as well.
You carry on, Dilip. You carry on. You introduce her.
Oh, you were giving me
the area where connectivity is very poor.
Yeah, you're giving me this wonderful privilege of introducing my colleague, Dr. Ruby Bansal. I visited her several times in Ghaziabad, and she's doing a human service, excellent service for the people in Delhi. And she's very interested in infectious disease, and she's a thorough reader of that. And she's also a joint colleague as a joint secretary of the ASI. And Dr. Ruby would be speaking to us, not because she's a lady, but she'll be speaking to us about women issues in HIV care. Over to you, Dr. Ruby. Thank you for coming. Thank you.
Thank you, Dr. Mathai. Good afternoon, everyone. So thank you for the kind introduction. Thank you for the opportunity by AIDSCON and AIDS Society of India. So I think my presentation is already recorded. So organizers, yeah.
Please start.
Yeah. Good afternoon. I'm Dr. Ruby Bansal from Ghaziabad. So it's a thank you organizers for inviting me. And today let me understand, since morning we are hearing about the HIV. So we understand about the few more thing in HIV, which is related to the women. So what is the difference between how the women are different when they are having HIV? So let me understand. So as we know, more than half the number of the people living with HIV worldwide are the women. And if we say, so mainly the young women between the 10 to 24-year-old are more suffering with the HIV and are having twice the risk of HIV as a young man. Means HIV women to men transmission is much higher. So HIV disproportionately affects women due to what is the difference? Basically, unequal cultural, social, economic status of the society, intimate partner violence, abuse, inequitable laws, harmful traditional practices, lack of the access to the healthcare service, education, poverty, and the early marriages. So तरह से how does the HIV affect the women directly? So men and women दोनों में ही HIV का different direction होती है, पर क्या होता है? So here I will like to use the bilingual language at your audience is the mixed. So we can see this is there can be the side effect of the medicine when the women is taking HIV. Few, they have different sexually transmitted infections. They have their own gynecological problem, which men are not facing. Different cancers, especially the cervical cancer, जो कि more prevalent है female में. Bone health, basically because कुछ medicines जो हैं bone health पर indirect effect डालती हैं, और otherwise भी women are more prone to osteoporosis. So depression women's में otherwise भी ज्यादा होता है, और जो HIV के साथ हैं उनमें ये थोड़ी सी और ज्यादा होती है. Lipodystrophy, diabetes, contraception and pregnancy issues. That is again a challenge in the women. So अगर हम सिर्फ देखें कि जो basically because this is all about कि aging with HIV. So when we are aging with HIV, definitely the problems are more. So there are again comorbidities, lifestyle disease, more are happening with these women. So lipodystrophy and diabetes, basically because अगर हम देखें कि बहुत सारी medicines हैं where जो कि mainly they can create this lipodystrophy, and even nowadays we are seeing कि since the dolutegravir came in the picture, weight gain is very much is a problem. So severely and very quickly male female both gaining weight, and जिसमें कि females ज्यादा weight gain कर रही हैं क्योंकि उनको central obesity, उनकी जो obesity होती है mainly hips पर जो है fats ज्यादा आ जाता है, तो वो भी एक problem है. So cholesterol definitely efavirenz के साथ भी problem था कि cholesterol and triglyceride बढ़ जाते हैं, and even the dolutegravir is also having. So उनका change in the face, breast size, body shape, mainly the increased risk of diabetes, increased heart problem. So, but what are the options? Definitely we are asking the patients to do more exercise, to control the diet, because early when they are having the disease, they are malnourished, they are thin and not eating food because of the illness. But जैसे जैसे बीमारी ठीक होती जाती है, HIV का medicines are effective, they have the magical effect. So patients को भूख भी ज्यादा लगती है और वो अपनी एक्सरसाइज और सब चीजों की हैबिट छोड़ देते हैं, तो वेट गेन सीवियरली होता है, एकदम से होता है. तो इसलिए एक्सरसाइज, हेल्दी डाइट, नो स्मोकिंग, नो अल्कोहल पॉलिसी, एंड समटाइम्स वी यूज द स्टैटिन्स, जो कोलेस्ट्रॉल को कम करने की दवाइयां होती हैं, वो भी इन वीमेन में हम यूज करते हैं टू प्रिवेंट दिस कोलेस्ट्रॉल प्रॉब्लम एंड टू प्रिवेंट द CAD. गायनिकोलॉजिकल प्रॉब्लम जो फीमेल्स में होती हैं, जो कि HIV के साथ हैं, उनमें और ज्यादा होती हैं, बिकॉज जो वेजाइनल इन्फेक्शंस हैं वो मोर, these women are more prone to the vaginal infections, basically because poor hygiene, maybe the multiple sex partner, maybe they are if they are commercial sex workers, so they have multiple sex partner or otherwise also. तो untreated vaginal infections जो होते हैं वो they can lead to the serious illness. और menstrual cycle problem are very common with these women's missed period, lighter heavy bleeding, or sometimes the premenstrual severe syndrome या premenopause और PCOD. इवन वो सभी जैसे कि अनकॉमन नहीं है इन women में भी, और ज्यादा ही हैं HIV patients में ये सब problems. So they need the regular gynae care. वो काउंसलिंग बहुत इंपॉर्टेंट है कि उनकी गायनी केयर प्रॉपर हो, एंड smear should be done. Liquid is important. Vaccine, cervical cancer vaccine. After testing, if they are negative, so this is also very important. You can see STD more frequent, complications more common, treatment failure भी common होता है, presentation में भी atypical, bacterial vaginosis, syphilis, और दूसरी STD भी काफी common है, और even the cervical cancer. So we need to take care everything in these women with HIV. Cancers. Definitely, we are talking about most common cancer is cervical cancer, जो कि otherwise भी इंडिया में women में ज्यादा prevalent है, और if they are the HIV positive, so उनमें और ज्यादा ये कैंसर के chances होते हैं. So screening, जैसा मैंने पहले ही बताया कि pap smear screening is very important. So pap smear regular करते रहना चाहिए. और even skin cancer, because so skin cancers भी काफी common है और breast cancer common है. So we need to definitely regular check these. And for the skin cancer, we need to ask them to use the sunscreens or to avoid direct sunlight and to take the umbrella when they are going into the sun. And for the breast cancer, regular mammogram is important. HIV and sexuality, women and men, कई बार क्या होता है when they are having HIV, so they stop having sex with each other. Or relationship basically because due to the fear of transmission, due to the fear of their own illness, or basically because they don't want to talk about the HIV, so unki sexual life effect hoti hai. But we need to again counsel ki this is with the condom, things can be normal and a person can have the sex normally if they are using the condom. And people, if they are virally suppressed, so, and if they want to have the normal sex, so at least if we are talking about the use to you, so sometimes even we need to counsel them. But definitely this is not stopping the, only condom can stop the pregnancy and the other STD. Although we have the PrEP also for HIV, but not for the pregnancy and the other STD. So these women can be pregnant also. So we need to counsel about their family planning also. Birth control and HIV. This is the same. HIV women can safely use any kind of the form of the birth control to prevent pregnancy. They can use the copper T, they can take the hormonal pills, or they can take the other methods, implants they can use. So to prevent this, तो वो सब उनको counsel करना बहुत जरूरी है. Basically, because if they don't want, or if their family is completed, at least they should understand how to control how to use the birth control things. So again, condoms are the only form of the birth control that can prevent HIV transmission, or these are the condoms are the only thing which can prevent them from the other sexually transmitted infections such as gonorrhea, syphilis. As जब से PrEP आया है, तो we are seeing कि PrEP आने के बाद if people are not using the condom, so उनमें STDs बढ़ गई हैं. So PrEP is not an option for this is an additional tool for HIV prevention, but not an option of the condom. So very frequently when the patients, HIV positive patients comes to my clinic or the other clinic, so उनके मन में बहुत सारे यही क्वेश्चन होते हैं. क्या can I have a children? मेरे बच्चे हो सकते हैं क्या? Will I or my partner get infected? What is the risk of HIV infection in my baby? मेरे बच्चे को तो नहीं हो जाएगा? मेरा कितनी उम्र रहेगी? मैं कितने साल तक जी सकती हूँ? डॉक्टर साहब लाइफ कितनी होगी? Will my pregnancy impact my HIV? क्या प्रेगनेंसी होने से मेरे HIV मेरे को बढ़ जाएगा, या HIV के होने से प्रेगनेंसी पे क्या इफेक्ट आएगा, और कैसे और कब HIV ट्रांसमिशन हो सकता है प्रेगनेंसी के? क्या मैं ब्रेस्ट फीड कर पाऊंगी? So every woman needs a heart. What are the effects of heart on my baby? So these are the many questions. They have the multiple questions in their mind. So we need to clarify each and everything once the female is coming with these questions. And ये सारी questions उनके दिन पहले दिन से होते हैं, whether once they are even not planning the pregnancy, because that is the most important thing the women's life, to give birth. So इसीलिए उनके दिमाग में सारे क्वेश्चंस बहुत पहले से होते हैं, और वो इन्हीं क्वेश्चंस के आंसर आपके साथ जानना चाहती है. So definitely, answer is definitely women with HIV can have healthy pregnancies. बहुत सारे हैं. Even सभी जितने भी लोग HIV ट्रीट कर रहे हैं, सभी का एक्सपीरियंस रहा है कि उनके जो पेशेंट्स हैं, उनके जो बच्चे हुए हैं वो नॉर्मल हैं. मेरे खुद के पेशेंट्स करीब जो हैं 30 कपल्स जो कि नॉर्मल बेबीज को डिलीवर कर चुके हैं, और सो उनकी सबके बच्चे नेगेटिव है. सो एब्सोल्युटली दिस इज नॉट ए क्वेश्चन विद HART हार्ट एंड HIV medicines patient can have. We can prevent the transmission. We can just even reduce the transmission up to 0. So Otherwise, risk of transmission during pregnancies is 1 in 4, approximately 25% अगर treatment पर नहीं है. But we can reduce it less than 1 or to 0. Prenatal and HIV care, C-sections if necessary, and viral load is more than 1000. If the patient is recently diagnosed, not on hearty, pregnancy के second trimester में या third trimester में diagnose हुई है, तो definitely the better option is the C-section. Although आजकल जो है government and everywhere they are asking कि normal deliveries also, but when the viral load is totally suppressed, then we can go for the normal delivery. Otherwise, the C-section is a better option. No breastfeeding. Again, if the viral load is fully suppressed, then we can this option should be, we can give both the option to the parents, and that is should be the choice of the parent whether they want the breastfeeding, or basically because in India there are a lot of the cultural things, बहुत सारे cultural bias हैं, बहुत सारी चीजें हैं, वो उनको जो ये फियर रहता है कि मैं घर में अगर दूध नहीं पिलाऊंगी तो मेरी सास कहेगी कि तुम दूध क्यों नहीं पिला रही हो, बेसिकली बिकॉज दे आर हाइडिंग द स्टेटस. सो बहुत सारी चीजें हैं कि मेरी माँ क्या कहेगी, मेरे पड़ोसी क्या कहेंगे, तो उस चीज में हमें जो है बहुत अच्छे से समझाना होता है कि व्हाट इज द रिस्क वर्सेस बेनिफिट of the breastfeeding. Definitely breastfeeding is good for the child. So maternal mortality, this child neonatal mortality को काफी कम करता है breastfeed, but simultaneously we need to prevent the HIV. अगर viral load suppressed है, so then we can ask the female to ask for the exclusive breastfeeding. She can exclusive breastfeed कर सकती हैं, और जिससे कि after 6 months sudden weaning, no mixing of the food, नो मिक्सिंग, नो टॉप एंड दिस दोनों फीड एक साथ नहीं होना चाहिए. तो ये बहुत अच्छे से क्लियर करना है. और अगर शी इज रेडी फॉर द फॉर्मूला फीड, सो बेटर शी कैन डू दिस. सो किस तरह से रिस्क होता है, कौन कौन से ट्राइमेस्टर में. सो HIV फर्स्ट ट्राइमेस्टर इन यूट्रो हो सकता है, इंट्रापार्टम हो सकता है, और पोस्टपार्टम हो सकता है. सो इन यूट्रो में 8 to 10% ट्रांसमिशन है. सबसे ज्यादा इंट्रापार्टम होता है, द टाइम ऑफ द बर्थ 17 से 20%, और पोस्टपार्टम इन द ब्रेस्ट फीडिंग 10 to 15% ट्रांसमिशन रेट है बच्चे में, अगर माँ से बच्चे को जाता है. डिप्रेशन इज अगेन, पहली चीज तो यही है कि डिप्रेशन का सबसे बड़ा कारण पहला तो डिजीज इटसेल्फ, कि ये बीमारी हो गई है, क्यों हो गई है, मेरे हस्बैंड को थी या मुझ हस्बैंड से आई है, या बहुत सारा चीजें हैं. बहुत सारी यंग लड़कियां हैं जिनकी मैरिज हुई है, वो उनकी कंप्लेंट रहती है कि हमें पता ही नहीं था कि हमारे हस्बैंड को है और हमसे झूठ बोल के शादी की है, और इस तरह की भी प्रॉब्लम है. या उनके साथ जो है कोई गलत हुआ है, कोई सेक्सुअल अब्यूज हुआ है, तब वो HIV का शिकार होती है, तो वो पहले से डिप्रेशन में होती है. और HIV के बारे में जानने के बाद और ज्यादा. सो 60% ऑफ द HIV वीमेन display the sign of clinical depression. Depression otherwise भी नॉर्मल लोगों में भी काफी हद तक डिप्रेशन बढ़ा है, पर HIV पॉजिटिव में ये बहुत ज्यादा है. फीलिंग ऑफ सैडनेस, गिल्ट और लो सेल्फ. अगेन अगर जो है उनका कहीं कोई अनप्रोटेक्टेड सेक्सुअल कांटेक्ट रहा है, तो वो गिल्ट बहुत ज्यादा रहती है कि मैंने ये क्या कर लिया और मेरे बच्चों को हो जाएगा, तो उस लड़की को ये वाली भी गिल्ट रहती है. इरिटेबिलिटी हो सकती है, लेक ऑफ इंटरेस्ट इन एक्टिविटी, चेंज इन एपेटाइट और वेट, ये सब डिप्रेशन के साइंस हैं. So acne, pains, difficulty in making decision, concentration, thought of the self-harm, suicidal tendency तक आ सकती हैं, change in the sleep pattern, fatigue, loss of energy, low sex drive. So अगर जो है किसी भी फीमेल में ये सारी चीजें आ रही है, तो you can just like think of कि person is suffering from the depression. So here the counseling is very, very important. Every time patients are coming to us, we are counting, which we should be doing. Every doctor who is treating HIV should do this thing. HIV एंड एजिंग, जैसे कि मैंने पहले ही बात की कि HIV एंड एजिंग आजकल ये बहुत कॉमन टॉपिक है, बिकॉज HIV की मेडिसिन की वजह से लाइफ इज प्रोलॉन्गिंग, क्वालिटी ऑफ लाइफ इज ऑल्सो इम्प्रूविंग. सो जब लाइफ बढ़ रही है तो एजिंग होगी, तो एजिंग के साथ साथ की जो प्रॉब्लम है वो इन वीमेन्स में भी ज्यादा प्रिवेलेंट होती हैं एज कम्पेयर टू नॉर्मल women. Men, women both, right? So maybe other older HIV patients have more medical problem related to the age. They have the diabetes, they can have the hypertension, they can have the CAD, they can have the osteoporosis, बहुत सारी चीजें हैं जो कि सिर्फ एजिंग का कंसर्न नहीं और भी कंसर्न होते हैं, जैसे कि मेनोपॉज, अर्ली मेनोपॉज हो सकता है, मोर सीवियर हॉट फ्लैशेस हो सकते हैं, ऑस्टियोपोरोसिस भी सीवियर हो सकता है, बेसिकली बिकॉज इवन द फ्यू मेडिसिन्स आर प्लेइंग रोल इन क्रिएटिंग द ऑस्टियोपोरोसिस अर्ली, सो दैट इज ऑल्सो ए प्रॉब्लम. सो कंसर्न फॉर ऑल ऑल्डर वुमेन, बट जो कि HIV से ग्रसित हैं उनके साथ ये सब चीजें ज्यादा होती हैं. बोन लॉस ज्यादा होता है, फास्टर होता है वीमेन में, अदरवाइज भी मेन से, और HIV पॉजिटिव पेशेंट्स में नॉर्मल वीमेन से और ज्यादा होता है, इसलिए ये ज्यादा फेस करती हैं इस प्रॉब्लम को. तो वी नीड टू हैंडल दीज प्रॉब्लम्स आल्सो इन दीज पेशेंट्स, दीज HIV women. HIV medicine side effect, definitely drug interaction, that is also common, so we should be taking care of that part also. क्या ले रही हैं, maybe sometimes even the birth control pill के साथ interaction हो सकता है, so हमें जो है सारी चीजों का पता होना चाहिए कि that women what all she is taking, किस तरह की चीजें ले रही है, क्या उसके साइड इफेक्ट हैं और क्या इंटरेक्शन है. सो बट समटाइम्स दूसरी चीजों के साइड इफेक्ट या मेडिसिन के साइड इफेक्ट और इवन द HIV की मेडिसिन के साइड इफेक्ट, मेक श्योर कि दे आर नॉट स्टॉपिंग द मेडिसिन, नॉट skipping the medicine, which is a very common problem with the efavirenz. It was a very common thing कि पेशेंट्स कहते थे डॉक्टर साहब बहुत ज्यादा चक्कर आ रहा था तो दवाई छोड़ दी हमने, 2 हफ्ते से दवाई नहीं खाई, और या मैं हफ्ते में 2 बार खा लेती हूँ और हफ्ते में 3 बार खा लेती हूँ. बहुत सारी प्रॉब्लम में मेरे पास पेशेंट्स ऐसी थी जो कि ये वाली कंप्लेंट करती थी कि हमें चक्कर आता है, सुबह उठ नहीं पाते हैं, बच्चों का स्कूल होता है, हम घर काम नहीं कर पाते हैं, मैंने दवाई छोड़ दी. सो वी शुड बी very sure कि कौन सी मेडिसिन है. If we need to switch, we need to switch it timely to have the better 99% or more than 99% adherence to get the early viral suppression. Living well, taking care of the women, yes, definitely उसमें न्यूट्रिशन का बहुत बड़ा रोल है कि न्यूट्रिशन इज वेरी इंपॉर्टेंट. हिंदुस्तान में अगर देखेंगे तो महिलाएं वैसे ही खाना बहुत मतलब कम खाती हैं, या आप कहें कि अगर जो है पहले घर के सारे लोगों को खिलाने के बाद जब वो जो भी बच जाता है तो वो खाती हैं, तो वो उनका न्यूट्रिशन वैसे ही कम होता है. सो HIV पॉजिटिव महिलाएं और ज्यादा शुरू में उनका खाने का मन नहीं करता या भूख नहीं होती या वे न्यूट्रिशियस डाइट नहीं लेती. खाना मतलब सिर्फ ये नहीं है कि आपको खाना खाना है, खाने में चॉइस क्या होनी चाहिए वो बहुत इंपॉर्टेंट है. सो इट शुड बी बैलेंस्ड डाइट, फुल ऑफ न्यूट्रिशन, बैलेंस्ड विद द फैट, कार्बोहाइड्रेट और आपके प्रोटीन्स और विटामिन का बैलेंस होना चाहिए. तो इन महिलाओं को आपको डाइट का बहुत अच्छे से बताना पड़ता है कि क्या क्या चीजें खानी है. सो इवन नॉट इट्स नॉट नेसेसरी कि वो कोई महंगे फल खाएं. सो आप यूजुअल नॉर्मल ग्रीन लीफी वेजिटेबल, दाल और घर का बना खाना जो कि दाल, चावल, रोटी, ग्रीन लीफी वेजिटेबल्स, उसमें जो है साथ में गुड़, तो ये सब चीजें और साथ में सैलेड और जो भी कुछ घर में जिसके भी जो भी सिस्टम से घर में खाना बनता है वही खाना अगर वो अच्छे से खाती हैं तो वो एक प्रॉपर बैलेंस में हो सकता है. दही, दूध, जिसमें छाछ ले सकती हैं, तो उनकी जो है खाने को आपको न्यूट्रिशन की गाइडेंस भी, न्यूट्रिशन की वो भी बहुत जरूरी है. रेगुलर एक्सरसाइज कैन इंप्रूव द हेल्थ एंड स्ट्रेंथन इम्यून सिस्टम, सो रेगुलर एक्सरसाइज ऑल्सो एंड पर है तो वो suddenly weight gain and it will have the depression also, so we need to take care of these things basically because they have a lot of anxiety, lot of psychological issue, so they feel helpless because they cannot tell this problem to anyone because they have to keep this problem with them. So that is the problem. और उसी की वजह से उनका जो एक कनेक्ट होता है सोसाइटी से वो कट जाता है, तो वो उनके पास कोई कहने सुनने के लिए that is the responsibility of the doctor कि we should listen to them properly and उनको peer groups of the HIV positive groups, so वहाँ पर हम can tell their problems and they can understand each other, so that is a very important thing. So at the end the summary is definitely HIV disproportionately affect women and adolescent girl because of the
You stop the voice, there is a disturbance.
Unequal culture, social and economical status, because कहीं बाहर करते हैं और उनको पता भी नहीं होता कि उनको ये बीमारी हो गई है. So sometimes they don't know about this disease and they don't know about कि क्या हुआ है, और उनको जो है इस तरह की प्रॉब्लम होती है, और फिर हस्बैंड फिर से बाहर चले जाते हैं, और समटाइम्स ऐसा होता है कि इवन हस्बैंड डोंट नो हिज स्टेटस, और महिलाओं को जल्दी सिम्टम्स आने शुरू हो जाते हैं बिकॉज उनका जो है नरिशमेंट प्रॉपर नहीं होता है, या उनके सिस्टम वीक होता है. Women with HIV can lead to the happy life. Definitely regular medication. Medicines are the magical pills. So if anybody is taking regular medicine, definitely they will lead a happy life. So regular follow-up with the doctor, because we need to take care of the other side effects, maybe the kidney health, we need to take care of the bone health, we need to take care of the anemia. So बहुत सारी चीजें हैं जो हमें देखनी होती हैं, इसलिए regular follow-up, regular testing is important. Healthy and balanced nutrition, regular exercise, regular screening for the cancer and other sexually transmitted infection. वो भी बहुत इंपॉर्टेंट है कि सिर्फ HIV को नहीं ट्रीट करना है, उनकी जो भी STD हैं और सेक्सुअली ट्रांसमिटेड इन्फेक्शन है उनको भी ट्रीट करना होता है. सो एंड ये बहुत इंपॉर्टेंट है. फिर दैट वन मैसेज कि HIV पॉजिटिव women can have the normal pregnancy, healthy pregnancy, ये बहुत इंपॉर्टेंट मैसेज है जो कि हर women को पता होना चाहिए जो कि HIV पॉजिटिव है. एंड बेसिकली बिकॉज देयर शुड नॉट बी जेंडर इनइक्वालिटी, कोई वायलेंस अगेंस्ट द वीमेंस एंड गर्ल्स नहीं होना चाहिए. ये अभी 8 मार्च गया है जो कि इंटरनेशनल वीमेंस डे था, और इस बार का थीम भी यही था कि ब्रेक द बायस, जेंडर इनइक्वालिटी और किसी भी तरह के बायस को ब्रेक करना. तो सबसे बड़ी बात तो मैं जो हमेशा कहती हूँ वीमेंस के लिए, कि सबसे बड़ा बायस तो वीमेन को खुद को ब्रेक करना होगा कि सेल्फ लव के दौरान. So they should love themselves basically, because women's के साथ प्रॉब्लम है, वो अपने आप को नहीं, वो अपने सारे परिवार को प्यार करती हैं और सभी लोगों का ध्यान रखती हैं पर खुद का ध्यान नहीं रखती. तो जब तक वो ये बायस नहीं छोड़ेंगी कि उनको खुद की भी केयर करनी है, तो चाहे वो HIV हो या कोई भी डिजीज हो, वो उससे जो है लड़ पाना मुश्किल होगा, क्योंकि उन्हें अपनी केयर, अपनी टेस्टिंग, अपनी समय से दवाई लेना, अपने लिए अच्छा न्यूट्रिशन लेना, अपने लिए एक्सरसाइज करना और अपनी हैप्पीनेस का ध्यान रखना. तो ये बहुत इंपॉर्टेंट है. So that's all with my this presentation. Now I'm open for the questions, and thank you very much. Thanks for patient listening.
Thank you, Dr. Ruby. That was good. You spoke in the morning session that we heard, really the voice of the unheard. You know, you really supported the cause of women. I have just 3 points, but 1 or 2 to make it a little more, kind of with no offense intended. Now, you are asking a lady to exercise. A lady is already doing 6,000 steps, more than 6,000 steps in a day as a homemaker. So why do we need an additional set of exercise? Number 1. Number 2 is I have an adult immunization clinic. Till today, I have not had the guts to give the HPV vaccine to my medical students because they are now 16. 16 is too late. Most recently, I don't know the legal part of it. I checked with my legal office as well. A group of my people went and gave HPV vaccine to people in the remand home or those who were involved in so-called human trafficking, and also for young, or for your orphans. Now, honestly, nobody has come to me, or neither have I gone to give somebody HPV vaccine, which today, I'm not speaking about the latency of HPV and when you can get a high-grade dysplasia. How much are we really doing for our women in this front of cervical cancer? Prevention, highly preventive. I don't know if HIV policies allow the use of HPV vaccine for them. Could you just?
Sir, I think it is very well there. Adult immunization, even on the ANACO guidelines, they are just promoting all the adult immunization in the HIV positive patient. Even the child immunization also if the child is HIV positive, so same immunization, except the live vaccines, all the vaccine should be offered to children and the adults as we are doing the non-HIV people. So as per the use mentioned, very well mentioned, ki HPV vaccine, definitely all the adult immunization is a gray area. Unless we could see this is in the COVID era also, where there was a lot of hesitancy in the starting to take the COVID vaccine. So that's why we are not up to the mark. We still did not reach to the Western world as per is the concern of the adult immunization. Although I have started it say long back when we have just first made in the Max Hospital in the Pushpanjali Crossley, the adult immunization center. But I can just tell maximum of my HIV positive women have taken this cervical cancer vaccine after the screening. So I'm who were just able to afford it, basically, because the problem is again the second problem with the HPV vaccine, it is a costly vaccine. So it's not, I mean, cost is approximately, if we are giving the 3 vaccine, so it's one vaccine costing 2,500, 2,800, even the 3,500 now of this Gardasil. So that is the problem. That's why the problem means lies. And you as a in a college, definitely, sir, you should promote more to the medical students. They don't have the affordability issue, but we should. It is again the sensitization.
Yeah, thank you, Dr. Ruby. Now I'm opening the floor open to the audience, and Dr. Gilada, could you take over and then orchestrate this program? Dr. Prathi, thank you very much for your presentation, Dr. Kumar Swami and Dr. Ruby, but I will be here, but I am requesting Dr. Gilada to conduct this. हमको हिंदी में मालूम, हिंदी में बात कर सकते हैं, but उतना अच्छा नहीं है. There is Gilada sir is there, is not there?
Yeah, he has got a weak internet connectivity, so I think we can go ahead with the panel discussion.
Yeah. Go ahead. May I ask the event organizers to, see if any of the members in the audience would like to ask a question, or would they send a Q&A or a chat box message?
No, sir, there is no message any.
There's one question in the Q&A box, sir.
Yeah, I think that was for me. It says, is it possible to share your experience with STI pathogens using these POC tests? So the molecular tests for chlamydia and gonorrhea, they perform very well. So even on Gene Expert, the sensitivity that we see is almost close to 95 to 99% in different studies. And even in our setup, we've seen very good results on Gene Expert. There are other platforms that are available. So Mall Biodiagnosis also has a molecular test for CTNG. And there are a few lateral flow assays where the antigen is detected, so they are not molecular. The sensitivity is a little low, but it has the advantage that you do not need these expensive equipments. The cost is much lower, and they can be done in setups where, in very small setups where these machinery are not available. Again, with syphilis, there are a lot of tests, and they are simple tests that can be done. So there are tests from Alere, Determine, there is SD Bioline, and all these tests have very good sensitivity. So with sexually transmitted diseases, these infections, the sensitivity of most of these tests are very good. And turnaround time usually varies between 30 minutes to 1 hour, depending on the platform that's being used.
Yeah. So I don't see any more questions, but I think Ruby's last slide showed a dish with broccoli and carrots, and that made me a little hungry. And I don't want to deny this opportunity to the audience who will be having the lunch without us. So kindly savor the lunch and think of us as you eat. On behalf of the AIDS Society of India, I really thank my panelists as well as my colleagues in the society, Dr. Kumar Swami, Dr. Prathi, Dr. Ruby, and in absentia for the moment, Dr. Gilada. Thank you very much for this opportunity, and I hope you all enjoyed it. We enjoyed it. Thank you very much.
Thank you, Dr. Dilip. Thank you very, very much for moderating this session. Thank you. I would like to thank all the speakers, Dr. Ishwar Gilada also for joining us today here. Thank you very, very much. We'll break for lunch and we will be back at 1:40 sharp. Thank you.
Thank you.
Thank you. We are missing you.
Yeah, even we are missing being there. And the lunch.
It's looking a wonderful conference. So we are missing to be there.
We all will come to Chandigarh.
Yeah.
Yes,
Hopefully next
definitely
year.
things will get better, and hope to see you in AIDSCON-12 physically.
Yes.
Yeah. Thank you.
Thank you so much.
Bye-bye. Thanks.
Bye.
नमस्कार। चंडीगढ़ स्टेट एड्स कंट्रोल सोसाइटी HIV एड्स पर कार्यक्रम कार्यान्वयन में सीखने, अनुसंधान और क्षेत्र के अनुभवों पर ध्यान केंद्रित करते हुए वस्तुतः 11 और 12 मार्च 2022 को 2 दिवसीय सम्मेलन AIDSCON-11 एड्स मुक्त दुनिया की ओर आयोजित कर रहा है। सम्मेलन 2030 तक HIV एड्स महामारी को समाप्त करने के लिए 2025 तक 95 लक्ष्यों को प्राप्त करने पर विचार विमर्श करेगा। आपका दिन शुभ हो। हम वहां आपका इंतजार करेंगे। आइए इस सम्मेलन को सफल बनाएं।
Welcome to AIDSCON-11. Chandigarh State AIDS Control Society is organizing its two-day conference AIDSCON-11 towards an AIDS-free world virtually on 11th and 12th March 2022, focusing on the learning, research and field experiences in program implementation on HIV/AIDS. The conference would deliberate on achieving the 95-95-95 targets by 2025 in order to end HIV/AIDS epidemic by 2030. Once again, welcome to the conference from Team Eventful.
नमस्कार। चंडीगढ़ स्टेट एड्स कंट्रोल सोसाइटी HIV एड्स पर कार्यक्रम कार्यान्वयन में सीखने, अनुसंधान और क्षेत्र के अनुभवों पर ध्यान केंद्रित करते हुए वस्तुतः 11 और 12 मार्च 2022 को 2 दिवसीय सम्मेलन AIDSCON-11 एड्स मुक्त दुनिया की ओर आयोजित कर रहा है। सम्मेलन 2030 तक HIV एड्स महामारी को समाप्त करने के लिए 2025 तक 95 लक्ष्यों को प्राप्त करने पर विचार विमर्श करेगा। आपका दिन शुभ हो। हम वहां आपका इंतजार करेंगे। आइए इस सम्मेलन को सफल बनाएं।
Welcome to AIDSCON-11. Chandigarh State AIDS Control Society is organizing its two-day conference AIDSCON-11 towards an AIDS-free world virtually on 11th and 12th March 2022, focusing on the learning, research and field experiences in program implementation on HIV/AIDS. The conference would deliberate on achieving the 95-95-95 targets by 2025 in order to end HIV/AIDS epidemic by 2030. Once again, welcome to the conference from Team Eventful.
नमस्कार। चंडीगढ़ स्टेट एड्स कंट्रोल सोसाइटी HIV एड्स पर कार्यक्रम कार्यान्वयन में सीखने, अनुसंधान और क्षेत्र के अनुभवों पर ध्यान केंद्रित करते हुए वस्तुतः 11 और 12 मार्च 2022 को 2 दिवसीय सम्मेलन AIDSCON-11 एड्स मुक्त दुनिया की ओर आयोजित कर रहा है। सम्मेलन 2030 तक HIV एड्स महामारी को समाप्त करने के लिए 2025 तक 95 लक्ष्यों को प्राप्त करने पर विचार विमर्श करेगा। आपका दिन शुभ हो। हम वहां आपका इंतजार करेंगे। आइए इस सम्मेलन को सफल बनाएं।
Welcome to AIDSCON-11. Chandigarh State AIDS Control Society is organizing its two-day conference AIDSCON-11 towards an AIDS-free world virtually on 11th and 12th March 2022, focusing on the learning, research and field experiences in program implementation on HIV/AIDS. The conference would deliberate on achieving the 95-95-95 targets by 2025 in order to end HIV/AIDS epidemic by 2030. Once again, welcome to the conference from Team Eventful.
नमस्कार। चंडीगढ़ स्टेट एड्स कंट्रोल सोसाइटी HIV एड्स पर कार्यक्रम कार्यान्वयन में सीखने, अनुसंधान और क्षेत्र के अनुभवों पर ध्यान केंद्रित करते हुए वस्तुतः 11 और 12 मार्च 2022 को 2 दिवसीय सम्मेलन AIDSCON-11 एड्स मुक्त दुनिया की ओर आयोजित कर रहा है। सम्मेलन 2030 तक HIV एड्स महामारी को समाप्त करने के लिए 2025 तक 95 लक्ष्यों को प्राप्त करने पर विचार विमर्श करेगा। आपका दिन शुभ हो। हम वहां आपका इंतजार करेंगे। आइए इस सम्मेलन को सफल बनाएं।
Welcome to AIDSCON-11. Chandigarh State AIDS Control Society is organizing its two-day conference AIDSCON-11 towards an AIDS-free world virtually on 11th and 12th March 2022, focusing on the learning, research and field experiences in program implementation on HIV/AIDS. The conference would deliberate on achieving the 95-95-95 targets by 2025 in order to end HIV/AIDS epidemic by 2030. Once again, welcome to the conference from Team Eventful.
नमस्कार। चंडीगढ़ स्टेट एड्स कंट्रोल सोसाइटी HIV एड्स पर कार्यक्रम कार्यान्वयन में सीखने, अनुसंधान और क्षेत्र के अनुभवों पर ध्यान केंद्रित करते हुए वस्तुतः 11 और 12 मार्च 2022 को 2 दिवसीय सम्मेलन AIDSCON-11 एड्स मुक्त दुनिया की ओर आयोजित कर रहा है। सम्मेलन 2030 तक HIV एड्स महामारी को समाप्त करने के लिए 2025 तक 95 लक्ष्यों को प्राप्त करने पर विचार विमर्श करेगा। आपका दिन शुभ हो। हम वहां आपका इंतजार करेंगे। आइए इस सम्मेलन को सफल बनाएं।
Welcome to AIDSCON-11. Chandigarh State AIDS Control Society is organizing its two-day conference AIDSCON-11 towards an AIDS-free world virtually on 11th and 12th March 2022, focusing on the learning, research and field experiences in program implementation on HIV/AIDS. The conference would deliberate on achieving the 95-95-95 targets by 2025 in order to end HIV/AIDS epidemic by 2030. Once again, welcome to the conference from Team Eventful.
नमस्कार। चंडीगढ़ स्टेट एड्स कंट्रोल सोसाइटी HIV एड्स पर कार्यक्रम कार्यान्वयन में सीखने, अनुसंधान और क्षेत्र के अनुभवों पर ध्यान केंद्रित करते हुए वस्तुतः 11 और 12 मार्च 2022 को 2 दिवसीय सम्मेलन AIDSCON-11 एड्स मुक्त दुनिया की ओर आयोजित कर रहा है। सम्मेलन 2030 तक HIV एड्स महामारी को समाप्त करने के लिए 2025 तक 95 लक्ष्यों को प्राप्त करने पर विचार विमर्श करेगा। आपका दिन शुभ हो। हम वहां आपका इंतजार करेंगे। आइए इस सम्मेलन को सफल बनाएं।
Welcome to AIDSCON-11. Chandigarh State AIDS Control Society is organizing its two-day conference AIDSCON-11 towards an AIDS-free world virtually on 11th and 12th March 2022, focusing on the learning, research, and field experiences in program implementation on HIV/AIDS. The conference would deliberate on achieving the 95-95-95 targets by 2025 in order to end HIV/AIDS epidemic by 2030. Once again, welcome to the conference from Team Eventful.
नमस्कार। चंडीगढ़ स्टेट एड्स कंट्रोल सोसाइटी HIV/AIDS पर कार्यक्रम कार्यान्वयन में सीखने, अनुसंधान और क्षेत्र के अनुभवों पर ध्यान केंद्रित करते हुए वस्तुतः 11 और 12 मार्च 2022 को 2 दिवसीय सम्मेलन AIDSCON-11 एड्स मुक्त दुनिया की ओर आयोजित कर रहा है। सम्मेलन 2030 तक HIV/AIDS महामारी को समाप्त करने के लिए 2025 तक 95 लक्ष्यों को प्राप्त करने पर विचार विमर्श करेगा। आपका दिन शुभ हो। हम वहां आपका इंतजार करेंगे। आइए इस सम्मेलन को सफल बनाएं।
Welcome to AIDSCON-11. Chandigarh State AIDS Control Society is organizing its two-day conference AIDSCON-11 towards an AIDS-free world virtually on 11th and 12th March 2022, focusing on the learning, research, and field experiences in program implementation on HIV/AIDS. The conference would deliberate on achieving the 95-95-95 targets by 2025 in order to end HIV/AIDS epidemic by 2030. Once again, welcome to the conference from Team Eventful.
नमस्कार। चंडीगढ़ स्टेट एड्स कंट्रोल सोसाइटी HIV/AIDS पर कार्यक्रम कार्यान्वयन में सीखने, अनुसंधान और क्षेत्र के अनुभवों पर ध्यान केंद्रित करते हुए वस्तुतः 11 और 12 मार्च 2022 को 2 दिवसीय सम्मेलन AIDSCON-11 एड्स मुक्त दुनिया की ओर आयोजित कर रहा है। सम्मेलन 2030 तक HIV/AIDS महामारी को समाप्त करने के लिए 2025 तक 95 लक्ष्यों को प्राप्त करने पर विचार विमर्श करेगा। आपका दिन शुभ हो। हम वहां आपका इंतजार करेंगे। आइए इस सम्मेलन को सफल बनाएं।
Welcome to AIDSCON-11. Chandigarh State AIDS Control Society is organizing its two-day conference AIDSCON-11 towards an AIDS-free world virtually on 11th and 12th March 2022, focusing on the learning, research, and field experiences in program implementation on HIV/AIDS. The conference would deliberate on achieving the 95-95-95 targets by 2025 in order to end HIV/AIDS epidemic by 2030. Once again, welcome to the conference from Team Eventful.
नमस्कार। चंडीगढ़ स्टेट एड्स कंट्रोल सोसाइटी HIV/AIDS पर कार्यक्रम कार्यान्वयन में सीखने, अनुसंधान और क्षेत्र के अनुभवों पर ध्यान केंद्रित करते हुए वस्तुतः 11 और 12 मार्च 2022 को 2 दिवसीय सम्मेलन AIDSCON-11 एड्स मुक्त दुनिया की ओर आयोजित कर रहा है। सम्मेलन 2030 तक HIV/AIDS महामारी को समाप्त करने के लिए 2025 तक 95 लक्ष्यों को प्राप्त करने पर विचार विमर्श करेगा। आपका दिन शुभ हो। हम वहां आपका इंतजार करेंगे। आइए इस सम्मेलन को सफल बनाएं।
Welcome to AIDSCON-11. Chandigarh State AIDS Control Society is organizing its two-day conference AIDSCON-11 towards an AIDS-free world virtually on 11th and 12th March 2022, focusing on the learning, research, and field experiences in program implementation on HIV/AIDS. The conference would deliberate on achieving the 95-95-95 targets by 2025 in order to end HIV/AIDS epidemic.
It's an honor to invite Dr. Venkatesh Chakrapani, Chairperson C#. Dr. Chakrapani does not need any introduction. He's a famous personality. He's been associated with us since long, and it's a privilege to have him here today. He's a public health research. He has done public health research among sexual and gender minorities, 60 plus peer-reviewed journals, articles, 6 book chapters, recipient of several fellowships, and a part of NACO HRTRGs on trans people and MSM, and has served in various organizations on different posts. We welcome you, sir. Sir, am I audible? Hello?
So can you please unmute, sir?
Yeah. Good afternoon. Yeah.
Sir, am I audible to you?
Yes, I heard. I just got
welcome,
promoted as a
sir. Welcome.
panelist. Yeah.
On behalf of Chandigarh State AIDS Control Society, I'm grateful to you for joining us today as a chairperson. Thank you. I would now invite Dr. Chiranjeevi Bhattacharya from National Program Manager. He's a National Program Manager from UNDP. We welcome you, sir. He's a medical doctor and a public health expert, and he is associated with UNDP presently. He has got major awards and honors and published an international journal and also implemented ICMR funded project. We welcome you, sir, today.
Thank you.
Sir, am I audible?
Yes, thank you. Good afternoon to all.
Good afternoon, sir.
Good afternoon.
Sir, around 1,000 people have virtually joined us today and they're listening to you. I hope they will be benefited with your intervention and with your talk today. And I'm handing over the session to you now, the chair and the co-chair. Thank you very much.
Thank you. Yeah. Good afternoon, everyone. So welcome to this session on advancing the health of trans feminine people and MSM. We know that trans feminine people and MSM, they face disproportionate HIV burden. NACO's surveys indicate that the national average HIV prevalence among transgender people and MSM is decreasing. However, it is still several times higher than that among the general population. Stigma and discrimination faced by trans feminine people and MSM, they contribute to psychosocial health problems like depression, which in turn can increase HIV risk. The lack of family and social acceptance and lack of education and employment opportunities also force many trans feminine people to engage in sex work, further increasing their HIV risk. Trans feminine people have unmet medical gender affirmation needs as well. Many government hospitals, they don't have facilities or expertise to offer hormone therapy or gender affirmative surgeries. Offering such services may also increase the uptake of HIV and other health services. This session accordingly focuses on these areas: HIV interventions, including virtual interventions, social welfare programs for transgender people, offering a comprehensive set of services for transgender people, and strengthening the role of communities in health interventions. So my co-chair and I welcome all the eminent speakers here for this session. I now request my co-chair, Dr. Chiranjeevi Bhattacharya from UNDP for his remarks.
Thank you, Dr. Chakrapani. Once again, good afternoon to all present physically there and also the virtual audience, and also welcome all our esteemed panelists. So as Dr. Chakrapani has set the tone regarding the introduction of this session, what we are looking at is we will be listening to multiple experiences from multiple stakeholders in the government, as well as from the community, as well as other stakeholders. So as you know, in this landscape of the LGBTQ or the specific to the HIV program, the transgender community and the MSM community, there has been many recent developments, both in terms of biomedical intervention as well as the other social determinants, which are equally important. Also, you must have seen that in the new global AIDS strategy, there has been a lot of focus on integration of services, whether it is health services or other social welfare measures. So there have been some very good pilots across India done by development partners on integration of services. So we'll listen to that also. Also, specific in terms of government intervention, the Ministry of Social Justice as envisaged in the Transgender Person Protection of Rights Act 2019 has come up with a scheme which was launched just last month for the transgender community. So these are very a positive and exciting development, and we have a long way ahead on implementation of those interventions. But we feel that this holistic approach will ultimately help us in our goal of HIV prevention and control as well. So I will stop here and I will hand back to my chair, Dr. Chakrapani, to introduce the first panelist, and then we will move forward. Dr. Chakrapani.
Yeah, thank you. Now I invite the first speaker, Dr. Santanu Purohit. He is the National Consultant on Targeted Interventions in NACO. So welcome, Dr. Santanu. Yeah, please proceed.
Thank you, sir. Thank you so much. With the permission from the chair and co-chair, I'll be presenting the topic that has been assigned to me. That is an updates on interventions for TG Hijra and MSM population under NACP. So this is the key slides. Just I would like to highlight when it comes to the prevalence among the MSM TG Hijra population, that clearly shows among the MSM that is 2.69%. And among TG Hijra, as per the last assess, that has come out 3.14%. It clearly shows the risks that lies with these key populations. So in order to provide the services under National AIDS Control Program, as we have been discussing since yesterday, the two major strategies under the prevention, that is targeted intervention we are having, as well as we are having the link worker schemes where both these populations are covered. When it comes to interventions among TG Hijra populations, I'd like to submit in the forum that the last mapping, when it was conducted in 13-14, around 70,000 TG Hijra populations were mapped in India. So in the current interventions, if you look at, we are covering these populations with both set of exclusive intervention as well as the composite interventions. So out of which there are around 41 exclusive and composite, 267 composite interventions, which is some up to more than 300 interventions that we are having at present. Apart from this, there are under the link worker programs, also we are covering the TG Hijra populations who are there at the rural sites. So current coverage under the TI, especially that you look at, that is around 84%. The case in case of MSM populations, if you look at the last mapping was done in 2009, and with estimated population of 3.57 lakhs, out of which at present we are covering through both composite and exclusive intervention of around more than 500 interventions, and again we are covering more than 3 lakhs of the populations, which is amounts to around 84% of the total estimated populations. So these are the major two approach that we are having. If I would show it in a pictorial way, if you look at the coverage and the estimated populations, if you look at the left hand side of the map of India, there are certain states where we need to work, and also NACO is keen to work with the Status Control Society and the communities to come forward to intensify the interventions in terms of increasing the coverage, especially in J&K, in some of the northeastern part, and also Bihar, where we already are working on this. When it comes to MSM population, the right side of the graph that clearly shows there are some of the pockets in southern states of India, including Maharashtra, Tamil Nadu, Kerala, in MP, and western Gujarat. There are more than 15,000 of MSM population have been covered through TI and other CPOs. So this speaks about the scale of the coverage, where invariably in both the cases more than 84% of the population have been covered. So what are the services that we do provide with the prevention, under the treatment, or then the care and support, and under the scheme of advocacy mainstreaming under NSCP. If you look at under the TI and link worker program, that we all come across with the differential strategy that we put across to reach out to our last mile community member with the TI and link worker scheme, with the close involvement of our community members with respect to regular extending this regular medical checkups, management of STI, RTA, provision of communities, provision of there are drop-in centers where we invite, and also our community members come together, share their feelings together, share their concerns, share their challenges together, and as a collectively we are reaching out to the community and also to the larger populations who are in contact with them. When it comes to HIV testing, that, as you know, with respect to counseling that is being provided through our more than thousands of ICTCs that is there, and also at the community-based screening that is also been given. When it comes to care and support treatment, that free ART medications and also PLHIV support that is being extended to this population. When it comes to advocacy and mainstreaming, that is one of the key important factors that under the National AIDS Control Program that we are looking at to increase the social protections, to increase access of the social protection schemes by our TG and Hijra populations. Along with that, you heard about this, dry ration distribution that has become the one of the most successful schemes that we have, seen in the field that has been reached to the community member, where more than 5 lakhs, more than 6 lakhs population, they are still so far been covered with dry ration distributions during the time of COVID that we have given. Also, with respect to the stigma and discrimination, that is many work that has been going on under the AIDS advocacy mainstreaming front, and also there has been constant engagement with the states with respect to establishment of the TG welfare boards at the state level. So these are the comprehensive approach that has been there for our communities with respect to TG and Hijra populations. Beyond this HIV and AIDS, that we do see when we interact with the community, and the demand that has come from the communities, that is it is truly diverse, that includes health, including the mental health, non-communicable diseases, substance dependency support with respect to alcohol, tobacco, and others. There are also demand with respect to gender, human rights issue. There are demand that has come with respect to extending the welfare schemes to our community member, and also most important the social needs, that is stigma and discriminations, service at the doorstep of the community, and social mainstreaming and reduction on transphobia. These are the different needs that has come out of the discussion, and this is the concern shown by our communities. What NACO really considering into taking it to the next level. So taking into consideration of health needs and non-health needs and other demands from the communities, what NACO are looking at a combination approach, the different strategies that we have adopted. At the one hand, we have collaborated with our partners, our bilateral partners. At the same time, we have taken, NACO has under the support of Global Fund has envisaged many activities to go forward. So, and also the under the revamping activities, as I stated, also discussed yesterday, to reach out to the virtual populations that we have seen, and also it is evident that most of our MSM and also TG populations who are operating virtually, I mean through the different dating platforms and all, we are trying to reach out to them with a specific strategy, and we are trying to reach out to them with a package of services that is tailor-made, and also that again build on the demands of the communities. At the same time, NACO, what we were looking at, providing the integrated package of services for the transgender community, where all the unmet needs that has been raised by the community that will be taken into consideration while farming of this package of services that includes mental health, that includes other social entitlements, that includes other health measures that required at the community level. At the same time, what are we looking at? The setting of the one-stop center. The one-stop center basically that we are envisaged to have it at the community settings. We have discussed yesterday about the Sampurna Sarika scheme. That is basically at the facility level where NACO facilities have, like ICTCs or DSRC, where we are going to have. But this one-stop center that will be based at the community level, and we are looking at to have it. I mean, for the TG, Hijra populations, IDUs, and other key populations, and exclusively that we are trying to provide the clinical services, behavioral services, other support services, and linkages to other government and other schemes that exist in different states. At the same way, we are expecting the increasing participation of the communities with the approach of community system strengthening, where we are trying to reach out all the districts and also trying to build the capacity of the communities with different aspects as per the need and as per the mapping of the needs of the capacity needs of the communities. At the same time, also NACO that looking at setting up the gender affirmation care center with the aims, the discussion and everything that has already been, and we are in the process of having this center at AIMS as the tertiary center. And with respect to the revision of medical curriculum, NACO already in discussion with the National Medical Council Commission. So this engagement is on. At the same time, NACO also looking at collaborating with different professional bodies at global and Indian level, like WPATH and ATHI, where we will be taking the feedbacks and the different global standards that is there, and how we can make it a tailor-made with respect to the Indian Indian standard, and bring it to the form of having it in the national level. So this is already I spoken about one-stop center. That is again with the support of the Global Fund that we are having, and especially with respect to the different services that includes but not limited to HIV screening, that going extend again the linkages for treatment and prevention services, and also to extend the social support to the communities at large. When it comes to the participation of our communities under the NSCP, as we all know, and also been a part of the planning, implementation, review, and evaluation of the NSCP program, and we have received the enormous support from our community, and with the support of community and constant engagement, we have reached the nearest milestone of the era. And also there have been member of the technical issues group and also technical working groups of NACO. There have been the member of the community advisory board at the district level. And also we are expecting the larger community engagements with respect to implementing the interventions through the community-based organizations that we are looking at. So these are the kind of avenues where closely we have received the feedbacks, the valuable feedbacks of the community, and NACO moving forward with the help and the support of the communities, bilateral partners, and we are looking forward to a greater participation, and also looking forward to better increasing access to services to the communities. Thank you so much. This is from our side. Thank you, sir. Thank you so much.
Thank you. Yeah, I think the questions we will take at the end from the audience. So I think we can move ahead, Dr. Saranjeev.
Thank you,
Yes,
sir. Thank you so much.
Thank you.
So I think now we can go to the second speaker. We have Ms. Karthika Pillai. She is Senior State Coordinator in the Project Management Unit of the Ministry of Social Justice and Empowerment. And she specializes on policy development and evaluation. And she has also represented India in the UNODC Youth Forum in 2021. So as I mentioned in my initial remarks, that Ministry of Social Justice has been launched the SMILE scheme focusing on the transgender welfare, and also the act has to be implemented in the state. So we'd like to hear from her the work that has been initiated by the ministry and the way forward. So Ms. Karthika, over to you.
Thank you so much, sir. I will be sharing my screen. I am not able to share my screen because someone else is sharing right now. Yeah, thanks. Just a second. Okay, so today I will be talking about Transgender Persons Act 2019 and the scheme which has been launched for the transgender persons. So according to the Transgender Persons Act 2019, Section 15, it was mentioned that the government has to set up serosurveillance centers, medical care facilities have to be set up for the gender reaffirmation surgeries that transgender persons sometimes go through. And we also had to ensure that there was before and after procedures, because gender reaffirmation surgery in itself is not the only thing that has to be done. We also have to ensure that there is post-operative care that has been given to them or pre-counseling that has to be given to them. So all these things had to be ensured. It was also mentioned in the Act that a health manual related to sex reassignment surgery also has to be created. Apart from that, different ministries and different departments were also asked to create medical curriculum and for research for doctors. And it was also mentioned that they have to facilitate transgender persons in hospitals and other healthcare related institutions. Provision for coverage of medical expenses in terms of insurance or any other scheme had also needed to be created according to the Transgender Persons Act. So based on all of these points, the Ministry of Social Justice and Empowerment recently launched a new scheme named Support for Marginalized Individuals, Livelihood and Enterprise. In short, it is known as SMILE scheme, under which there are two components. One is for the rehabilitation for welfare of transgender person, and the another component is for persons involved in the act of beggary. So under the comprehensive rehabilitation for welfare of transgender person, the ministry has a national portal. So the national portal acts as an online service center wherein the transgender person can log in and get their own transgender person's identity card and certificate. So this identity card and certificate, which is being issued, is a total online process, and this card has to be there to avail any kind of service under this scheme. So currently all over India, the ministry has issued 5,600 plus certificates and ID cards. And we also have 12 Garima Greh running in the country. So Garima Greh is basically shelter homes for transgender person. It is for their holistic development. Any transgender person in need of care and protection, they can reside there and get an individualized plan for themselves made for their health checkups, skill development, and any other requirement that they might have. So under the SMILE scheme, we have these many components. So the first component is skill development and livelihood, and then we have scholarships. So these two components are actually getting launched on the 15th of March this month. So any transgender person who is interested in availing skill training or financial assistance for studying further, they can apply on the portal. Then we have composite medical health. So composite medical health is basically where the transgender persons are being provided with a health insurance with collaboration with NHA, National Health Authority. I'll discuss about that a little later in my next slide. Then we have Garima Greh, as I previously mentioned. It is shelter homes. It is currently being run in 12 cities all over India. It's pilot. So what the ministry expects in the near future is to have at least one of these shelter homes in all of the states in India. Then we have transgender protection cells. It is for the safety and welfare of the transgender person, as most of the offenses against them do not get submitted or they do not come, they are usually hidden. So what the ministry is trying to ensure is there is at least offices at the state and at the district level that ensures that TG persons, they do not feel left out and their offenses and crimes which are being done against them, it comes to notice and it is resolved. Then we have other welfare measures. Under the other welfare measures, the ministry aims to see proposals from any organization, community members of transgender persons, and states, districts to come up with region-specific proposals, which can be anything, which can be a primary healthcare center or unisex toilets, trans-friendly toilets, which will be totally funded by the ministry. So this is the composite medical health that we are planning to roll out in the coming month. So the procedure for this is, it's a health package in the form of Ayushman Bharat TG. It will be part of Ayushman Bharat Yojana, which is currently being run all over India, PMJ, with NHA. So what we have is there are a comprehensive rehabilitation package already in place. But most of the surgeries that the transgender person might require for gender affirmation, they are not included in that package. So what ministry did was they set up committees and ensured that the well-informed decisions are made based on evidence-based practices, and they constituted few surgeries after also consultation with the TG community, what all they might require to feel comfortable in their own bodies. And we created a package which also consists of cosmetic procedures. Some of the cosmetic procedures such as nose correction and vaginal dilation, prostatectomy, these are not included, and it is also considered to be cosmetic. So we ensured that these are included in the package, and any person can go to any empaneled hospitals of PMJ and get those procedures done. So the beneficiary must have the TG certificate issued from the national portal. It takes about 30 days to get the certificate. It's the maximum time period by which the district authorities have to issue the certificate. So once the TG person has that certificate and identity card, they can visit any of the empaneled hospitals or common service centers, and just with that certificate serial number, they can get their data identified and verified on real-time basis, after which they will be issued with a card. So this card will not only just be a physical card, it will also be provided on their dashboard. So on the national portal, we have a dashboard for each and every applicant, wherein it will be connected with different databases. So in this case, it will be connected with NHA, and they will issue that identity card in their dashboard also virtually. So with this TG card, it is totally cashless treatment. No beneficiary has to give any amount to any hospital. They just have to visit, and they will be provided 5 lakh rupees per annum. It will be individual based entitlement, not family based, which usually PMJ follows. And once they have the treatment ready, whatever treatment that they require, they can go and get it done, and the ministry shall provide the fund for all the treatment to NHA directly. So the features of health component is, we obviously require the TG certificate card, and as we know, the Ayushman Bharat TG card, it is valid all over India. So if a person who resides at Odisha, they can also get any kind of surgeries and procedures done at Delhi also, or any other states or any districts. Currently, there are not a lot of hospitals and healthcare centers which specialize in gender affirmation surgeries. So what the ministry is currently doing is to identify such hospitals who have these features and who have experts from health professionals who are good at gender reaffirmation surgery. As we know, it also requires other specialists such as gynecologists, counselors, psychologists. So there will be a team of people who will work on this specific gender reaffirmation surgeries. It is redeemable at all private and government healthcare facilities. And we will also be providing training to doctors and sensitization of hospitals, because there is still a lot of stigma and discrimination attached, which needs to be looked into. And we are creating a manual for that, so that each and every patient who goes to these hospitals, they are taken care of properly, and without any ostracization, they are able to receive those facilities. We are also trying to empanel as many hospitals as possible where Ayushman Bharat coverage is not present currently, and also help those doctors who are interested in learning about gender reaffirmation surgery to actually learn more about how to conduct these surgeries. So yeah, thank you so much. And this was it from my side for the scheme.
Thank you, Kartika. I think that is very, very informative. And I think since these are very recent development, the audience may have a lot of questions. So we will try to take in questions in the end. But I will now again hand over to the chair for the next speaker.
Yeah. Thank you. Now we will invite Dr. Sangeeta Kaul, who is the Division Chief of in HIV/AIDS Division of USAID India. Welcome, Dr. Sangeeta. Yep. Please proceed.
Thank you, Dr. Chakrapani, and a very good afternoon to all. I will be talking about integrated health service delivery for transgender persons, primarily highlighting the work initiated by USAID along with its implementing partner, Johns Hopkins School of Medicine. Currently, we have two clinics which are fully functional. One is in Hyderabad and the other one is in Thane. Next slide, please. We all know the transgender population in India has the second highest HIV prevalence of 3.14% compared to the other high-risk groups. The vulnerabilities among transgender people around HIV is complex and associated with various socio-economical variants. Gender expression, high-risk sexual behavior, multiple partners, sex work, drug use, lack of acceptance, and social support make transgender people extremely vulnerable. Next slide. We all heard Dr. Shantuni from NACO sharing with us information about the TI approaches for the transgender and HIDRA population. So what we feel that the TG population do have needs other than HIV needs. They have healthcare needs. And in this context, USAID, along with its implementing partner, started the Mitra Clinic that offer HIV and non-HIV services in a non-judgmental and stigma-free environment. Next slide, please. The first comprehensive Mitra Clinic, the Transgender Clinic, was started in Hyderabad in January 2021. This clinic has been functional now for the last 15 months. And the key objective of this clinic is to identify at-risk TG individuals and link them to transgender-specific non-HIV services together with HIV services in the TI and non-TI settings. Next slide, please. The Mitra Clinic has service delivery in a two-pronged approach. The first one is we have very specific activities at the clinic, and the second is a very strong referral system. At the clinic, the services provided are related to health and HIV, gender affirmation, and the most important one is legal and social protection. Next slide, please. The most important aspect of this Mitra Clinic in Hyderabad is that all the service providers are from the TG community, and hence all the clients coming to the clinic feel at home to access these services. Counseling and psychosocial support is one of the key services that is provided, and counseling is provided for HIV, STI counseling, treatment adherence counseling, follow-up for viral load and CD4 tests, general health counseling, as well as peer-based psychosocial support services. Next one. The general health services, as I mentioned earlier, I think the slides, are they visible? Can you see the slides, Dr. Chiranjeev and the team?
No, I think, please share the slides again.
I think the host, the event people are looking at this, yes.
Right.
Okay. Let me go to slide this one. The general health services, as I mentioned, in this clinic we have the doctors from the transgender community, and they provide management for non-medical HIV problems, whether it's hypertension, diabetes, or treatment for other non-communicable diseases. Most of the TGs, they are in need of a range of gender-affirming interventions, both medical and surgical interventions. The medical interventions.
Dr. Call may check with the host again. Karan, what is the issue? Because we cannot see the slides.
Yes, sir. We're just sharing that.
Okay, let me wait for the slides so that you can.
For the benefit of the audience.
Yes. So in the meantime, I can just...
You can try to maybe project the slides from your end, because that is possible, I guess, because you are a panelist.
Okay. Let me try that. Can you see it now?
Yes. Yeah.
Yes, ma'am.
Okay, great. So I was talking about the gender-affirming medical services, which most of the TGs, they need either a surgical treatment, whether it is bottom surgery or top surgery, facial hair removal, interventions for modification of speech and communication. And all these services are important, but I would like to mention here that in our Mitra clinic, only the medical services are provided. Medication and management of hormone replacement therapy is provided, and guidance and support, as well as very specific referral for services related to the gender affirmation surgery. Legal and protection services, which I mentioned earlier, are one of the important services which are important for the transgender community, especially to improve the quality of their lives. So at this clinic, legal gender recognition documentation is held for all the clients who come to the clinic, linking with the government schemes, whether it's the Aadhaar card, the health card, or the banking pension. In addition, the clinic also has an outreach component, and during the COVID phase, most of the staff of the clinic were actually spending time distributing food grains to those TG members who were in need for it, and also looked at referral for vocational training with the idea of improving their livelihood options. Now, this slide demonstrates some of the key achievements of the Mitra clinic in Hyderabad. As you can notice that out of 833 TG clients registered at the clinic, 90% of them received sexual health counseling. 63% of them received non-HIV services. And out of 446 TGs who were screened for HIV, 26 screened positive. And out of that, 14 had confirmatory results. And all these 14 newly diagnosed patients were linked with ART Center, and they are currently on treatment. If you look at the HIV positivity in our clinic in the cohort of this TGs whom we screened, it is at 3.1%. Now, in order to increase the footfall to the Mitra clinic, a lot of efforts are needed towards demand generation. And these activities, as you can see in the different pictures in this slide, which have been another important feature of this Mitra clinic. To sum up, the key highlights of the Mitra clinic, the demand generation leads to clients visiting the clinic, and after registration, they are provided with a range of services. Now, we know that it is always important to quantify the key outputs and outcomes of this clinic service delivery model. So data is very meticulously collected at the facility and analyzed at the facility level, the state level, and the national level in order to improve the operations of this clinic. In addition, getting direct feedback from the community is an important monitoring system that is in place at the clinic. Thank you so much. I would request you all to visit the YouTube and search for this Mitra Clinic, Pride and Beyond. It's a documentary film that will give you more information about this clinic. Thank you so much once again. Over to you. Cheers.
Thank you, Dr. Kal. Yeah. Yeah, Dr. Sivanji.
Yeah, thank you, Dr. Chakrapani. And indeed, very informative session from Dr. Kal. And I'm sure in the end we will take up questions. So can we have the screen of the next speaker? Yeah, thank you. So next speaker is Mr. Murugesan Sivasubramanian. He is the project manager in the Humsafar Trust, and we invite him to share the experiences from Humsafar Trust, which they are doing in terms of the virtual interventions for this key population. So Murugesan, over to you. I think he's joining physically.
At the outset, I would like to thank Dr. Kang and Sandeep ji for extending this invitation and allowing me to present from here. This is a presentation that I'm trying to make of the last 1 year that we have done as part of the Global Fund project, where we are trying to have online interventions to reach out to high-risk populations, key populations who are soliciting and finding their sexual partners online. And so I'll try to share some of my experiences and challenges and see how we can try to integrate this in our existing national program. So just a brief about Humsafar Trust. It's a CBO based in Bombay, founded in 1994. We work primarily with LGBT communities and other marginalized populations. Our focus is on health and human rights of the communities. Since we are one of the pioneering ones, we also kind of do a lot of capacity building and mentoring for smaller CBOs across the country. Our work primarily is through 4 different components: health, where we run our TIs and clinic to reach out with prevention and treatment related information, messages and services in Bombay. Advocacy, because we work with LGBTQ rights, and now we're also working with female sex workers populations. We feel that human rights of this community should also be addressed, and so that is also part of our program. Capacity building, as I mentioned, because it's all about trial and error, and we also need to see what's working, what's not working, and how to learn from your previous experiences and strengthen the community-based organizations across the country. Research, we all know it's a key part for any programs, because whatever program is implemented, we need to analyze the data and see how that data findings can be again brought back into the research, can be analyzed and brought back into the program to strengthen the ongoing program. So research and program are kind of an interlinked arms at Humsafar Trust, which we kind of follow very rigorously. This is the first one, where the official launch was done on 25th June 2021. Sri Alok Saxena ji sir was present at the meeting, and with his blessings, we inaugurated the event. We also had Dr. Bilali and Shobhini Rajan and other key members from Alliance also who were present with us at the meeting. So primarily this is looking at 2 goals, but I'm trying to 3 goals, but I'm just focusing on the virtual intervention part, where the focus is on, because we know that so the title that we're trying to work is on reaching the missing millions. I know yesterday Shantanu also presented about how there is a lot of gap in the virtual space, and we are not, there's still a long way to go to reach our first target of reaching the first 95. And the second and third 95 are dependent on the first 95. And in that view, we thought that there is a substantial amount of population which is at the virtual interventions or on online, and we need to reach out to them. So in view of that, we have 2 objectives. One is to reach out to them, and second is to link them to screening. So it could be at the private healthcare sector or at the government healthcare sector. But given that this is a program that's closely running with National AIDS program, we try to focus most of our populations to be referred to the nearest ICTC, and also link them to the ITI centers, so that even after the project winds up, we have a more sustained and a continued approach, sustainable approach for the services to be provided to the committee members. So this is a pictorial one where we're trying to show that at the ground level, you see a lot of virtual outreach activities. We have virtual navigators who are present at each of the states. So this is a very low resource constraint project. We have only one virtual navigator across one state, so that he can reach out to as many as much populations and motivate them for HIV testing. Once the rapport is built and we are able to reach out to the communities, we provide them with e-referrals, and which they kind of again go back to the nearest ICTC center, and they come back with the referrals, and we follow them up for the results and linkages with CBOs. This will be further more clear when I show in the next slides. But as the one of the core layer at the ground root is about virtual activities. The second one is about building private support, because some of the committee members at the virtual population may not be comfortable to go to an ICTC center or an FICT center. So we also think that private labs and private doctors do play a key role, and we need to strengthen them in this work. And one of the major things, because it's a virtual intervention, the behavior online BCC or social media campaigns do really a key play a role, as they are the ones, the messages are the ones who are going to drive the testing and build the rapport for us on the online spaces. So this is a pictorial presentation. The package that we were just, Shantanu also referred to in the previous slide, about how there are different intervention packages, which includes SRH referrals, BCC. The 1097 is one of the key factor where we refer most of our people, if they need any more further support to the national helpline, HIV PrEP, STI testing facilities. Apart from that, we also are focusing on counseling, mental health, crisis-related support services, social entitlements, skills, and livelihood linkages. So this is just a pictorial representation where across the different states, we have one navigator each. So we have 20 navigators in the country. Our head office is based in Bombay, and we have 4 regions through which, so the head office in Bombay, we have 4 regions and 4, there's a state unit in each of the in each regions who then kind of run the operations in each of the states. So what we do is whenever a virtual navigator goes onto a dating app or on an app, he builds a rapport. He tries to talk to them. He informs that he's from the project and he's here to talk about HIV, AIDS, STIs, PrEP, and other innovative methods that we have for HIV prevention and treatment. Once that's done, we do his HIV risk assessment, and then UID is generated for each of the client, and they are referred to the nearest testing centers, both private and public, or government, whichever he feels comfortable. He connects with the service provider, and then we talk to the client whether he's been able to reach to the success services, what has been his feedback, was he able to get the quality services that was intended to, and we also try to we ask him to, if he's comfortable, then we ask him to share his results, because in the current scenario we cannot ask directly to the counselors because of the HIV/AIDS Act. So we ask the clients to, if they're comfortable to share the results, so that, if they're positive, we can link them to the HIV treatment-related services and facilities. So this is just a center, this is like an Instagram page where we have the logo and where we talk about the different services. The contact number of the virtual navigator is given. And this is where I think what Sandeep ji was mentioning yesterday, that should we give a project phone number or a, personal phone number. So we have in our project managed to give them a project phone number so that, the client's identity is protected, and, so that he knows this is the official phone, so that he also can maintain as he can attend to it whenever during his office working hours. So this is just a slip that we kind of give as a e-referral, because in TIS we have a hard copy, but in here we either give them on the dating apps or we give them on the WhatsApp where we connect, and this then show to the ICTC counselors. So then we also build parallelly work with SACs and different ICTC counselors to accept this as a referral mode, and put them in the registers as one of the NetReach clients. And we do not ask for to share the results, but the PID number, so that we know that this client has actually converted into a successful referrals, because we do not have any clinics of our own apart from Bombay. So we primarily link them to the existing government facilities or to the TI centers. Communication strategy is one of the key backbone of the services. We are developing a communication framework. Towards the end of the month, we will have a 3-day workshop focusing on the different themes, messages, platforms, which needs to be identified and mapped to talk about the HIV prevention messages in different social media. This is just a glimpse of what I was showing, that because we primarily began with working with MSM, and the apps are more focused for MSM dating population. That's why you see a larger population tilting towards Planet Romeo, Blue Grinder, where others are, very less. But I think as we are going on, we are trying to explore other options. Some of them are paid, so we are also trying to buy subscriptions and see how we can navigate these apps. Just a glimpse of the population that we have reached. We have reached up to around 82,750 in the last 10 months. We have risk assessed around 30% of them, of which around 27 have gone for testing. We have a total positivity rate of 4.5 in the entire project status. The only thing is, out of the people who have positive of the 98, only 42 have shared the results. So we are trying to talk to them, and also trying to talk to SACs, if they can help us validate the numbers, so that, or maybe make personal visits to ICTCs and see if, their linkage status can be kind of validated. And as I said, that 75% of the testing has been at the government space, and 25% has been the private space. So just to talk about it, I'll just talk a little more. I know the session is on MSM and TG, but we also are working with female sex worker populations, and we do realize that different populations need different virtual interventions or different virtual approaches. For female sex workers, we are working with spas, outreach. We are doing outreach on WhatsApp, and specific apps, where female sex workers can be could be traced or could be found, and we could talk to them. We are also looking at women in high risk behavior. They need not be female sex workers, but women in high risk behavior is also another key typology that we are trying to look at. MSM, we are trying to reach through parties, social groups, and referrals. With TGs, what we have been able to find is, when we talk to them what HIV-related messages, they come back to us and they say that, can you help us with the ID cards? Can you help us with the social entitlement services? Can you help us with some ration support, or some more topics on feminization and other supports, and other gender affirming hormone therapy. So we do refer them to like what Sangeeta just mentioned in the last week. If they're in Hyderabad, in Bombay, we refer them there. I know Pune also, they're doing some work, and we're also referring them to the government hospitals to see that they can get the best services available for them. Just the last slide on innovation challenges. So, with the apps, we are able to use apps to go beyond the certain locations. So we are also trying to training some of the SACs and the outreach workers also on how to use fake GPS to reach out to. So now I'm in Chandigarh, I can move my app to Goa and see who all are in Goa and push my messages in Goa. We are exploring social media interventions. Now Instagram Reels and other social medias have come up. So how to mobilize with them. We are networking with different partners who are working in the same field, on the same area. And we are looking forward, because we are a community-based organization. So most of our focus remains on using community as a resource, and as a resource to reach out to the key populations in social media. Challenges, because it's a site, it's mostly an act. If we keep talking about messages, they block you. So that becomes a problem. Grindr takes you off. We also need to see whether, because it's an e-referral and it's only one person, one state, how do you physically ensure that they have actually reached, if they don't give the PID numbers? So that becomes like a loss to follow up for us. We are talking to NACO and seeing that can we be part of the SOAP system, so that, the ICTC counselors can take us more seriously, or, and put that in and enter that in the database, so that at the end of the day, we know that so many referrals has been part of this data system. And I just mentioned that how we need to talk to TGs on HIV messages, and also address their other unmet needs that's kind of important for them. With this, thank you for this opportunity. Thank you so much.
Thank you, Murugeshan, for this nice presentation. We would also request our audiences to please post your questions in the Q&A box, because after this presentation, we will be able to take a couple of questions. So now for the last one, I hand over to Dr. Chakrapani.
Yeah, thank you. Now we welcome Ms. Jaina Patel, who is a well-known activist. She was one of the petitioners in the famous Nalsa case judgment, and she has 20 years of national and international work experience. And she I think she also currently works with KPMG as Director Diversity and Inclusion. Welcome, Jaina.
Thank you, Venki. With just one correction, I don't work with KPMG anymore.
Okay.
I can't. So thank you for someone who is making my presentation, who's going to be rolling out the slides of my presentation. I'm going to be quick in interest of time because it's already 2:40 and I'll reduce my speaker time to about 5 to 6 minutes instead of 10 so that we can still take questions and it doesn't spill over. So I'm going to be talking about basically what are some of the approaches, what are some of the principles, basing it on what I have understood in working on the last 3 phases of NACP in terms of health interventions and how do we build on community participation. And I am, talking of it from a very specific perspective of health for all. Health for all also means the communities at risk, they prioritize decision, they prioritize how efficient or effective services will be. And the next slide, please. So, for me, the context was basing that we've come to the 45th anniversary of the Alma Ata Declaration. And what does this say? It says that health is for all. And it is not saying that health is only for general community or health is for specialized group. It says health for all. And that's where the importance of community-based participation and community-led participation to make health systems intervention successful. And I think the core crux of it is 3 things: engagement, accountability, and resilience. So if you're talking about community engagement, most of our interventions are geared towards looking at community engagement because ultimately our outreach, our loss to follow up, our gains, the way we kind of look at performance bonding, it's all on community engagement. But how much of emphasis are we now going to be putting at accountability and resilience building, especially from the context of what the last 2.5 years of COVID has actually taught us? This from a perspective is very important as we shape whether it's Suraksha Safar, etc., or the one-stop crisis center that that we look at, or the MOSJ SMILE scheme. Accountability and resilience building is actually, and for me now it is no longer a beneficiary or a provider-led initiative. To the other speakers in the session also we talked about, is there is a huge paradigm shift for a systemic approach for community health. Next slide, please. So I am going to be not going through in detail, but I'm going to ask you one question for your reflection. So for any intervention that has been planned, what are the systemic changes that are missing? I think Murgesh, my previous speaker, spoke of a very important component, the component of targeting people with too many messages, looking at what the systemic requirement around dating websites or apps is. The moment you hit with too many messages, there is automatically a system ban or a system block to your messages. If there are other components, like for example, the transgender community, we may look at non-HIV services, prioritizing that. And I think Dr. Sangeeta also in her presentation on the transgender clinic mentioned that. And for me, when I look at community empowerment, for me, it is something that we define as, and when I say we, I represent another organization called the National Network for Transgender People. It is something that it makes us stronger, more confident to take controls of our lives. So whether it is changes in the social environment in the agencies that are targeting, so to develop resilient health systems. The next slide, please. And this, of course, tying into the larger goals of sustainable development goals. So, I mean, I don't need to talk about this, but basically this diagram is self-explanatory. So whether you're looking at the hard components of financing, commodities, diagnostic tools, equipment, and health, all of these are facilitated essentially through your community health system sending and participation in health interventions. And what are the soft components that are probably being missed out or not looked at effectively is whether our policies, whether they are human resources policies or organizational development policies, are they actually community friendly and inclusive, or are they actually exclusive by design or by intent? What are the payment mechanisms that we're looking at? Are these really truly integrated? Some of the quality around issues, and how do we engage the private sector? The next slide, please. So for me, when we were asked this one question is, what is the community role in health systems or health interventions, and how do we strengthen this? So for me, it is about being valued, about being taught as essential and empowered actors. We are not looking at a provider initiated approach. We are seeing how communities can be made more resilient. And most importantly is, how do I work on the accountability? And if you actually go, and most importantly for me, it is providing voice for those who are currently voiceless. So for example, if I belong to the transgender community, the transgender community is not a homogeneous mixture. It's extremely heterogeneous, as people around you are. And when I say heterogeneous, what do I mean? There are people from that someone who might believe from the transgender Hijra community. We are known to be pretty articulate and loud in terms of when we not. But the same cannot be said for a gender non-conforming person or a non-binary person or a trans-masculine person for that matter. How are we going to be looking at accountability of the entire system? And I'll give you one small example, and Kartika would probably relate to that. When we were doing some of the translations with regard to the smile scheme, and we talked about for Tamil Nadu and doing the translations in Tamil, the word trans is accidentally only kind of translated as Aravani. So the other people who are not Aravani based identities are now questioning, are we out of the ambit? So while this can only be a translation error or in terms of perception error, so this is again putting the focus back on accountability at both ends. May I request the next slide? If you actually go to the next slide, so that there is something for me to talk about. So for me, the essence of multi-stakeholder and multi-sectoral partnerships are very important. Dr. Venki has always been championing for multi-sectoral and multi-sectoral and multi-stakeholder approaches. UNDP, and in my own previous role at UNDP, and the current interventions that is being very ably run by Dr. Chiranjeev is all about multi-sectorality. And today, I think by giving voices like me and organizations and network at this platform, it's only determining the person who has a seat on the table also determines to require attention. The last slide. Next slide, please. Again, I would like to focus on, it's not only enough to have tokenistic representation. How do we kind of look at equity and accountability? Now, very big terms. And sometimes we use equality for equity and equity for equality, thinking that we all mean the same kind of language. Unfortunately, it is not. And for me, it is very essential to kind of talk about. I wish I could talk into more detail, but in interest of time, I just have one more slide. Please go to the last slide of my presentation. Not this one, the next one. Like, for example, I also want to talk about how in the recent past, when there were drugs shortages around ART, a lot of community people shot videos, highlighted the issue, and they were extremely instrumental in making sure that a continuous supply of ART. So while the government and their stakeholders did their own jig in terms of ensuring supply, but the demand creation and demand monitoring has to be handed over. And I must say, a large portion of it goes to all the network of positive people, including the National Council, the NCPI. And I had the good pleasure of working with them. So the kind of vigilance they kind of put in was extremely important. And the last slide is what I wanted to introduce is the National Network for Transgender Persons. This is a network of more than 98 CBOs across India, where we are kind of looking at bringing them together. These are people who have either trans-led or trans-owned NGOs and CBOs, or have a significant component. Now, it is an informal network currently because we do not have registration status. We have put in our papers to get it registered as a society in New Delhi. Hopefully, looking at the current caseload and COVID management, it might take 3 to 4 months. So who does it consist of? It consists the entire plethora. We have people who are with intersex conditions. We have trans-masculine people, trans-feminine people, and people who belong to the Hijra Kinder community. Thank you, and I will take questions towards the end if there are any.
Thank you very much, Jaina. Yeah, so of course you highlighted the central role of communities in any kind of interventions or programs. So now I think I'm not sure like whether we have any questions from the audience. I'm not seeing any questions. And also considering the time, I think we are supposed to close in 1 minute. So maybe I will request maybe we can just maybe summarize. Like I would request my co-chair to give his maybe like closing comments, and then I will also then give mine, and then we can close. Thanking everyone. Yeah.
Thank
Dr.
you.
Saranjeev.
Yeah, thank you, Dr. Chakapani. So I think we had a series of very well-informed and informative sessions covering a spectrum of issues, right from the interventions from the ministry and involvement of community. So 2-3 key points which I would like to make is, of course, as I made in my initial inputs, that the basket of services has to be holistic to achieve our goal of prevention and control of HIV. So in that direction, especially for the transgender community, we have begun with the SMILE scheme. So I see, and I think Kartika will appreciate the fact that in terms of working with the community and having different community-led intervention and having good experience, the HIV program has got very good learnings over the years. So I think we as a UN agency see a strong convergence between this government organization and this government program for the effective implementation of the SMILE scheme, and as has been the learning from our HIV response. For any success, the community should be at the forefront, and they should be leading the intervention, and as has been rightly mentioned by Janab. So I think overall, my opinion is we are moving in the right direction, and once we all stakeholders work together, we'll reach our goal of ending HIV as a public health problem, as well as providing holistic health services to the community. So I will stop here and I will hand over back to the chair, Dr. Chakra.
Yeah. Thank you. I think I just have maybe 2 or 3 points from the, I think the NACO's presentation obviously shows increasing coverage of MSM and trans feminine people. My only little comment is about the denominator taken for the coverage of trans people, because that was based upon, I think, 17 or 18 states, not on the entire India. So maybe Dr. Santanu, maybe if I'm wrong, like I can correct, but that's what I think. That is one, thinking about the denominator for coverage for trans feminine people. And of course, in the talk of Murugesh, we understand that the virtual interventions, they have the potential to reach unreached MSM who are not maybe a part of the targeted intervention programs. And from Dr. Kaul's speech, we can see that Mithra clinic model supported by USAID seems promising, that it is community owned and community run and potentially maybe scalable. So I think those are the key points which I would like to say. And I think because there are no other questions and because of lack of time, I think we thank both co-chair and me. We thank all the speakers of the session. Thank you very much for your wonderful presentation, and thank you for being here. And we also thank the organizers, both Chandigarh SACS and also NACO. Yeah, thank you very much.
Thank you, Dr. Venkatesh. Thank you very much. And thank you, Dr. Charanjeevi. Thank you for being with us and chairing and co-chairing this session. Thank you once again. Moving on to our next session, session 11, Prevention Issues Focusing Key Population. It's an honor to invite Dr. Shobni Rajan, Deputy Director General TI and BSc Division, NACO, New Delhi. Dr. Rajat Adhikari, National Professional Officer, Prevention Research and SIMNE for HIV, Hepatitis and STI, WHO. Dr. Pushpanjali, Professor, National Institute of Health and Family Welfare. Dr. Murugesh from Humsafar Trust to chair and co-chair the session. I welcome you all on behalf of Chandigarh State AIDS Control Society and hand over the session to you now. Thank you. I hope our co-chairs and chairs are in place. Can you hear me, Dr. Rajat?
We can hear you. Yeah.
Right. Then handing over the session to you, Dr. Rajat. Thank you very much.
So I don't know whether Dr. Shobini ma'am, she's there. Then I think I will.
She's going to join us very soon. She's online, but I think she has some problem, and she's going to join us. Don't worry. So I think you take the lead and start the session, please. Thank you.
Okay. So anyway, good afternoon to everyone, and I think also to my co-chairs, Dr. Pushpanjali Swain and also Murugesh, our favorite.
Murugesh sir is here with us physically. So once again, I welcome him.
Yeah. Okay. So,
thank you.
So I think this is going to be a very important session because our focus is on key populations. So in fact, I will just say that maybe I will give Dr. Swain and Murugesh to just give few words, and then we can move to the first presenter. So Dr. Swain, to you. Thank you.
Yeah. Good afternoon to all of you. And I would be, I'm very happy that SACS has, like, they have invited me, and AIDSCON has invited me, and then I am quite happy to have these sessions because this is a prevention and issues focusing key populations, and I look forward for all the presentations. Thank you.
Thank you, Dr. Swain. Murugesh, few words quickly.
Thank you, sir. I think it's really an important session because we have been discussing about how to reach out to different populations, from yesterday, and one of the key topic has been also how to reach out to the first 95, and especially among key populations. So I think it's a very interesting topic, and we have a power-packed, panel from Dr. Vijay Shruta, and Dr. Tilan Prasad and Kannan, who will take us to different to their presentations and focus on the issues that we can, or the interventions that we can plan, so that we can have multiple innovative technologies to reach out to the key populations. So yeah, thank you, sir. Over to you.
Yes, thank you, Murugesh. I think because we have limited time, so we'll directly go to our first speaker. But as you rightly said, we have champion Shruta, then we have so much experience, Dr. Tilan Prasad, and also we have from Prath, Kannan. So first, I think Dr. Vijay, to you. I'm just calling you Dr. Vijay, and please go ahead with your presentation. Thank you.
Thank you. Once again, thank you to the organizers, Chandigarh SACS and NACO, for this opportunity to present my ideas about. Are you going to advance my slides, or would you like me to do it?
So we will change the slides, sir.
Okay, so let's go to the next slide. So what I want to spend a few minutes talking about is the fact that although we have done a lot of work, we have 2.35 million PRHIV and millions more affected by the epidemic. Progress over the last 3 decades has demonstrated commendable performance by the public health policies spearheaded by NACO. And this is particularly impressive looking at not only the magnitude of the numbers, but the spatial geographic diversity of India, which really is something incredible. There is no other parallel anywhere on earth. When we talk about comparisons between India, one has to compare the rest of the world with India, because India is really truly not just a country, but it's a continent. So many different states, so many different geographies, so many different cultures and administrative areas. So, but what I'd like to say is that behind all of the very impressive aggregate statistics are millions of individuals and families and communities with hopes and fears, desires for basic needs that cannot be ignored. So this time I would like to propose that there is a really different paradigm that we call salutogenesis, first proposed by Aaron Antonovsky. And that is really a path towards a purposeful life with autonomy and dignity for all. So there's a lot more about salutogenesis on my YouTube channel, which is here in the slide. So you're welcome to spend a lot more time on that. Next slide, please. So the response to HIV/AIDS in India really started in 1986. So as we can see, from NACP 1 to NACP 2, 3, and 4, we have made a tremendous amount of progress. Establishment of NACO and SACS, and the amount of voluntary counseling and testing centers, STI clinics that were there that we saw, and then a massive scale up to 50% reduction in new infections. And then again, by the time we get to NACP 4, we see a 37% decline in new infections and a 66% decline in death. This is a truly incredible statistic, unparalleled in the annals of public health anywhere on earth. I challenge anybody to show me this kind of an impact in a public health program anywhere on earth. Next slide, please. So in NACP 5, we are focusing now a lot more on information, education, communication, a lot of different things that you already have heard about, previous speakers talking about using different platforms to communicate, a lot of effort in prevention, a lot of community-based organizations are involved now. Early detection, we have increased the amount of testing for a lot of at-risk population. We currently have 14.8 lakh people on ART. We are managing comorbidities and opportunistic infections, and we are doing viral load testing. We have transitioned to using viral load measurements as the cornerstone of our metric for looking at effectiveness of the entire epidemic management strategy. Next slide, please. So the accomplishments are truly incredible when we come to think of it, because you must put this in perspective as to what has been done throughout the rest of the world and what has happened in India in a much, much shorter time frame. It's really telescope. And the amount of accomplishment considering India's diversity of geography and culture is nothing short of incredible. So we are on track to attain 95% reductions in new HIV infections. We've got a massive scale up of HIV prevention testing, more than 34,000 testing centers, 1,900 ART centers, 1,400 targeted interventions, viral load testing through 64 high throughput molecular labs, 4 million high-risk groups, and around 1.5 million PLHIVs being tested. Free standardized antiretroviral therapy for all PLHIV and comprehensive management of opportunistic infections, and now transitioning towards state-of-the-art in-seed anchored regimens like the Lutic. Next slide, please. So the accomplishments, again, this concerted effort have impacted the epidemic and resulted in a major reduction in the number of AIDS-related annual deaths. So 48% decline in new infections, 66% decline in AIDS-related deaths. And even among the key populations, prevalence HIV down from 2.7 to 1.5% in FSWs, from 4.4% down to 2.6% in MSMs, down from 7.1% to 6.2% in IVDUs, down from 8.8% to 3.1% in transgender people. So by September 2021, 14.1 lakh people are on antiretroviral therapy. So really, India has transitioned very, very fast from taking HIV from being a virtual death sentence to a chronic manageable disease due to ART. These are incredible accomplishments for a country like India, nothing to sneeze at. Next slide, please. What are the current challenges? Well, the burden is still substantial. We still have 2.35 million PLHIV. We do need to have prevention, testing, treatment services, because we have, for all of the PLHIV, we also have a lot of other people who are impacted, who are at risk, and we need to factor in vulnerable populations that are at risk for getting infected. So we estimate that maybe we need to reach out to maybe another 80 million people to ensure that we are on track to end HIV as a public health epidemic. We have full access to ART, but despite free ART, we do need some more improvement in the uptake to ART. We do acknowledge that there are a segment of people who have logistical issues and other issues and difficulties accessing clinics. We do need to ensure uninterrupted service and supply of ART and viral load testing. As you know, recent COVID pandemic severely tested our capability in delivering on that. The presence of HIV/AIDS-related stigma and discrimination have been reduced. Now, I talk about this in a 30-year perspective. When I first came to India, the scene was entirely different. So compared to that, today, it's a whole lot better. But we still have work to do. There are miles to go. We still need to work hard on the vulnerable population. We need to make sure that exclusion, marginalization, stigmatization is eliminated. Not only for HIV, I think this applies just as well to many other things, particularly tuberculosis. So as a general paradigm, we in the healthcare systems professionals have a lot of work to do in this area. Now, scale up has improved access to services, but quality and sustainability is another imperative that we really need to look at and focus some more energy on. Next slide, please. So the current challenges ahead in India. Well, although ART has substantially reduced morbidity and mortality, we still have to address the HIV-related cardiometabolic disorders, in particular hypertension and diabetes. Now, what's happening is that the HIV epidemic has simply been superimposed on another epidemic in India, which is metabolic syndrome, the increasing incidence of diabetes, hypertension, and related disorders. HIV simply makes things a whole lot worse. So PLHIV have a higher risk of non-communicable diseases because of HIV-related immunosuppression. Now, although we have managed to reduce mortality, we have to acknowledge that many of our PLHIV are growing older, and along with that increasing age, we are seeing the consequences of chronic HIV-related inflammation in addition to all the other risk factors. So in India, we see prevalence of hypertension 21.2%, hyperlipidemia at 22.2%, hypertriglyceridemia at 27.2%, obesity at 7.8%, depression, awesome, 24.4%. That's an incredibly large number. Cervical cancer, 1.7%, diabetes, 18%. So the problem is that all of this multiple causes of morbidity in PLHIV is very complex. It's far more complex and far more challenging than in anybody else. So we see that about 47.7% of PLHIV have multiple other areas of morbidity, and a little less than half still have significant opportunistic infections. Now, some of the problems that were really severe problems, and particularly with legacy regimens that were anchored on nucleoside analog inhibitors, acute to life-threatening chronic conditions, anemia, skin rash, hypertriglyceridemia, hepatitis, peripheral neuropathies, those have been reduced in prevalence and intensity due to the much safer, better therapeutic index, advanced regimens that we use today, particularly the dolutegravir anchored regimens. So we have seen some increase in mortality and morbidity due to co-infections, and also the morbidities of the non-communicable diseases. So we really think that we need to focus a lot more attention on PLHIV being tested for related comorbidities, co-infections. But most importantly, we need to emphasize this: PLHIV deserve to be treated with dignity. Next slide, please. So the barriers, what are the barriers? The treatment centers are providing care, but they are not fully equipped to provide a comprehensive range of care to manage coexisting co-infections and comorbidities such as non-communicable diseases and even adverse drug reactions due to all of the medications that people take. Not just antiretrovirals, but PLHIV, remember, take a lot of other medications as well. And we need to address all of this. The current approach does not factor in socioeconomic determinants of health, such as livelihood, family support structures, etc. This is not to minimize the tremendous work done by many NGOs in this area. I'm talking primarily of our public sector ART centers. Now, each ART center has a medical officer, nurse, a counselor, laboratory technician. However, the treatment are primarily still focused on provision of ART and some specific preventive measures for opportunistic infections. by and large, in too many ART centers, we get the feeling that a lot of the work that we do, the interventions for PLHIV, becomes somewhat impersonal and somewhat transactional. Can't really blame them. A very high volume of patient load leaves very little resource available to address anything more than meeting prescribed targets that are anchored in narrow numerical goals, for example, a goal of 95, 95, 95. So everybody is fixated on these metrics. So it's like processing people rather than taking care of people. Next slide, please. So the future, the way forward, I think, is to think about building capacity of ART centers and personnel to empower them towards a paradigm of salutogenesis. Like I said, this is something that Aaron Antonovsky looked at and first articulated many, many decades ago. So what we need to do is build the capacity of ART personnel on integrated, comprehensive clinical management, including the non-communicable diseases and adverse drug reactions, by integrating social determinants of health with all of the medical interventions. We need to educate the support structures like family and friends to care for PLHIV and provide information related to social programs that are provided by the government and also many NGOs, because they participate mightily in the care and help that is provided to PLHIV. And, again, I want to reiterate the tremendous work done by many NGOs during the COVID pandemic to ensure that PLHIV got necessary services. We also need to explore technology in virtual capacity building initiative. This is something like the eNischit platform that Share India uses to help people manage complex cases of HIV, including HIV and tuberculosis. Telemedicine support that we provide through eNischit. And as we have seen during the COVID pandemic, many providers started using telemedicine much more effectively. And this is a great technological tool that we need to see better use of. We need to strengthen and ensure a protective legal and policy environment that provides non-stigmatization, non-discrimination, and a proper alignment with the human rights framework. So we need to design and implement programs and policies with a meaningful involvement of PLHI. And many of our NGOs, you have heard during this conference, have presented their work and how they have involved communities in this endeavor. Next slide, please. So what I'm saying is that we need to now move from looking at just mere aggregate statistics to the individual humanity of PLHI. So the current focus, which, like I said, is anchored in some prescriptive numerical targets like the 95-95, is essential, but not enough. So considering the complexity and requirements of PLHIV, the public health response must focus on ensuring a holistic, comprehensive, inclusive approach that would address the range and health and social issues faced by PLHIV. Acknowledge that every human has fears and hopes and expectations of fulfillment of basic needs that transcend a mere medical need. We do need early screening and better clinical management of hypertension, diabetes, liver disease, chronic kidney disease, cardiovascular disease, alcohol-related diseases, dependence on drugs. All of these things are critical to longevity. But a focus on well-being needs to be participatory. It cannot be transactional. We cannot adopt the attitude that I'm the benefactor, you are the beneficiary, and therefore a transactional relationship is what is required. This is prescriptive. It will not work. We need a non-transactional relationship approach of salutogenesis that results in better health and well-being of each individual. So what is key is mutual respect. This is foundational to the trust of PLHIV that engenders a sense of coherence. Coherence has three essential components. One is comprehension. There is a clear and shared understanding of the complete condition by both the provider and the beneficiary. We look at the capacity of PLHIV to have an ability to cope with the condition. And it's not simply the medical condition.
So I'm sorry, Dr. Vijay, to interrupt you. You have to, I will request you to wrap up your presentation, please. Thank you.
So this is the last slide. So the next concept is capability. And the capability means ability to have a purposeful life with autonomy and dignity. And that was the last slide. Thank you very much for your attention.
Thank you so much. I think because we have very limited time, I think we're running short of time. So may I request Murugesh, if you can introduce or let me request Dr. Swine maybe to introduce next presenter, and then Murugesh, you can do the next one. Thank you.
Yeah. Thank you, the previous speaker. It was a nice presentation. It was giving a lot of insights about that, how the people living with HIV, how they are having some other, non-communicable disease and others. So it was would be now the next speaker would be Miss Sorut Rawat, and she is specialized in MSc Medicine, HIV/AIDS and STI medicine, and then designation is research manager, and currently affiliation is the Humsafar. Over to Dr. Suruta Rawat.
Thank you so much for the warm invitation and the welcome. I look forward to being a part of this presentation. AIDSCON is very, very close to my heart. It's one of the first places where I presented my research studies. And I look forward to sharing some insights from our virtual interventions to very diametrically opposite studies that we are looking at presenting. The first one is 0 meters away, which looks at findings from a cross-sectional India-wide survey of MSM who were reached on online platforms, mainly from Grindr. And I'm going to speak a little bit more about the study. We have titled the study 0 meters away because it's a bit of a catchline from Grindr, one of the most popular gay dating apps used by men who have sex with men in India. And you kind of see something that says, 1 meter away, 200 meters away, 3 kilometers away. So 0 meters away was a bit of a play on that, indicating that we as an organization are always around if you need us. But right now we kind of need your support for some very important questions that we have in the community. So I'm not going to go much into the background, considering that internet has been adequately discussed as an area of focus within our HIV interventions. We know that with the last few years coming in and internet plans and data plans going a lot more cheaper, Android phones becoming a lot more accessible, people have migrated to the internet. It's not that everyone is using the internet all the time, but there is a substantial shift, particularly in populations that are urban, that are younger. And it's important for us to know the community that's out there to be able to reach to them and provide health services, right? So the objectives of our initiative was one, to see whether we could just enroll communities on internet spaces via advertisements, and to understand what are their sexual behaviors, are they getting tested for HIV or not, and what are the different individual factors that are associated with HIV testing. Of course, the study was conducted in 2017. So PrEP at that point of time and even now continues to remain as a key discussion point. So we wanted to understand that these communities online, what is the PrEP awareness and acceptability? Are communities willing to take PrEP? Do they know about PrEP? So yes, these are our objectives in a nutshell. The methods that we implemented, this was conducted around Jan to Feb 2017, was a cross-sectional web-based self-administered survey. The survey was very short. It had around 20 to 25 questions max, took around 5 to 10 minutes to complete, right? It was available in English and Hindi, which kind of works as a plus point, kind of does work as a drawback as well. I'll speak about that a little later. But our eligibility was that these individuals who aspired to answer the survey would need to be self-identified as any of the MSM identities. They could be cis MSM, they could be trans MSM, they needed to be over 18 years of age. They needed to be sexually active with another man in the last 2 years, live in India, not be an immigrant, right? We had a criteria for that as well, and we had questions that kind of picked that up. And how we recruited people were via advertisements, okay, on Facebook, Instagram, and Grindr from Jan to Feb 2017. I'm going to acknowledge the support that we received from Grindr for Equality at this point of time, who gave us free advertisement support across Grindr, right, across all over the country in this duration. And the incentive for participation was not for answering the survey. This was a study that we did with very, very limited budget. So the incentive that we had was basically an online gift card worth INR 1,000 for 10 people who we would select randomly via a raffle. Okay. So the methods and the questions that we had included questions on HIV testing, sexual health behaviors. We asked people about the barriers that they had faced to HIV testing. This was only asked to people, of course, who had never been tested. We asked questions on PrEP awareness, current PrEP use, likelihood of PrEP, and of course, we used multiple logistic regression to figure out the answers. To analyze the answers. So here are some of our recruitment statistics. Bear in mind that this survey was only out there for 1 month, right? Participant had to click on the ad, check whether they wanted to participate, and if they met our eligibility criteria, they would be taken to the entire survey. So we had over 16,000 people who clicked on the survey across India in this 1 month, right? Around a little more than 8,000 really started the survey, okay? Around 8,000 people again consented to participation, around 7,000 met the inclusion criteria, and a little over 4,000 completed the entire survey. So our analysis does, of course, include answers from these 4,000 people. But for people who had partially responded, we did include them in the raffle as well. And if their answers were fine, by more than fine, if they completed certain sections entirely, we've also considered those for analysis. Now I know that this slide is super busy, but I'm going to highlight some of the key features here, particularly with regard to sexual orientation, the age group, right? As well as, their behavioral history as far as sex goes. One is that most people on these platforms have identified as gay, bisexual. There aren't many people who identified with any of the vernacular identities that we have. And around 28% of the population did answer the survey in Hindi. Again, as expected, over half of our population came from metropolitan cities. Some of them were definitely urban, but we have around 20% participation from rural as well as semi-rural areas. Economically, we have a group that is definitely, I would say, be considered as well-earning. Over 40,000 INR per month is what we are looking at. And if you're looking at behavior, 75% had anal sex in the last 6 months. 42% reported, sex like condomless anal sex in the last 6 months, and 40% of people had more than 6 partners in the last 6 months. Right? Substance alcohol use with sex was also very, very high, and only 37% of the population reported access to free HIV testing. Okay, so if you look at the different structural analyses as to what were the different behaviors, we can see that not a lot of people disclose having sex to a doctor, right? Only like if you look at the number of people, only 59% people were out to anybody, which means that we were looking at a closeted group, and the STI diagnosis was pretty high. We've not, of course, asked people for reports, so we understand that this is self-reported at this point of time. So anal sex as well as STI diagnosis in the last 12 months are pretty high. If we look at the results of this in a nutshell, we have 46% of sexually active men from our sample who've never had an HIV test. 47% of these report having condomless anal sex, right? And among these, 25% have been tested more than 12 months ago, which means that the HIV status that they have in mind or they assume themselves to have is probably not correct. So what were the reasons for not testing? Low risk perception, very, very high. They either feel that they do not need to go for an HIV test, they are not at risk for HIV, and that actually comprises over 70% of our population. There is also fear that, hey, listen, I'm scared of an HIV test. And it's again very important to remember that these are they're not one answers. People were allowed to take multiple options. So these could be a combination of reasons. Okay. So for inclusion, so the next section that I'm going to speak about are PrEP questions. For PrEP, we did not consider all of the people. We actually fine-tuned them down to the risk criteria that would put them at high risk, which is basically more than one partner for anal sex, condomless anal sex, STI diagnosis in the last 12 months, or substance use. So the interesting part is out of the 2,400 participants that we categorized within this section, almost 70% were aware of PrEP. And despite of having awareness, right, only 1% was currently using PrEP. So there is, of course, a gap between awareness and use. If we ask people that are they likely to use PrEP, they were like, yes, 61% agreed. And 37% said that they were very, very unlikely to use. Okay, so if we look at the factors that were associated with PrEP use, we look at different factors that contribute to significance, right? One is that if people are out about their sexual identity, if they have access to free HIV testing, and if there is some level of risk perception, people are likely to use PrEP. Okay, again, if their own number of partners are higher, if they are aware of PEP, post-exposure prophylaxis, these are all factors that contribute to likely interest in PrEP. And again, here, if you look at this slide, I think I've kind of titled it wrong. My apologies for that. The population that's indicated here were least likely to use PrEP. So people who identified themselves as bisexual, had education up to middle school, earned less than 10,000 and came from rural areas, did not feel the need to use PrEP. So this gives us an idea of the population profile that might be out there that might need special interventions or information if you look at PrEP use. Now looking at places of delivery.
So Sruta, you need to speed it up because I think
yes, I've got like one slide more before I submit. Okay,
yeah,
so if you look at places of delivery, again, online was preferred as opposed to other sections, but again, this is a multiple choice option. So people might have selected multiple options to go with. So here summarizing is that if you look at HIV testing and if you look at different populations groups, we've definitely reached a different sample. Jahan pe awareness of HIV testing is low, but people are scared. There's low risk perception. There is a fear, and that needs to be addressed. And if we look at PrEP, there is definitely interest. There is definitely acceptability, but we need to scale up our understanding of their risk, their access to services to probably improve PrEP uptake. We have a publication that we've published about this. If anyone's interested, I'll be happy to email the paper. And a big thank you to my team at Humsafar Trust, Dr. Viraj Patel for his guidance, Alpana ma'am as well. And especially thanks to my communities on Grindr for taking the time out to help us with the responses. So this is my current slide. Would we want to move on to the next presentation, which I understand is also mine, or would we want to take some time out?
Thank you, Sruta. I think, okay, so we will move to the next presentation quickly, but maybe, Murugesh, you want to introduce the next presentation topic, please? Thank you.
I think that's Shruta. So, okay, so maybe I can, in the meantime, I wanted if anybody has any question, please put them in the chat box and, we can take them at the end of the presentation. So I think next, I'll invite again Shruta to talk about analyzing area and internet-based e-safe, the group that they have, Yaria. So they have looked at an analysis of that to look at what is the group's HIV prevention, treatment, and access services among MSM and transgender youth in Bombay. So,
Shruta, I have a quick suggestion because you have consecutive 2 presentations and we are also running late. So please, if you can just summarize, maybe in few slides. Thank you.
Thank you, Rajat. I'll try my best to do that. I think it's going to be 2 presentations for the time of 1, but cool. So I'm going to speak about IARIA, which is a social media support group that is managed by the Humsafar Trust. I am one of the founder members. This was started in 2011, managed by a group of support volunteers aged 18 to 28 who look at the group, and it's supposed to be like a virtual safe space for people. And hopefully we should be able to provide insights on why we are looking at IARIA as probably a e-drop-in center for communities going ahead from here. So the reason why we started IARIA was initially that we realized that the current interventions, our current organization does not speak the language of youth. We felt that there was a growing concern around HIV, AIDS, and STIs. So around 10 individuals of us, 18 to 28 years old, identified as lesbian, gay, bisexual, transgender, came together, set up a voluntary group on Facebook where we all would act as admins, and people had access to free posting. The group was initiated in 2011. And as you can see, there have been a number of initiatives undertaken by YARIA that look at HIV/AIDS awareness in particular. We had designed something known as the Kush Pudi, which provided condoms, lubricants, etc. in all one tiny package. The way YARIA functions is, of course, that there is a core team that looks at all of these activities. And the main objective is to provide peer support to people who are hesitant to come in real spaces, which is why the space is virtual. The aim of this activity was to look at how does YARIA function as a support group model, and how does this group facilitate crisis support in particular for its members. What we did was that we used a platform named Grytex, right, to extract all of our data from 2011 to 2016. So this software extracted all of the posts as they were in different content forms, followed by de-identification of all data. Right, it definitely did give us a lot of de-identified data, but in cases where people had used names, it made us do that. There were some 7,000 posts that were extracted during this period, which is very, very active, followed by qualitative analysis of information that we received. So out of around 7,000 posts, we picked up around 700 to look at the different themes of discussion by participants. It's important to bear in mind that all of these 7,000 posts were by people within the group. They weren't by admins. They weren't us talking about things. These were issues brought up by people, right? And as we can see, the most common topics over here were looking at self-esteem, were looking at icebreakers, jokes, and games. It broke my heart a little bit because apart from, all of these conversations, despite all of the efforts that we tried to bring HIV in, it was not one of the top discussion points. So if we look at icebreakers that were there, which was like around 200 threads, most of them were talking about jokes, most of them were talking about games, right? They wanted to talk about Big Boss and who was the next LGBT person in there, and looking at crushes within groups. So it indicates people's connection or need for something that is more lighthearted, right? And the next thing that was around esteem and identity looked at peer support for providing esteem, coming out support, disclosure support. All of these codes that you see here are not verbatim, they're not even de-identified, they're paraphrased. So none of this is really conversations from the group. Okay, so if you look at the themes, again, they range from everything from lighthearted banter to crises, right? And the support that was provided during crisis was sometimes just people wanting to vent, and then people looking for tangential support that looked at connecting to health services, that looked at connecting to living services because they'd been chucked out and all of that. So people, as indicated earlier, direct advice was not something that they were looking at. They were more looking at spaces to vent. So the limitations of our work is that, yes, of course, this is very, very basic. It's just short online posts. We couldn't follow up with any of the members. It's privacy related issues, it's data related issues. So all that we could do was look at the conversations and try to understand what is happening. The sample is relatively small, like out of 7,000 threads over the last 5 years, we picked up only 700, right? And only English posts were analyzed. It's key to remember that there are different conversations happening in different languages. The strengths were that all of these conversations came from community members themselves, right? There were frequent interactions. There was a lot of involvement and participation. So this does indicate that this works as a support group space. People do talk about a lot of things. The only challenge is that they're not talking about HIV, AIDS, and STIs, and not talking about health, which is a reflection point, because if our interventions, look at reaching out to individuals who are seeking this support, it's probably important to include an angle of mental health, include an angle of situations that look at social health support, right? Social support that along with health. So implications of this are that probably looking at online models like YARIA that provide support like this to different individuals, and maybe looking at integrating such models into our existing interventions. And of course, again, the study was supported by the IAS Different Service Delivery Grant that allowed us to look at different service delivery models. We believed Yaya was one of them. My team at Humsafar and Einstein, thank you. The presentation was compiled by Dr. Malika Govindan, who provided us support for analyses as well. And of course, a big gratitude to my family at YARIA and the admins for keeping the space alive. All of this is voluntary effort. So I hope.
Thank you.
Dr.
Thank you,
Rajat, did I meet your
Shruta.
time? Did I meet your time requirements?
Yeah. You are a champion. I think always very popular.
Thank you. Yep.
And we can, Dr. Shobhini ma'am is already there. So ma'am, welcome to you. And I think we will request you to introduce the next presenter. And you are the best person to introduce him. Thank you.
Absolutely. So thanks, Rajat. It is my pleasure to invite Dr. TLN Prasad, who is Director, Government Results Accelerator in Swasti, the Health Catalyst. And Dr. TLN Prasad is my friend from the earlier NACO days, where we used to be part of the STI team. And he holds a specialization in DVL as well as in public health. And his current affiliation is to Swasti, the Health Catalyst, but he has a very long-standing old affiliation to the STI program and to NACO. He has received many awards like the Dr. V. Govindan Nair and Dr. P.S. Ranganathan Memorial Awards during the IASCD and AIDS conferences, the Silver Jubilee Oration, and he continues to be the member of the STI TRG in NACO. And now he's made a name for himself in community systems. So over to you, Dr. Prasad, to speak about partnering with private sector. Why are the linked PL-HIVs getting lost to follow-up? Is there a mistaken interpretation of viral load results by PL-HIVs? If yes, how to address it? Now, that's a long topic, but I'm sure you have your presentation to tell us more about it. Over to you.
Doctor, we can't hear you. I think you are muted. Or you can switch up your video also if you want, because you said that you have some bandwidth issue.
Prasad sir, can you try, please?
Hi, Rajat. Are you able to hear me now?
Yes, we can hear you.
Yes, we can hear you very clear.
Yeah. Thanks, Rajat. So I already shared the presentation. If it is possible, if you can show that, that's nice. Otherwise, what I will do, I will say, I don't know how to show it from my.
So Murugesh, can somebody from there?
Yeah.
Can somebody share his presentation? Dr. Prasad's presentation.
Just a minute, ma'am, please. Just a minute. Thank you.
Yeah, in the meantime, I think, without wasting time, let me see. Since yesterday, we are hearing, different learned speakers talking about the 9090 or 9095 targets, and then where is India and what are the various challenges associated in reaching the last mile. So it is known to everybody, but my apprehension is, apart from the program implementers, does the community aware about this? Does the community understood this message? If they have understood this message, why they are not partnering with us? There is a sizable proportion of the HRGs, whatever name and type we want to say, they are outside the program perspective. Why still this is happening and what needs to be done? I think probably I will take maybe about 5-6 minutes to share my thoughts. And again, I would like to disclose that whatever I'm going to present, these are purely my thoughts, my ideas, and no organization is responsible for that. So I'd like to make it very, very clear.
Ari, don't worry about that at all.
Yeah, yes. So that's the reason I have changed the title also, Dr. Shobhini. So I said that addressing the last mile challenges, some thoughts. And these thoughts are purely mine, as I said in the beginning. Yeah. Next slide, please. May I have the next slide? Yeah. Now we all know what is, just go behind. Previous slide. Previous slide. Yeah. So we all know what is U and U, that is, undetectable virus is equal to untransmissible virus. We also know treatment acts as a prevention, not only improves the quality of the life of the PLHIV and addresses the various opportunistic infections, but then there is also a growing need for the balancing between the prevention and the treatment. Still, in India, the prevalence of the HIV is so minimal. The program has done a fantastic job. Are you able to hear me or not?
I have two numbers.
Yeah. So as a
yes,
result,
Dr. TLM, go ahead.
Yeah.
We can hear you.
Yes. So at the same time, though we need to take care of both the prevention as well as the treatment, they're equally important because treatment makes these people non-infective so that we can curtail the onward transmission. And whereas the focus on the prevention should continue. And I also heard people are saying around 7%, 8% STI in India. And then probably that may not be, I don't know what is the source for that. But if it is so, then probably that is a point of worry also. So again, underscores that the prevention is equally to be important. And at the same time, treatment also need to be given important. If you want to curtail or address in a resource poor country, the treatment part, the more emphasis should be on the prevention so that we'll have a little or negligible or manageable kind of a drug toxicity related issues, drug resistance related issues and all, especially when we are rolling out, self-testing and then pre-exposure prophylaxis. And so when we don't even have the idea how many people are taking them and how many are able to continue and how many are discontinuing and what is their HIV status. So keeping in this, I personally feel that we need to give both importance to prevention as well as treatment. At the same time, more emphasis should be on the prevention. Next slide, please. Now, reaching the unreached. Now, everybody says, there are a lot of population, HRG population, who are beyond the reach of the programs. Now, especially this is true with reference to MSM and TG and IDO. And to some extent, it is not that big problem with FSW. So how do we reach them? And before we talk about reaching about them, and we should also think about why they don't want to partner with us. What is making them not to partner with us? What is that, what the need, which we are not able to provide in the program? So probably, one is, sexual behavior-based segregation of this population. Now, if the end objective is ending the HIV/AIDS problem as a public health problem by 2030, what should be the idea? Anybody with a risk of acquiring or transmitting HIV or STI should be identified and offered treatment at the first point of contact. That should be the motto. Instead of that, we try to segregate them based upon their sexual orientation, sexual behavior, sexual preference. As a result, we are making more and more compartments within the community of the HRG. That itself is leading to lots of conflicts, confusion, diversity. Now that probably is one reason where we are not able to bring the unity. So this is again purely my thought. And then probably I feel that the relevance of this sexual behavior based segregation or sexual orientation based segregation may not be relevant in a program mode when we want to address the onward transmission. Secondly, what is the we say on one hand mainstreaming, but the other hand, all our attempts in the program is a compartmentalization. Now, NCDs, non-communicable diseases like diabetes or hypertension, they are not transmissible through air. HIV also is not transmissible to air, unlike COVID and then tuberculosis. Then why are we segregating them? Why should we require a separate avenue for counseling and testing? Is counseling and testing is not required for diabetes? Is counseling and testing is not required for cancer? Is it not required for hypertension? Is it not required for TB? If that is the case, then why we are segregating and keeping separately a board of ICTC? Probably that itself is stigmatizing the people in accessing the services instead of mainstreaming them. We want these marginalized population, most at-risk population to come into the main society. On the other hand, our design, our strategy, our approach seems to be saying to them not to come. So probably this is another area where we need to look into. And then there is a lot of demand, as others are also saying that we always focused about the HIV counseling and testing and linking to ART, and similarly the STI management, diagnosis and treatment. But these are the two enough to improve the quality of the life of these people? Is there anything else which they want? Is there any value-add services? Can we motivate them to come and join us, to partner into the program? Probably that is the area which we need to look into and then that will also help it. And at the same time, when we are expanding the scope, we also need to ensure the quality of the service delivery, whether it is HIV or STI or any other, for example, NCD screening and subsequently linking them to services or malignancy screening. All these are important, but everywhere there should be a bottom line of quality. Then only the people will appreciate. And we should also consider them as a pool, as a larger society, rather than looking at the minuscule kind of a population. Next slide, please. Now, partnering with the private sector is a very, very important. Way back, almost 10, 15 years back, STA component in the NACO has done lots of models, by partnering with the private sector. And then subsequently, it has been copied by other divisions in the NACO, and subsequently other programs are also. Now, again, NACO is starting to revitalize this concept of partnering with the private sector. That is really very essential and need of the hour. But at the same time, we need to understand private sector is something very, very difficult. I know even in our own national capital, there are different people prescribing different ART regimes other than what national program advises. Now, these are all specialists and super specialists. We can't say anything to them. But if they keep on prescribing the medication, which is not advocated or suggested by the program, then probably the end result will be we are developing a lot of exposure of HIV to the various antiretrovirals, which may become very useless at the time they will be inducted into the program. So this is another thing. So that means there is a need for regularizing the private sector while we try to partner and support the private sector. That is very, very important. Secondly, their capacities also need to be built. Now, many times, different programs keep their draft policies, strategies, guidelines on the website and ask for people to give comments. But nevertheless, none of the people who are experts in the field, they never give any feedback, barring one or two. So probably we need to make sure that they read these, they understand why government saying that the whole country has to follow one guideline to minimize this kind of complications development in future. Probably then for that, one reason could be capacity building, a systematic capacity building of the private sector, private health sector service providers, and so that they'll be able to be much more productive to the program. Lastly, those people who does well, who support to the program, maybe there is a need for recognizing them and then awarding them, so that that becomes a kind of an incentive, and they will take more active interest in partnering with the program. Next slide, please. Now, if you see this, there are many people have said what are the way challenges. So I will also like to summarize. This is a classical slide what Madam Aradhana Jori has presented in 2013, in 2012 in the UNAIDS conference. But then I feel still it is a very, very relevant slide even in the present day. Now there are the three challenges. You see, we require a higher domestic funding, especially towards the IEC. Now everybody says that IEC budget is not like the earlier budget, and probably the IEC, the way it used to be there earlier, it is not seen nowadays. So probably there is a need to look at that. Secondly, we need to also balance prevention and treatment, as we discussed earlier in the beginning itself. Then there is a strong need for convergence with the health systems. After all, NACO takes care of the urban population, which is minuscule of about 20 to 30%. And then again, it is not the entirely under the program, and we only do a limited kind of a thing. So the larger health system like NHM need to be partnered and then to mainstream this. Though this has been articulated for quite some time, nothing seriously has progressed much. Probably in this direction we need to look into, and that will help us. And then the policies, whatever policies we are articulating, they need to be very, very progressive. They need to be instead of looking at the people who are at a high risk for STIs and HIV in a separate way, rather than we should start looking at them as a general population as a mainstream society, so that we'll be able to take them in and then take along them in controlling the epidemic. Lastly and most importantly, sustaining the political will. That is far more important. That gives a confidence to the programs to go ahead with full energy and motivation, without fear and apprehension that the program may get closed or something like that. So we keep on saying, but then if it comes from the mouths of the stalwarts, the politicians, the parliamentarians, and from the government itself, that will be very, very good. So these are the important ways and the challenges which I see, which are very, very relevant even in 2022. And then probably this is left to the cognizance of the leadership at the NACO. I'm sure that they are also aware about that. Next slide, please. So this is my last slide. Thank you very much, Rajat. I think I have completed my presentation within the stipulated time. Thanks, Dr. Shobni. Thanks to the chair and co-chair. And then, as Mahatma Gandhi has rightly said, that you must be the change you wish to see in the world. So it should all begin from us and with us. And I'm sure with all the learned audience and the committed leadership at the NACO, and definitely these changes will be thought of, and much more than this. And the way recently the HIV surveillance meetings have happened, and then the Sampurna Surashtra strategy meeting has happened, the CSS and CLM discussions are happening. I'm sure there is definitely a change in the mindset of the NACO leadership, and there is also revitalization there, and I wish them all the best. Thank you very much once again to chair and co-chair, and to the Chandigarh SACS for giving me this opportunity. Thanks a lot.
Thank you, Dr. Prasad. Dr. Rajat, would you want to make some comments?
Oh,
or
no,
Dr.
please.
Swain?
Please go ahead and introduce maybe the next speaker, and we can talk maybe at the end.
Okay. So the next speaker is Kannan Mariappan, who is presently working in PATH as a senior program officer for HIV. He is specialized in public health and has won awards like the Spearhead Leading by Example Award, Annual Award by PATH. And Kannan is again not new to the program. He has worked for NACO, he has worked for the TSU, and he has always been closely associated with the prevention team at NACO. So over to you, Kannan, for your presentation on the STAR self-testing project.
Yes. Can you able to see the screen?
Yes.
Yes, we can.
Yes. So
please stick to time.
Yeah. I'll finish it in 10 minutes. Thank you, Doctor. So good evening to everyone, and chair and co-chair and organizing committee for giving the opportunity to present the new initiative called HIV self-testing study in India, first time. So this is not the presentation to share any findings of the study, because we are in implementation. So we wanted to share what is happening around HIV self-testing in our study. So the title of the study is Accelerating Access and Uptake of HIV Self-Testing in India. This is a demonstration project, and Ms. Alpana Dange is the PA of the study from Hamsafar Trust. And this study has, this project has a 3 key output. One is about enabling environment created to support introduction of HIV self-testing in the countries. So we have worked for this, even the study to initiate in India, even the many people are aware of it. More than 15 months it took to take all the regulatory and ethical approvals to initiate the study in India. Second is non-availability of HIV self-testing kits in the country. So is one of the main activity also for the project to facilitate between the stakeholders for the research institute and the manufacturing institute to facilitate the availability of HIV self-testing kits in the country. So there are 7 HIV self-testing kits company are working on this, and then 2 is already moving on for the clinical evaluation part. So hopefully by end of year we may have 2 approved kits in the country. That is the separate part. The output 2 is the main thing about the study, service delivery models, and then we implement and show what is the kind of a linkage is there. This entire presentation we going to talk about the output 2 one. Output 3 is about the dissemination of the findings and then mobilize the resources for the transition and scale up. So this is the 3 output of the project. So the output 2, as I said, that's about the entirely about the study. It's a purpose of the study is to demonstrate feasibility and acceptability of HIV self-testing among different key population groups and also generate evidence. So there are objectives. The first objective is to assess the feasibility, acceptability, and demand of HIV self-testing across different population, and there are 5 different models are there. Second objective is to see what is the type of test kit that they prefer and what is the approach that they prefer. Third, we wanted to understand when we talk about HIV self-testing, what is the level of linkage to the confirmatory test
even if they found non-reactive, what is the level of linkage to the prevention services? If they found positive, what is the linkage for the ART initiation? So we wanted to assess the linkage part of it. And then we also wanted to document the challenges in linking the study participants to all these services, and is there any social harm also. So this is one of the very important study. This will provide major findings for making some kind of a national level self-testing guidelines to the program. And as I said in the output one, that these are the 13 different set of approvals that have been obtained to start the study in India, which includes different ethical committees, import license, CTR registration, HMSC approval, approval from NACO, then international path approval, then CDC, SIB approval, all those things. So with that, the study has been common, and then we have some data. So to initiate the study, we have conducted one formative assessment to understand the enablers for the HIV self-testing, because the first time in India. So we have conducted the study with a very key in-depth interviews with the 42 respondents, 35 from HRGs and 7 from other service providers, technical experts and stakeholders. What we found, these are the 6 key findings only we have put it. That report is there for around 150 pages. So, but we have mentioned only key items. So what they mentioned is that we have to be very clear when we talk about self-testing, what is the credibility, whether what is the sensitivity and specificity of the test. That has to be highlighted, and that will be helpful to scale up the test. Then they also said that it will minimize the stigmatizing interactions. So whether it's between anybody. So self-testing they themselves can do, and there is no point of discussing about the stigma part of it. Then they also highlighted that it has to be highlighted that importance of screening when we compare with the ICT test, because that is a confirmatory, this is a screening test. And always you have to have a support and mechanism to test for the confirmatory and for the linking to the ART services. So that should be available when we talk about this self-testing. Then familiarizing self-test, because nobody has seen it, and then they wanted to experience it, they wanted to feel it. Now everybody, even when we started, many people had that kind of an apprehension, but now people are very familiarized with the self-testing. They themselves are doing it. The last one, it's a big challenge one, normalizing getting regular HIV. They are saying that you don't put it self-testing into like a once in 3 months or once in 6 months. Put it like a sugar test, put it like a pregnancy test. Whenever they want, they should do it. So normalize the entire self-testing kits. These are the key findings from the formative assessment. Then coming to the study part of it, we have 5 different models. As I said, community-based model, private clinic model, virtual model, workplace model, and community pharmacy model. Almost 70 to 80% of the kits have been allotted to the community-based model, so that we can able to see what is the kind of a population that we work, what is the response from the key populations. So we work with many partners. I'll come to that in the last slide. And then the study is being implemented 14 states except Uttar Pradesh. Uttar Pradesh, there is some approval process still going on. Once it is done, we will also implement it. But otherwise, we are working in all other states. Study started and it is under progress. So we are aimed to reach around 112,000 participants through this study, and then which will be completed in June 2022. So this is the major flow of the entire study process, like from eligibility assessment to understanding the social harm. So once you finish the eligibility assessment, you have to get an informed consent. Once you have done the informed consent, then you will be enrolled into the study. After enrolling, will be collected certain basic data, and then pre-test counseling, conducting of HIV self-testing, post-test counseling. For the pre-test counseling and post-test counseling, we have around 3 separate videos in 8 languages, and also kit demonstration, how to conduct the test kit. So all the 3 test kits that we use, we have three different videos, and also in 8 languages. So that is available in our YouTube channel. So then we are linking them to the linkages for the confirmatory and as well as to the ART services. So these are the main intervention steps that needs to be followed in the study. To monitor and advise the entire project, we have formed a project advisory group under the chairmanship of Dr. JVR Prasad sir, and then other key representatives from NACO, ICMR, NARI, WHO, UNH, USAID, CDC, ILO, PATH, and TIS, then Southern Hospital. There are so the key experts once in 3 months they review the project and then provide the guidance. Then we have a community advisory board consists of key population and PLHIV communities. And the chair position is a rotation basis that has been decided by the community members. They said, since we represent from different typologies, so let us have the chair position is rotation. So earlier, the first when we selected Dr. Chakravani was the chair for this committee advisory board. Now we have selected new person, which is Selvi from FSW committee. So and then we have representation from different network, and they also meet once in 3 months. And this community advisory board makes monitoring visit to the study sites. So different states they visited and they provide support to us. Then we also set up a mechanism at the state level under the chairmanship of project director, and then representation from stakeholder and the communities, PLHIVs. They are all part of the state oversight committee to monitor the study at the state level. And further down, district level community monitoring board. So this is only consist of communities only, key population and PLHIV. So the transformation of information across the board at the grassroots level has to be taken to the community about HIV self-testing. So capacity building. So capacity building is the one area we also got a support, because this project we don't have that much of adequate resources. So we also got an external support from PEPFAR partners. So Share India is helping us in building the capacity of the entire study staff along with all the states and other things. So we also conducted a master trainers program, and then we have done the cascade of the entire field study team. Around 700 staff have been trained on HIV self-testing along with the TA and other staff and other things. And then we also conduct hands-on field level training also. So we send our state managers or the regional managers to go and spend time over there and then provide the training to the study team, because we found that regular in touch with the study staff about the study protocol and the procedure that needs to be followed. Same case, we also conduct every month or once in 2 months interim online capacity building quiz on the study procedures or the protocol that needs to be followed for the study. So based on that, state-wise further discussion that we also undertake. The other major thing is site monitoring, because since it is going to be covered 1,12,000, more than 1 lakh study participants, we need to have an independent site monitoring. Again, Share India is helping us in facilitating this site monitoring. They have completed 10 states, 15 districts, and 41 sites of the study so far. They will be continuing it. And so far, as per the study protocol, they have scored on an average 92%. The study procedures are followed in the sites. So there are minute suggestions are there. So we are also giving back to the training and then following up with the implementation partners. The other thing is about the engagement of the communities. So community advisory board at the state level, state oversight committee, we have a committee participation. At the district level, committee monitoring board. Then we also have different community consultations from north to south and other things. We have a lot of community consultation to orient about HIV testing. Then we had a discussion with the different community networks like ANSW, IDUF, and then through Hamsafar also we had a lot of discussions and other things. Then the CBO engagement. What we thought is that CBO engagement part is that we didn't have any kind of local organization connection and other things. So what is the implementation partners, we also said that local CBOs will be recognized, CBOs and GO will be recognized in the study, and because they are the one who is regularly working with the key population, and after study follow-up along, the CBO will be carrying out. So that is also we have done. So the kind of an engagement that has been established in the study with the local level CBOs who are helping us in implementing the study. And then we also presented this study to the national CSS system and then got the feedback. So these are the key things that we have established. And then more than 250 CBOs are working through this study. So this is another
So, Karnan, sorry to interrupt you.
Yeah,
You
one more,
need
two
to
more slides.
wrap up quickly. We
Yeah.
are already into the tea break time. Thank you.
Yeah, okay. So this is a virtual model that is sagaindia.org, where you will be able to access with the OTP, and then you can avail the test kits through courier, or you can collect it from nearby sites. It is everything is self-driven, 8 languages. The page automatically changes, so it is easy, user-friendly. Then it's a YouTube channel that all the videos in different languages available. Anybody can download and then see how the test kits has to be performed. Counseling, pre-test counseling, post-test counseling are available. So this is the last slide. These are the takeaways. So WHO pre-qualified 3 self-test kits are used in the study. 13 approvals, more than 700 staff trained. Almost 20,000 test kits have been distributed. 8 languages in the materials, and then social media campaign, virtual model, online capacity, regular site monitoring. All these are under progress, and then we are on. This is the one slide that just wanted to show what is the preference of the study participants so far. It varies, depends upon the states, and then even the districts, it has changes. And when you see in the Northeast, you say blood-based one, because the oral-based has one condition, is that if you have a hepatitis C infections, then you cannot use the Vora quick test kit. So what is happening is that in the Northeast, you see the blood-based one picking up because of the hepatitis C prevalence over there. In other states, its variants are there. We will disseminate the findings in June end. These are the main information from this study. If you have any questions, please, these are our key partners. Thanks to NACO and all the PEPFAR partners, SATI, Hamsafar Trust, Share India, NCPI, BHS, ITEC, ILO partners, all ICMR, NARI and NIE, and all our vendors. Thank you. Thank you, Rajat. Thank you.
Thanks, Karnan, for a very nice presentation on HIV self-testing. And even NACO is very keen to know where we stand with respect to how the results of this study are going to look like. Yeah. So we look forward to hearing more from you in coming days.
Yes.
Dr.
Yes.
Rajat?
Yes, ma'am. So because time is very limited, so I think, and I don't know whether we may have some questions also. So I'll just quickly share a couple of observations. So first of all, I think all 5 presentations under these sessions were really great. And you know, starting with Dr. Bijay, I think he made an excellent, outstanding presentation. And although kind of, you know, he painted actually a lot of remarkable achievements which we have achieved. Thank you so much for appreciating that. But at the same time, I think I just observed that when we say we are on the track to, you know, achieve 95% decline in incidence by 2030, it is actually, I will say, big question mark, because in the sense, like, it is true that global average was, you know, 23% incidence decline from 2010, whereas our decline is 48%. But by 2020, our target was 75%. So we are, you know, far behind. We have to catch up. And of course, we were even behind, you know, the UNAIDS report says not only India, across the world, even without the pandemic. So pandemic, of course, came and there were 2 waves, 3 waves, but still we were far behind. So in any case, I think at the same time, our achievements are remarkable. But if we have to achieve 2030 targets, we have to really pull our shocks. And then another observation I had, like when I think our champ, you know, very popular speaker like Sruta, I noted down, you know, the response rate of that online survey. It is actually around 60%, because I think 6945 people were eligible, but finally 4179 people completed the interview. And so anyway, that's a, for any online survey, response rate is a big issue. And I remember that anything beyond 80% response rate is always, people will question representativeness. But anyway, this is always a big challenge. And anyway, Dr. TLN Prasad made his, few thoughts very clear and very impactful thoughts. And the final presentation, as Dr. Shobini ma'am already mentioned, that, we are all looking forward to the demonstration project or pilot project, whatever you say. The results are very important for our future, program on HIV self-testing. So I'll end there, and maybe, other my speakers, and ma'am, you can conclude at the end, maybe, as a chair. Thank you.
Thank you, Rajat. I think you have yourself done a very good job of concluding, so I'm not going to repeat in interest of time, but I'll certainly request for comments, if any, from Murugesh and Dr. Swain, and then we'll conclude our session.
Yeah, thank you, ma'am. No, I also wanted to comment Dr. Vijay's presentation, because it was really nice. He spoke about the aging of the epidemic and the need to address socioeconomic determinants, to look at how do we reach the different aspects of 95, 95, 95 if you're trying to reach the goal. And I think that was really commendable. And Shruta also highlighted the needs, because a lot of work is currently on virtual interventions, but how do we look at the surveys and how do we take those surveys and plan our interventions was a key takeaway message for me. And, needless to say, Dr. TLN Prasad, with his thoughts, putting that picture that Aradhana Jori had presented, that high level funding, and that it took back me in like 2006, where we spoke about different issues and how relevant they are and how we can use that frameworks to currently fill the gaps. And lastly, definitely, Kannan, I know, because we are co-partners of the project, the amount of work in systems building, community engagement, pre-test, post-test, and putting the systems forward. And thanks for sharing those findings on formative assessment and a couple of the feedback on the preference of the HIV test kits. I know we are halfway there, but yes, mostly we will be able to complete it and come up with some interesting results to see what's the way forward to the study towards a policy level implication. So thank you all the presenters. It was really nice. And thank you for the organizers to have me as a co-chair. Thank you.
Thanks, Murugesh. Dr. Swain, comments, if any? Okay. So we declare the session closed. I hand back to Chandigarh sir. Okay. We could read that out. I am unable to hear it. See it, sorry.
Dr. Rajat, if you can read that comment for us, because we cannot see that. Or
which comment?
Professor Swain's comment. I think she had
put
on chat.
Very much for all the presenters, and thanks to SACS, Chandigarh, and NAC.
Okay, thank you. Thank you.
Thank you so much.
Thanks, Dr. Rajat.
Chair. Now I request our chair, Dr. Shobini Rajan, Deputy Director, Journal TI and BSc Division NACO, to honor Mr. Murugesh Shiva Subramaniam from Humsafar Trust. Thank you so much.
Someone can take a picture. Yes. Thank you.
Thank you very, very much, ma'am. Thank you, sir. Thank you all the speakers, chairs and co-chair. Thank you very, very much. Moving on to our next session, session 12. It's an honor to invite Dr. Manmeet Kaur, Professor from School of Public Health, PGI MER, Chandigarh. She does not need an introduction. She's a famous personality of Chandigarh. Everybody knows her. So it's an honor to invite her here today. We welcome you, ma'am. I would request Mr. Manish Kumar from TSU to please join us on stage again. He's team leader TSU SPYM. I request Mr. Sandeep Mittal, Deputy Director TI Chandigarh SACS, to please join.
We are able to see each other at least once again.
Now handing over the session to our chair and co-chair. Thank you.
Good evening. So good evening, everyone. I have both the co-chairs on my left and right, Dr. Sandeep and Dr. Manish. So I would suggest that let Mr. Sandeep introduce two participants, and two participants will be introduced by Mr. Manish, and then we will have comments after the sessions. So can we start? I think we should begin with the first presenter, if you can invite them.
Yeah. So I would like to invite Dr. Manjeet Singh, who will be speaking and sharing his experiences on HIV and hepatitis co-infection.
Yeah, thank you, Chairpersons. At the outset, I'd like to thank respected Dr. Aman Kang for giving me this opportunity at a forum where the national and international authorities are there. Nevertheless, the topic that I am going to touch is very important in today's perspective. Now, for the last 3 years, while working for National Viral Hepatitis Control Program, I realized that under the state AIDS control activities, whatever we were doing, we were screening for hepatitis B and C and probably doing nothing for these people, which is again something really very big thing to do nothing for something. And when we'll be just going through the presentation, the type of problem for HIV people being created by and hepatitis C and B is really huge. And I think better late than never. It's a time now really to intervene, because a major morbidity and mortality is being contributed by the hepatitis viruses to these patients, rather they dying because of the HIV. So hepatitis C virus and hepatitis B virus and HIV, we all understand that share the similar routes of transmission by sexual intercourse or drug use by injection. So co-infection is common. Where one virus is there, the second and third is also there. People at risk of HIV infection are also at risk of hepatitis B and C infection. And liver disease is a leading cause of death among HIV, HCV co-infected patients. That's a very important thing for us to understand, and is becoming an important cause of death among HIV, HPV co-infected. So when the two viruses there, the death is multiplying many times, and the three are there, it is multiplying much more. The risk of death from liver disease is highest in the patients which are infected by both these hepatitis viruses. Now, when we talk about B or C co-infection, there's an increased risk of developing chronic hepatitis. We have serious medical complications, including an increased risk of liver-related morbidity and mortality. HIV positive individuals all need to be screened and are now being screened for hepatitis B under the state AIDS control program all over the country now. And all those who are negative, they need to be vaccinated against hepatitis B for the obvious reason. And the post-vaccination testing of people living with HIV is recommended 1 to 2 months after administration of the last dose of the vaccine series. I think this is one area where we need to really work upon, because these people may be responding to the vaccine or they may not be responding to the vaccine because of the immune reason. And HCV affects 2 to 15% of people living with HIV worldwide, and up to 90% of those who inject drugs. So 90% becomes a huge number, which means almost everybody who is taking injectable drugs can have HCV. And if we are not screening or not treating them, we are obviously helping in the spread of their disease. And chronic B infection affects an estimated 5 to 20. So it's almost similar number if we talk about C and B. And the global estimates of burden of HIV and HCV co-infection is about 2.75 million, and with B is 2.6 million, and maybe almost similar number maybe having probably both also. And the burden of these co-infections are greatest as all similar diseases when we talk about the South Asian regions. So if just we see this graph, the curve on the top is the survival when there is no B or no C infection in an HIV patient. And as the number of, here the B comes into the picture, and here C comes into picture, and here both and C. So you see the survival that goes down, and this is just at somewhere around 4 to 5 years that the survival comes so down. So this means these patients are not dying of HIV, these are dying of the hepatitis viruses. So again, when we talk about the percentage patients with the cirrhosis, so if it is only HIV, we know the HIV virus itself can have hepatic involvement, and ART itself has got hepatotoxicity. In spite of that, when the person is negative versus HCV positive with the hepatitis C viruses, the percent of cirrhosis goes so high, and the cirrhosis basically itself means a death warrant or a predisposition to hepatocellular carcinoma. So this is one of the studies from the Manipur, which tells about the basic incidence and prevalence when the antiviral drugs for hepatitis C or B were not being used. So the HCV prevalence was about 93% among the IV injectable drug users and 34% among HIV negative. So this is the number that adds on when the person is HIV positive. Similarly, HIV prevalence was 34% in HCV positive and just 1.7%. So these two add on to each other. And these were the various risk factors which were found in the study for having both the infections. And similarly, when we talk about the number from the Western studies, that a large number of people are having hepatitis C co-infection, hepatitis B co-infection, and maybe both the co-infections. And also, when we discuss about the pathophysiology of the disease, HIV increases the levels of HCV viremia. So they both are in fact synergistically increasing the complications or severity of each other, so that the patient early progresses to the cirrhosis, liver failure, and death. And cirrhosis has been observed to occur 12 to 16 years earlier in persons co-infected with C and HIV. And liver-related morbidity and mortality is a prominent non-AIDS related complication, and up to 80 to 90% of liver-related deaths occur because of the hepatitis C infection. And mortality in the co-infected is related to HIV viral load and CD4 count. So again, stressing the importance of understanding the viral load and controlling the viral load in this patient, so that the opportunistic infections also remain relatively old. And the successful treatment of chronic hepatitis C in HIV patient, it stops the progression of HCV-related liver disease and complications of decompensated cirrhosis. So it's a very, very hopeful scenario. Drugs are available under national program. They are available free of cost, and by and large, they are free from major side effects also. So this is one of the studies that comparing 265 patients with HCV and HIV, only HIV and only HCV. So mortality over 3 years, you see 17% in those with both HIV and HCV, whereas it had been only 9% with only HIV and just 6% with the HCV. So it is multiplying 3 times or multiplying 2 times here. And the co-infected mortality varied by race also in this study. So when we talk about the people who inject drugs, I know this is a very special group of people when we talk about the AIDS control program. No, 67% of people injected injectable drug users have HCV antibody. So there lies the importance of screening. Now, till 2019, when there's a coordination at the national level occurred between National Viral Hepatitis Control Program and State AIDS Control Program, that was the reason that it was decided that whenever we are testing for one of the viruses, we will be simultaneously testing 3. Otherwise, we are doing not even half the job. And increased risk of HCV-related disease, transmission, morbidity, and mortality, as already we have learned about it. And considering as a priority for HCV treatments had been very low because of the criminalization of the drugs use and discrimination and stigma and other reasons associated with that. So screening of people who inject the drugs are very important till they are totally off that habit, because as ongoing injectable drugs are there, even if you treat the hepatitis C infection, you cure it also, they are likely to get it again also. So treatment of HCV, when we talk about in this patient, now the things have been really simplified, and it requires the integration of services, other healthcare needs, treatment of HIV and tuberculosis. Now you see again, tuberculosis coincidence is quite common when we talk about these immunocompromised patients. maybe HIV, maybe hepatitis C, or maybe hepatitis B. So we need provision of the opiate substitute, sterile injection treatment, avoidance of discrimination. We had a lot of discussion on this topic during the last 2 days, and hepatitis B, vaccination also in all these cases. So that had been one of the reasons in Chandigarh also. Already quite a lot of coordination has already been there, and maybe on the treatment and investigation part, there is still a space for us to go together to manage these patients in a more effective and more rapid way. And I think these are the areas when we want to investigate these patients, like all other clinical cases, a good history, physical examination of jaundice, hepatosplenomegaly, because the staging of hepatitis C is important when we talk about the management of the drugs. And now these are directly acting antiviral drugs which are now available. The outcome in HIV co-infection are comparable to almost HCV infection. So probably we need not be much scared when we talk about the side effects of the drugs. And the outcome is also more than 95% people can be cured when we are using directly acting antiviral drugs in these patients. And no, what is the principle? Just as an outline, though this is not the forum to talk about the treatment or the cure of this thing, but the principle is the first initiate the treatment of HIV and achieve HIV suppression before starting the hepatitis C treatment, because viremia will be having its own hepatotoxicity and the drug-drug interactions also. But there are certain circumstances where it makes sense to treat hepatitis C infection first and then initiate therapy for HIV. Now, this could include the person with moderate to severe fibrosis, the rapid liver disease progression, and so in these cases, the HCV can be controlled within a period of about 3 months, rather cured, and subsequently we can put them on the treatment for the HIV, or depending on the understanding of the drug-drug interactions, both can be started simultaneously also. So these are now the new regimens for those who are interested, though the discussion about these drugs is beyond this forum. And these are the various studies which have shown the excellent safety when we talking these patients with these drugs. And there had been a concern about the ART hepatotoxicity, but the potential harmful effects of ARP drugs are really not as significant, because the drugs that at present we are using for management of both HIV as well as HCV are relatively safe. And so these are the drugs that we are using. So for those who are interested in the drug management, the site I have already shown here, and these information is easily available. So just about a word, this program was launched viral hepatitis in 2018, and since 2019 we have got coordination. Now in Chandigarh, all the patients of hepatitis are also screened simultaneously when we are talking about HIV. Now what we need to do is to start our HCV RNA and HPV DNA also, and treatment centers also needed to be where ART is being given. Probably we can simultaneously treat the patients off, because they are the people who are coming to you. So these are few of the achievements that already this program has done since its launch 3 years ago in PGI and in Chandigarh. And these are the few of the highlighted areas are the one which still we need to work. So this is the target for hepatitis B: reduction in incidence, mortality, and 80% of the patients should be treatment. But when we talk about this program at ground, miles to go, it's just a beginning. So we'll request all those people who are talking about HIV, I think we must be talking simultaneously about all these 3 viruses. Thank you very much. Thank you.
Thank you. I think the message is very loud and clear that we need to have screening for all the viruses together, and then should actually put people on treatment together. And it will be cost effective as far as I understand. Thank you very much. Can we invite the second speaker?
I'm happy to invite the next speaker, Dr. Ravinder Kaur Sachdeva. She is a Senior Medical Officer, ART Center, PGI MER, and she has a very, very short stint with Technical Support Unit in early days of NACP3. And she'll be talking about frequency of TB in HIV patients after IPT.
Thank you, Chairperson and Co-Chairperson.
I would like to thank Chandigarh SACS for giving me this opportunity to present my data of ART Center. Thank you. So I'll be beginning with the INH prophylaxis and tuberculosis in HIV. So as we all know, tuberculosis is a very common and opportunistic infection which we commonly see in HIV infected patients. And each day we are seeing so many patients in ART center who are having co-infection and opportunistic infection of tuberculosis. So worldwide, total of 1.5 million people died from tuberculosis in 2020. TB is present in all countries and in all age groups. India has the highest estimated TB burden, and annually 26 lakhs estimated to develop tuberculosis. The risk of tuberculosis increases 16 to 21 times in HIV co-infection with or without antiretroviral therapy. And people who are living with HIV, they are 18 times more likely to develop active tuberculosis than people who are not with HIV infection. So HIV and TB, it forms a very lethal combination, and each feeding the other progress. So common symptoms which we see for active lung TB are cough with the sputum, chest pain, weakness, weight loss, fever, and night sweats. Rapid molecular diagnostics test has actually helped in diagnosing tuberculosis very quickly, and it has a very high diagnostic accuracy, and it has led to the major improvement in early detection and in the TB outcomes. The four main TB prevention strategies in PLHIVs are intensified TB case finding with high quality ATT, early ART initiation among PLHIVs, isoniazid preventive therapy, and airborne infection control in healthcare facilities and congregate settings. There's 90% reduction in TB diseases in PLHIVs after preventive therapy, and this has been given in various literature all over. So effective implementation, if done for IPT, it can result in 8.3% decline in TB incidence in Southeast Asia region. So this study published in Lancet, it is recommending that all the patients receiving antiretroviral therapy in moderate or high incidence areas, irrespective of tuberculin skin testing, they should be given IPT prophylaxis. So how does IPT prophylaxis work? About 50% adults in community, they have latent TB infection, and isoniazid, one of the most effective bactericidal anti-tubercular therapy, which is currently available. And it protects against progression of latent tuberculosis to active disease and prevent TB reinfection post-exposure to an open case of tuberculosis. So, and who should be offered for IPT? All adults and adolescents living with HIV who are screened for tuberculosis with a clinical algorithms for 4S symptoms, which I just mentioned. Children living with HIV who are more than 12 months of age and not reporting poor weight gain, fever, current cough, or history of contact with tuberculosis, or who are unlikely to have the active tuberculosis, they should be offered IPT prophylaxis. Additional investigations, it helps in ruling out active tuberculosis infection, but these are not mandatory before initiating IPT prophylaxis. At each monthly visit, how we are proceeding in the ART center. At each monthly visit, PLHIVs, these are assessed for 4S symptoms, side effects of INH, IPT adherence, and doses missed since the last visit. Adherence to drugs is assessed by remaining doses of pills during the monthly clinic visits. And if they report with no symptoms, they are counseled on the need of IPT, drug adherence, adverse events, TB symptoms, healthy nutrition and hygiene, and provided with the monthly supply of the drugs. And if TB is diagnosed, ATT is initiated. So all asymptomatic PLHIVs with no current evidence of active TB and not currently on ATT will be considered eligible to receive IPT prophylaxis. And they are initiated with 300 milligram of INH with 50 milligram of pyridoxine to be taken every day and for 6 months. These are few of the contraindications before for IPT initiation. Those people with active tuberculosis, those with active hepatitis, peripheral neuropathy, poor adherence to cotamoxazole therapy, and poor understanding of IPT, or having contact of the MDR TB case, and who have completed drug-resistant tuberculosis treatment, and these are not eligible for the IPT prophylaxis. This is a flow chart which is being followed in the ART center for initiation of IPT prophylaxis. Patients are screened for 4S. If symptoms are found, they will be investigated for tuberculosis. If no 4S symptoms are reported, and then they are found to be eligible for IPT prophylaxis. So this study is actually, which was done in the ART center, is to see the efficacy of INH prophylaxis, which has been given to the patients over past 4 years in the frequency of tuberculosis. So in the ART center till December 2021, 10,200 patients were registered in the HIV care. 8,158 patients were initiated on antiretroviral therapy. Of these, 5,711 patients, they were initiated with IPT prophylaxis. There were 5,091 patients who are alive and on ART, and there are 2,008 deaths reported so far, and 1,549 patients have been transferred out, and 459 LFU and 256 opted out from the treatment. In last 4 years, total 768 cases have been diagnosed in the ART center for, with tuberculosis, which was clinically diagnosed, microbiologically confirmed, pulmonary TB clinically diagnosed, or microbiologically confirmed. In 2021, we saw 172 cases, 165 in 2020, 244 cases in 2019, and 187 cases in 2018. So a total of 5,711 patients, they received IPT prophylaxis, and of this, 81.4% patients, they completed with the INH prophylaxis, which formed to the number of 4,652 cases. There were 1.9% patients who were stopped with the INH prophylaxis due to the hepatitis or some gastric symptoms which were reported, and they were not, they were stopped with the INH prophylaxis. This bar diagram is showing that we initiated 5,711 patients on IPT prophylaxis. 4,652 they completed with the INH prophylaxis, and 950 patients are on IPT, and 109 they have stopped. So I analyzed the data for how many patients they developed tuberculosis after completion of the IPT prophylaxis. So in 2021, 12 cases were found to have tuberculosis after completion of IPT prophylaxis. In 2020, there were 3 cases who were found to have tuberculosis after completion of IPT, 5 cases in 2019, and 2 cases in 2018. So total of 22 cases of 4,652 cases developed tuberculosis after IPT, which amount to a percentage of 0.47%. After a mean duration of 14 months, there were 8 pulmonary TB cases and 14 cases with extrapulmonary TB. 4-timoxazole prophylaxis was given to all patients, and there was none patient with the hepatitis B or C co-infection. And all patients, they reported to have adherence more than 95%. CD4 count was assessed for these patients, and baseline CD4 was 315, and the recent CD4 is 376. There is not much statistical difference. Viral load at the time of the previous viral load was higher, and the recent viral load, they are virally suppressed. Of all 22 cases, they are virally suppressed. So 17 cases are receiving first-line therapy, and 5 are on second-line antiretrovirus. These are the various regimes which are being offered to the patients. And of these 22 cases, 17 are alive. There are 2 deaths and 3 lost to follow-up. So 81.4% patients, they completed with IPT prophylaxis, and 0.47% tuberculosis was seen in patients who completed IPT prophylaxis. So the systematic review and meta-analysis from clinical trials, they have demonstrated a reduction in the tuberculosis among PL-HIVs after IPT, ranging from 30 to 74%. And IPT has reduced TB incidence by 52% in PL-HIVs who are attending clinics in Tanzania. This has also been reported. This is another study which has been from India, where they have looked for the incidence of tuberculosis while on IPT, which was found to be 1.17 cases per 100% year. So IPT is to be provided to all PLHIVs without presumptive
Thank you, Dr. Ravinder. It's, I think, very important that we should now start with the prophylaxis for tuberculosis so that we have less number of tuberculosis patients along with HIV, and we can probably save more people.
Right, ma'am. And we are actively doing now in our clinics. Each day patients are assessed for IPT, and we are actively giving IPT prophylaxis to our PLHIV so as to reduce this incidence.
Yeah, important finding. Yeah, thank you.
Thank you so much. Thank you, ma'am.
So our next speaker is Dr. Ravindra Rao. He doesn't need any introduction. Nonetheless, Dr. Rao is additional professor in Department of Psychiatry, All India Institute of Medical Sciences, New Delhi. He has been associated with National AIDS Control Program for quite long. In fact, he has worked as program officer in National AIDS Control Organization and is credited for OSC rollout in public health setup across the country. So can we have Dr. Rao, please? Sir, over to you.
Rao sir, are you sharing your screen, sir?
Yes, I think you can start, Dr. Rao.
So there's an issue with your audio, sir.
Am I audible now?
Audio of
Dr.
the
Rao, we can.
Dr. Rao's audio, basically. We can see your screen, sir. The headphones are not working, sir. The mic is not working. Yeah.
Stigma discrimination पे गिरिजा.
Online.
Sorry, sir, we're not able to hear you, sir. Can you check your mic, please? There's a, on the bottom left corner, there's a symbol of a mic. Just click on it once.
Hello, I'm audible now?
Yes, you are, sir. Perfectly well. Thank you.
Okay, great. Sorry. Right. So thank you to the chess and thank you to Chandigarh SACS for having me to share my thoughts and to present an important aspect of problems associated with people who inject drugs, which is on overdose prevention and management. So my earlier speakers have talked about two important comorbidities, which people generally accept that they occur with more with PWID or people who inject drugs, which is hepatitis and tuberculosis. But more often than not, they are not cognizant or they are not aware that there is another bigger problem that happens with injecting drug users or people who inject drugs, which is overdose. And that is something which is very important for us to talk about. Now, we know very well that drug users have higher mortality as compared to the general population. Reports or research studies show that almost 10 to 15 times higher mortality as compared to general population. Now, the reason for deaths, what has been seen is not HIV or hepatitis, but the most common cause of death among drug users is due to overdose. And among overdose related to drug users, the opioid group of drugs are the most often incremented lot for causing overdose and overdose related deaths among drug users. So that way it has huge mortality as well. Now, if you look closer home in South Asia, so Bangladesh, for example, some of the cohort studies that have been done shows that the mortality rate once again is much higher among injecting drug users. This study was among injecting drug users as compared to general population. Even in our country, there was a cohort study conducted from Chennai, and way back in 2009, it also showed the same, and it showed that the mortality risk among HIV positive IDUs is 3 times higher as compared to those who are HIV negative. But in both HIV positive and HIV negative IDUs, the leading cause of death was opioid overdose and not HIV or HIV related complications. That is something which we need to understand here. Now, before a person who is injecting drugs, he dies or he succumbs to overdose, they also experience a greater number of non-fatal opioid overdose. So, in fact, the rates of non-fatal opioid overdose is much higher as compared to the fatal opioid overdose. So, for every 100 non-fatal opioid overdose, 3 to 4 die of overdose. So, in that sense, non-fatal opioid overdose are, in that sense, a harbinger of a fatal outcome with one of the overdose episodes. And if you see studies across cities and countries, it shows almost 40 to 50% PWID have experienced a non-fatal opioid overdose. Now, even in our setting, we try to link up with TI, which is linked up with our community drug treatment clinic. We conducted a study. One of the thesis study was on this. And what we also saw that was that among 104 injecting drug users, the rates of ever overdose as well as overdose, this is non-fatal opioid overdose, in the last 3 months was much higher, almost 1/3. And if you see ever, almost every IDU had experienced a non-fatal opioid overdose. We expanded this study to include the rest of the targeted interventions in Delhi, which is supported by Delhi State AIDS Control Society. There also the results were replicated. It was almost the same. So that is something which we need to understand, that non-fatal opioid overdose is much higher among PWID, and they can lead to a fatal consequence. Now, non-fatal opioid overdose, apart from a fatal outcome, can also lead to other kind of consequences such as injuries, brain hypoxia, seizures, paralysis of limbs, chest problems, being assaulted while unconscious. So all of this also happen with non-fatal opioid overdose. But most importantly, non-fatal opioid overdose also provide us with an opportunity to prevent further overdose episodes. And that is something which we need to seize the opportunity, we need to make use of. Now, what is overdose basically? We know very well that overdose is something if the amount of drug exceeds the tolerance limit in an individual who has developed tolerance to a particular dose, then he lands up into overdose. And that is the same case with opioid overdose also, that a person takes opioid alone or in combination with other drugs in quantities over and above his own capacity to tolerate opioids. So that is what we call as opioid overdose. Now, what are the signs and symptoms of opioid overdose? They are very easy to diagnose, not much of a problem. So, for example, if you look at the effects of opioids, we know that one of the acute effect of opioid is meiosis, which is constriction of pupils. In overdose, that effect is exaggerated, so you have pinpoint pupils. Similarly, you have sedation or stupor as one of the effect of opioids. And in overdose, you have sedation stupor to such an extent that the person is unresponsive or is difficult to be woken up even after stimulation. Similarly, we know that opioids act on the respiratory center and they depress the respiratory center, leading on to reduction in breathing. Now, in overdose, what happens is there is a respiratory depression where the person has very low rates of breathing, and gradually then he stops breathing altogether. So these three symptoms or signs are called as the cardinal signs of opioid overdose, which is unconsciousness, small pinpoint pupils, and reduced rate and depth of breathing. These are three cardinal signs of opioid overdose. So much so that if a person presents with these three, then the first thing that you need to do is to rule out opioid overdose even before considering other differentials for this presentation. Now, opioid overdose, you also have other symptoms. So we looked at not responding, slow breathing, but he may also make choking, gurgling, or snoring kind of sounds. His lips and nails will turn blue. The skin will be cold. The pupils will be tiny, that we saw. Also, the person may have vomiting. The person may have acute lung injury. In some opioids like tramadol overdose, the person may have seizures as well. The lungs will be filled with water, which is pulmonary edema, and heart conduction changes can also occur as a symptom or sign of opioid overdose. Now, what are the risk factors for opioid overdose? What lands up? We know that he is taking opioids more than he can tolerate, or that person can tolerate. But what are the risk factors? Now, the risk factors is the pattern of use of opioids itself. So, for example, injecting drug use itself is a big risk factor for opioid overdose. The rates of opioid overdose in a person who is injecting drug is much higher than a person who is chasing heroin, for example. And not recent injectors, but people who have long history of injecting drug users, they are more at risk. Also, changes in the purity or potency of heroin that is available, loss of opioid tolerance because he's abstinent, either because he has been jailed or he has been forcibly sent to a rehab center. So when he is forcibly made to quit opioids, that also is a high risk for opioid overdose. Concomitant administration of other drugs which depresses the functioning of brain, mainly alcohol and benzodiazepines. Comorbid physical illnesses, they reduce the tolerance of the person to the effect of opioids. That also can lead to opioid overdose. Similarly, comorbid psychiatric illness, especially depression, and in depression, a person who has suicidal ideas, opioid and opioid overdose may be a very efficient way to die and a painless way to die for that person. Similarly, there are other distal or remote risk factors such as incarceration, homelessness, sharing of syringes, sex work, injection by others, a person is victim of abuse, HIV positivity. All of these also are risk factors for opioid overdose. Now, what about knowledge of opioid overdose among people who inject drugs? We think that people who inject drugs, they know everything about their drugs. That's not true. There is limited knowledge. Studies have showed that many people don't even worry that they may land up in overdose. Only about 1/5 of patients or PWID were able to identify risk factors of opioid overdose correctly. Sometimes they also have wrong and dangerous knowledge of opioid overdose. That is something which we need to be worried about. Similarly, in our study also, we found that we used one of the scales to assess the knowledge. And what we saw that knowledge about risk factors, signs, actions to be taken following opioid overdose, or knowledge about naloxone, which is a specific antidote, that also is much lesser. And it was on the lower side of the range as compared to the higher side. People also had wrong knowledge. Like, for example, almost half of them thought that putting a person in a bath of cold water is a way to treat overdose, or put the person in bed so that he can sleep it off, which actually can make the outcome as fatal. Only 2% knew that there is a specific antidote called as naloxone to treat opioid overdose. Now, that is something which is the base on which we'll be discussing prevention and management. Now, how can overdose be prevented? Opioid overdose be prevented? The important thing is to educate and impart knowledge to IDUs about what is overdose, how can we prevent them, how do we manage them. As we discussed that many IDUs, they experience non-fatal opioid overdose before having a fatal opioid overdose, and that can be an excellent opportunity for educating people about overdose. And there have been studies which have shown that it is possible to impart overdose related knowledge to injecting drug users. So there people can be trained, and there is a significant increase in the knowledge levels after giving that training. So what are the kind of education messages that are provided in overdose prevention programs? So the thing like avoid mixing drugs, don't mix opioids as well as benzos together, don't drink alcohol after you inject, give a gap between two drugs. If you are abstaining, then and then you are restarting opioids, then the best is to take a small dose, test it, and then take the full dose that you feel intoxicated with. If there is a new dealer or the supply is unfamiliar, take a tester dose and then take your full dose. Avoid using alone. Don't use it alone, because if you're in the company of others, then at least that person will be able to help you if you land up in overdose. Take care of your physical health, because we saw that loss of tolerance can happen if you're physically ill. There also have been various materials that are there to help people get awareness about overdose. For example, when I was working with UNODC South Asia office, we had developed this education material which is available on YouTube, free for viewing. This is an animation kind of a video which you can easily use to educate PWID about what is overdose, what needs to be done in a person who has overdose. The second way to prevent opioid overdose is opioid substitution therapy, or OST. Various studies, systematic review, meta-analysis have clearly shown that OST has a greater chance of reducing overall mortality as compared to people who are not on OST, people who are off treatment. That is something which we need to remember, that can become a treatment for opioid dependence, but also can prevent opioid overdose also. Now, when a person lands up in overdose, how do we manage it? So the important thing is that the index of suspicion should be very high in a person with known history of opioid use, especially a person who is injecting drugs. We discussed about the triad of sign, and respiratory depression is a hallmark of opioid overdose or an accidental opioid poisoning. Now, the important thing is the management should begin in the field first, then it shifts to hospital. Unfortunately, that doesn't happen. In the field, we do not offer at the moment in our country basic management of opioid overdose. Now, IDUs themselves, their peers, they are often the potential first responders because they're the first witness to a peer overdosing. Now, with the pattern of opioid use or injecting drug use shifting to homes of PWID, family members can also provide opioid overdose management before the ambulance arrives and picks up the person to be shifted to hospital. So it is important to train frontline health workers, injecting drug users, as well as their families on overdose management. The management is very simple. There are some first aid and there is a specific antidote before you go on to providing a hospital level care. So for example, the acronym SCARE ME is a very easy to remember. So S stands for stimulate, C for call for medical help, A is maintaining airway, R is rescue breathing and recovery position, E is evaluate, M is muscular injection of naloxone, and E is once again evaluate and support. So for example, so each of these steps can be easily taught to PWID and their families, and this can be easily imparted to these to the clients and their families. So that is something which we need to focus on to provide this kind of education to PWID. With regards to the specific antidote, which is naloxone. Now, naloxone is a specific antidote. It is a opioid receptor agonist, antagonist, so mu receptor antagonist, and it helps in reversing the signs and symptoms caused by opioid overdose. So the beauty of naloxone is such that if a person has opioid overdose, you inject naloxone, and within 2 to 3 minutes, the person will suddenly get up and awake. He'll be awake, and he'll start breathing. So it has that kind of a rapid kind of effect. Now, it does not have any effect except in the presence of opioid. So for example, you and me, if we are opioid 9, if you have not taken opioid, if we are injected naloxone, nothing is going to happen. So it is that safe. It can be administered by any route. Intravenous is the best, but intramuscular is equally effective as intravenous. No fatalities in opioid naive individuals, generally available as a 1 ml and 2 ml injection with a strength of 0.4 milligram per ml. Easily available in chemist shop. It doesn't come under NDPS Act, which means that storing, procuring, there are no legal hindrances or roadblocks there. Ideal route is intravenous, as I said. Intramuscular can also work. Start with a low dose, wait for a couple of minutes. No response, you can administer another 0.4 to 0.8 till you have 10 milligram maximum dose. If the person does not respond despite this, then you may think of another differential before moving on, before you think that there is some other reason for this kind of a presentation. What is important to remember is that the effect of naloxone happens only for 30 to 90 minutes, which means the person can experience opioid withdrawals because naloxone is an antagonist, but these withdrawals will be short lasting. right? But important thing is that after 30 to 90 minutes, the overdose symptoms may return. That's why you need to observe the patient for at least 6 to 8 hours, even after he has recovered from the overdose episode. So once the person recovers in the field, the person can be shifted to hospital for during this observation period. So as I said, if there is no response to naloxone, then you need to look for alternative explanation for the clinical symptoms. You need to continue ventilatory support, oxygenation, and blood pressure maintenance if these parameters are deranged in this person. What should we not do while helping a person? So don't leave somebody who is overdosing alone. Don't put him in the bath. People think that by putting him in the bath, the person will wake up. Don't do that. Don't give him anything to drink or induce vomiting. He could choke. People think that by making him drink salt water, the person, because salt water is seen as a vomiting inducing agent, and that can take care of the poisoning. That doesn't happen. Don't inject salt water as well. So that also is dangerous and can cause sudden death. Now, in many countries, there are naloxone distribution programs, for example, OEND, which is there in several states of USA, which is overdose education and naloxone distribution. So there are overdose education programs, naloxone distribution programs, which are distributed by the peers, but the families have this kind of naloxone. Naloxone kit is available for them. Even naloxone nasal sprays are available, which are easier to administer. Unfortunately, we don't have that kind of a facility or that kind of a program in India. So in India, you have various challenges in preventing and managing overdose. One is, of course, there is lack of proper and adequate knowledge. Now, this is not just with the PWID, their families, but even the general community. If somebody is an injecting drug user, he's lying on the street, we just leave him, not knowing that possibly he can die, and this death can be easily preventable. Even the police, the law, the policy makers, program managers, most of them, they do not have this kind of a knowledge. There is lack of immediate help in the field, as I said. Ambulance, it may take time to reach. In the field, you don't have availability of naloxone. There is lack of availability of naloxone distribution by the peers and outreach workers. Even in case of TI, our outreach workers kit do not contain naloxone. That is something which we need to do, and we need to teach the outreach workers and peer educators how to use this naloxone. Obviously, we have talked about stigma and discrimination throughout this two-day conference. I need not touch upon that as much. And also important is the challenging policies and laws, because people are afraid, if I take an IDU to the hospital, what will happen to me, whether I'll be caught. If the peer is taking him, then the problem of medical legal. So those kind of issues, they deter peers or any bystander to take an injecting drug users to the hospital or to the emergency department and offering help. So those are some of the issues that we need to be mindful of. And it's high time that we have a proper opioid overdose naloxone distribution kind of a program embedded either within the targeted intervention or other kind of program need to be devised for this kind of a problem, which is easily preventable. Thank you. That was my slide.
Thank you, Dr. Rao. It really was quite exhaustive. You tried to cover all the important issues related to overdose, like prevention and how much awareness is there and what needs to be done, and also taking care of those who have been overdosed and how to save their life. So it I think is very, very important and needs to be part of the program. Thank you very much for sharing it. And can I now invite for the next speaker? Yeah.
So we have the last speaker of this version of AIDSCON, and the speaker is Dr. Girja Manju Thakur. She is the project manager of Swasti Health Catalyst, and the point she's going to talk about is stigma and discrimination issues among TG and Hijra community.
Thank you, sir. I have shared the PPT. Okay, yeah. So good evening, one and all, and thank you for providing an opportunity to get insights from honored participant. Here I'm going to discuss about stigma and discrimination issues faced by transgender and Hijra community. Next slide, please.
Please open the slideshow.
Karan, unshare and share it again, please.
Yeah. So who are the transgender? The transgender people have a gender identity or gender expression that differ from that the sex they were assigned at birth. In term, as gender identity is the opposite or of their assigned sex, like trans men or transwoman. The transgender people may now identify as heterosexual, homosexual, bisexual, and otherwise. It may decline to label their sexual orientations. The next slide. Yeah. In view of this, the M2F means trans woman that born with the male anatomy. As a gender, she is a female, and female to male as a trans man born with a female anatomy. As a gender, he is a male. As we are aware that in the reduction of vulnerability, the intervention has started to overcome the HIV based on the intervention typologies MSM, transgender, DD, homosexual, heterosexual, bisexual. And for this, as a support, the next slide. The targeted intervention program has launched in across in India, and they are providing the HIV as well as the STI services. Along with that the Transgender Welfare Board has established in some of the states like Tamil Nadu and Maharashtra. They are promoting the community well-being. Apart from that, the District Legal Service Authority also support to the legal and human right related issues to the transgender. Now we can see that in the COVID pandemic, National Skill Development of India that also support to stand on their feet in the way of the livelihood. But yes, still they are faced lots of stigma and discrimination at various levels. Like family, many families still they not accept their child as a trans, whether it is man or woman, and the stigma starts from it. As adolescents face dilemma situation of body and feeling, instead to understand their feelings, no one accept, no their siblings also accept in their family. As a peer in informal education system, child grown in school and in subsequent at college education, but peer group they not accept as a trans person in their group and they tease them. In society also, so many discrimination they face at the public places. Mainly they receive such a stigma like mitha, hijra or chakka, such a kind of abusing word they receive in general also. Sometimes it's happened that in their own community, in the previous only, their own community also discriminate them and they face a lots of concern from their own community. And yes, as we are working to reduce the HIV vulnerability among the key population, but many healthcare providers not treat them as a human, and hence they don't want to take the services. So there also they feel the stigma and discrimination. What happened due to this stigma and discrimination? They are not able to take education what they want to or what they desire. Also, they refuse to take the services to reduce the vulnerability. They undergone through the depression, lack of confidence develop among them. Then mental health concerns increase due to this. Also, they attempt to the some addiction, and yes, unemployment also lead to this one. Hence, some of the recommendation at the 3 level. One is family, one is community, and third one is the policy level. At family level, we need to introduce the propagate family counseling, involve family in discussion on sex and sexuality topics, orient family on the importance of support the trans people need to prevent mental trauma and addiction to substances. At community level, organize regular public webinar and discussion via folklore like today is going on, and mass media to reduce stigma and discrimination, to identify and nurture the skills so that they will become productive to the society. At policy level, it is very important, introduce value-added service such as SRH, SRS, it's through trained and dedicated hospitals and service providers. Draft and roll out a framework which eliminate the ambiguity of terminologies and bring harmony between LGBTQA. Involve all stakeholders at national, state, and district. So one common message goes out from everyone. Like nowadays, the CLM, Community Lead Monitoring Program, is a community system strengthening program. It gives that of the platform to all the community leaders for the raise their hands and also work on national, state, and district level. Policy level, it has to be the introduce a toll-free number and 6 inputs from all type of KPI charges on a regular basis and address them. Encourage trans community involvement in the planning cycle and reserve staff strength for trans people at all levels. And yes, lastly, regularize the private health sector enduring service as per national guideline. Thank you so much.
Thank you. It was quite quick, I would say, but quite interesting that yes, stigma actually starts from home at the family level, and we need to somewhere guide the family. And I think we need to start probably at the time of when the woman is pregnant itself and we are communicating with her. So probably we can communicate a bit on this as well, that there could be any type of sex there and the orientation could be different at the same time. So thank you very much. I think before closing, I would like to invite my co-chairs, Mr. Mittal, if you have any comments.
Yeah, so these are actually very pertinent presentations that we have made in the last sessions of this AIDSCON. So naturally the issues related to HIV and hepatitis, we are all focusing on all these, and we understand the quantum of work that needs to be done. So surely we'll be able to, we actually have started this screening, and recently these HIV sentinel surveillance, it is now also focusing on the surveillance of hepatitis cases. So naturally we'll generate some evidences and we'll surely strengthen this program further in all key populations that we are reaching in Chandigarh. So that these are great inputs that we have received. Thank you.
Thank you, Mr. Mittal. And you have any?
I think you have summarized it well, ma'am. All these 3 topics or 4 topics were very, very relevant in today's context. We all know what is the Hep C situation in Punjab. Program data suggests more than 60% among PWID, and this is the high time we start looking at Hep B, Hep C, and HIV all put together, particularly among drug-using population. Similarly, Dr. Ravinder talked about IPT and how actually it helps PLHIV community in terms of containing TB amongst them. Dr. Rao very elaborately talked about overdose, and this is one of the topics which actually needs to be propagated among the drug-using community, because we do see a good number of overdose-related death cases, and this is one area where we need to focus more on in time to come, so that these death cases could be prevented among drug-using community. So all these 3-4 topics were quite relevant, and we need to work much more vigilantly on these issues, so that this can be taken care in a much more qualitative manner in time to come. If you have any question, if we can quickly go through the chat box, and if any questions are there, we can take them up.
No,
otherwise, we can close this.
Let's. I don't think that there are any questions, but if there are any, yeah. Are there any questions?
No, ma'am.
Huh?
No.
No. Thank you. So before closing, I would like to thank Chandigarh SACS for inviting me for the session, which was so very important and actually was quite useful to open up new areas to work on. Thank you. I also thank my co-chairs for helping me with inviting and then commenting on the presentations. Thank you very much.
Thank you, Dr. Manmeet. I request Shri Manish Kumar, Team Leader TSU SPYM, to honor our chair, Dr. Manmeet Kaur. Thank you so much, ma'am. I request him to please honor Mr. Sandeep Mittal, Deputy Director, TI Chandigarh SACS also. Thank you. Thank you. Thank you all the speakers who joined us today virtually. Thank you very, very much. this was an end of the technical sessions. We had 12 sessions in all 2 days. Now coming on to the last session, 13, valedictory. We are just waiting for our chief guest to be here with us. Dr. Suman Singh, Director Health Services, UT Chandigarh. She's already arrived. She'll be with us in any moment. Please put your hands together for our chief guest. Dr. Suman Singh, Director Health Services, UT Chandigarh. We welcome you, ma'am. I request our project director, Dr. Amandeep Kang, to please give her a floral welcome. Thank you. Now I request the project director, Chandigarh SACS, to give a welcome and an outcome for the conference. Thank you.
Good evening, everyone. It gives me great pleasure to welcome Dr. Suman Singh, Director Health Services, Chandigarh. Achha. And I want to thank her for her unstinted support to this Herculean task, because when the third wave started, actually, usually we start planning around December to hold the conference every year. It's held in February. So when we started planning it, then we thought we'll do it in February and the dates were set. And suddenly the third wave struck us. And first we thought, okay, let's do it virtually. Then going into hybrid and not knowing, when this third surge is going to finish it off. And then when we had planned for this thing, okay, let's fix a date and let's hold it virtually so that we can plan and go ahead. And then suddenly the wave comes down. And then we start getting requests from people, no, please do it hybrid now, there is no risk. And then we again thought within 15 days, we had to just switch it into hybrid, and a sudden change was there. And we got all support from Dr. Suman Singh to go ahead with this. And then we got support from the Director General of NACO. We went and called on sir that we are going to hold and come to invite you. And if you come and join our conference, it will be a real booster for us. Immediately, within 2 minutes, he agreed to come here, and the whole NACO team came here to support us. And now I also welcome Dr. Ratnamilai Desai, President, Family Planning Association of India, and Dr. Kalpana Apte, Director General, Family Planning Association of India, for sparing time to join us for the valedictory function. I also welcome representatives of NGOs, heads of peripheral units, and also the Red Ribbon Clubs, whose concentrated efforts have helped Chandigarh SACS to reach out to the key performance indicators. Over the past 2 days, we have had a very fruitful 2 days of proceedings during the conference. And it's very heartening to share with you that 1,004 delegates registered with us. And we have had panelists and speakers from other countries also joining us virtually. About 80 speakers from a variety of fields have shared their experiences and expertise in 12 scientific sessions held in the conference in the past 2 days. The team from NACO, under the leadership of Shri Alok Saxena, Additional Secretary, come Director General NACO. They physically attended the conference and gave inputs on priority areas which needed attention and incorporation into the National AIDS Control Program. The deliberations have been done around the NACP 5 response to end HIV/AIDS epidemic by 2030. The speakers from various institutions, including the global partners and civil society organizations like UNDP, UNAIDS, WHO, USAID, CDC, IPPF, and many more, they have all shared their expertise and experiences. The NACO representatives shared the HIV epidemiology and strategies to fast-track the response. Focus was also given on the key research priorities under the NACP 5. It was agreed that we need to focus on reaching out to the unreached by identifying vulnerable populations through various programs like Sampoorn Suraksha Strategy, virtual outreach, screening them for HIV, and linking identified PL-HIVs with the ART centers. The importance of making provision of managing mental health of PL-HIV and key population has also been highlighted by many panelists. Specific focus has been given on HIV, sexual and reproductive health needs, and rights of the adolescents. The deliberations have also been done on the newer technologies for diagnosis and management of HIV, advancing the health of trans feminine people, and MSM and prevention strategies focusing on the key populations. The findings of the conference will be very valuable. They are going to be shared with NACO for incorporation in the National AIDS Control Program. And I welcome Dr. Suman Singh again. Thank you.
Thank you very much, ma'am. Now I would request Dr. Ratanmala Desai, President FPAI India, to please join us on the dais. We welcome you, ma'am. Request Dr. Kalpana Apte, Director General FPAI India, to join us, please. I request our chief guest to give away a few mementos. I would like to invite Dr. Kumol. She's the Director, Population Research Center, PU Chandigarh. I request her to please come up on the stage and receive her memento for operational research and evaluation activities. Congratulations, ma'am. I request Dr. Rana, State TB Officer, for HIV-TB collaborative activities. Congratulations, sir. Mr. Shekhar, Senior Technical Supervisor. He's also been awarded for HIV-TB collaborative activities. Dr. N.K. Goyal, HOT Community Medicine, GMCH 32. He's been awarded for operational research along with supporting our RRC, ma'am. Thank you, sir, for all your support. Dr. Savita Prasha, Coordinator, Center for Public Health, Punjab University, Chandigarh. Thank you. Congratulations, ma'am. Now I would request Dr. Manjeet Singh, SMO Skin Department, GH16. He was a judge for the poster competition. Thank you very much, sir, for your expertise. We are really grateful to you for taking out valuable time and judging our posters. I request Dr. Sonu Goyal, Professor, School of Public Health, PGI MER. Is he there with us? Okay, moving on. Dr. Ajay Veer, I request him to please come. Miss Renu, Lab Technician. She has initiated HIV testing in Maloya. Congratulations, Ms. Renu, for your hard work. We appreciate. Dr. Sonia Mehta, MO26 Dispensary, for increasing HIV testing counseling services in Chandigarh. Thank you for all your support, ma'am. Looking forward for your continuous support. Thank you. This award is being awarded to Dr. Brinder Jeet, and Dr. Gunjo is requested to take her award, please. This is for zero transmission rate in MTCT program in ICTC 16 pregnant women. Congratulations, ma'am. Ms. Pooja Thakur, President, Chandigarh Network of Positive People, for all her support, and proper services are being provided to PLHIVs. And she is a nodal officer for helping us. So congratulations, Pooja, for your hard work. Ms. Meena Witch, General Secretary, Care and Support Center. She's been awarded for best coordination, I should say, among PLHIVs. In COVID pandemic, ma'am, she has worked very, very hard. She went to the houses of the patient to deliver medicine, nutritional support. She was very instrumental. We appreciate your effort, Meena ma'am. Ms. Nihan, Field Investigator, Svetna Project. Nihan, congratulations, and we look forward for your continuous support in future too. Congratulations. Dr. Charu Gupta, Nodal Officer, NHM, Chandigarh, for supporting, coordinating with NHM for HIV/AIDS program. Thank you very much, ma'am, for overall support. Mr. Rajeshwar Singh, Senior Law Officer, State Legal Service Authority, for organizing AIDS camps, helping people, guiding people. Thank you so much, Mr. Singh, for all your support. Dr. Sunil Arora, SRL Lab in charge, PGI MER. Okay. Dr. Preet Mohinder, SMO Microbiology Lab, GH16, for Quality Management System in Laboratories. Congratulations. Dr. Neena Chaudhary, SMO Burel Jail, for successful implementation of HIV surveillance program in Burel Jail. Congratulations, ma'am. Dr. Paramjeet, DMS, Sector 16 for overall coordination. Thank you, sir, for all your support and guidance you give us from time to time. Thank you so much, sir, for all your support. Now I would request Shri IPS Bajwaji from FPAI Mohali, he is the president, to please receive his award. Thank you, sir, for implementing such a good TI. Thank you very, very much for all your support. Thank you, sir. Shri Mahajan from SOPS, Honorary Administrator cum Secretary. Thank you, sir. Thank you, sir. Dr. Nareshanand Bhardwaj from Safosh, he is the director. Thank you, Mr. Bhardwaj, for all your support. Thank you. Shri Pramod Sharma from Yuvsatta, he is the coordinator. Congratulations, Mr. Pramod. Shri Vinod Kapoor from FPAI Panchkula, he is the president. I request him to please come up. Thank you, Mr. Kapoor. Dr. A.K. Kundra from SOSWA, he is the chairman cum executive director. Dr. P.L. Kalras from Sehat, he is the director. I request the project manager to receive, please, if he is not there for some reason. Congratulations. Dr. Sumit Arora from APSWDP is the president of the NGO. Congratulations, sir. Mr. Kushbinder from TCIF, he is the project director. Congratulations, Mr. Kushbinder. Shri Sevanand Butts from TSU. Mr. Deepak Kumar from TSU. I request Mr. Munish to please receive the award. Thank you very, very much. Now, Mrs. Manjeet Kaur from Dev Samaj College of Education, Sector 36B, Chandigarh, for implementing excellent RRC. Thank you. Not to miss out the hard work of the members of Chandigarh SACS, ma'am. So it's the time to honor them. Am I missing out on something? I hope not. Okay, I request Sister Manbir from, she's the staff nurse of GM SH16. Is she there with us? Thank you, please. We appreciate your efforts. Thank you very, very much. I request Dr. Manmeet to please come up on the stage and receive her award. Thank you very much, ma'am, for all your support and guidance you've been giving from the past so many years to us. Thank you. Now starting with the program officers, Mr. Parvinder Sharma.
NGOCSI.
On and on, yes. I request Kalyani Singh to please receive the award for NGO CSI. I request Mr. Parvinder Sharma, Assistant Director Finance, Chandigarh SACS, if he around. Okay, I request Ritu Sharma to please take away the award.
Now we are, hello. Now we are starting the felicitation of SAC staff, because this conference was held in a very short time, and to turn it around into a hybrid mode and then to connect so many people and run the program on time, and we finished on time, started on time, finished on time, and all the panelists joined, and they were very fruitful. Discussions were held, and I would like to share with Dr. Suman that all the divisional heads of NACO, I admire their work and the way they held on to whatever work was allotted to them. They seamlessly just went on doing it, and I was, whatever apprehensions I had that I have joined this year, probably, I need to get to know how all this is going to happen in such a large scale. But I want to share with Dr. Suman कि मुझे पता ही नहीं लगा how these people did it. Hats off to them.
I request, there's a one, I have skipped one, sorry, apologies for that. Dr. Manjeet Singh, SMO Skin Department, GH16. I had given him, I think, Punama. Okay. I request Ritu. Ritu has received, sirs. Okay. Dr. Bhavna Sangal, Regional Coordinator North. Please put your hands together. Congratulations. Mr. Manjeet Singh Gulia. He's Assistant Director Lab Services. Mr. Sandeep Mittal, Deputy Director TI. Ms. Poonam Bakshi, Monitoring and Evaluation Officer. Mr. Kavaljeet Singh, Assistant Director CST. Dr. Chitender Dhaya, AD-SPM, Social Protection Mainstreaming. Mr. Sunil Pangal, Assistant Director Youth Affairs. Last but not the least, Tinu Khanna, Deputy Director IC. I think all CSAC staff should come. We are a CSAC family, so I request everyone to come up on the dais and please join us for a group photograph. Okay. So, Hanji, there's one award which has been left. देखो इतना बड़ा प्रोग्राम है, छोटी छोटी गलतियां तो होती रहती हैं. So there's a gentleman, Mr. Rajiv Kumar. He is on behalf of Dr. Sonu Goyal. So I request ma'am to please honor him. I request Dr. Kalpana Apte, Director General FBI India, to say a few words, please.
Thank you, Pinuji. Dr. Kang, Dr. Singh, thank you for giving us this opportunity to be here at the closing of this very inspiring and enthusing conference. The government and NGO partnership is an important way to take the agenda forward. And FPA India, as we all know, is an organization 73 years old, working for the sexual and reproductive health and rights in India. HIV and SRH integration is a very, very important strategy. And you saw two of our branches being honored for the work that they do. And we commit to Chandigarh SACS and to you, ma'am, that we will continue to work. Today itself, we had a long conversation. How can we provide SRH services to the most marginalized and community members? They do have special SRH needs. And what are those groups like women IDUs, absolutely hidden group? How can we work with them? How do we identify them? So that is our commitment, ma'am, that we will continue to provide services. And thank you for having us here. We are really honored. Thank you so much. Thank you.
We had a poster competition also going on simultaneously, which was online. And people were giving ratings for that. There were two streams, social and medical. So we had judges also who were there to rate them, and then the rating was combined and the winners were decided. So I request Ms. Poonam Bakshi to please announce the winners for today.
The first prize goes to the poster 9. The topic for this social category, factors affecting accessibility of healthcare services by transgender community. And this prize goes to Dr. Gina Corgill, a GMCH 32 intern. So
congratulations, winners, as winners are not here because they were not informed in time. She's here? Okay.
Okay,
Congratulations. Please come up on the stage and receive your award.
And there is another winner for the medical category. The first prize goes to the poster E29. That is a topic for this mother to child transmission of HIV experience at Treasury Care Hospital in North India. And the prize goes to Litika Singla from GMCH 32.
She's not there.
No, I think.
Okay.
So the prizes will be hand over, I think so.
Yes.
Will be later. And the second prize is E26. That is exploitation of COVID-19 related fears. This is
regarding blood donation,
in India. And Dr. Suchet from PGI Chandigarh.
Congratulations,
Dr.
sir. We'll give them prizes later on.
Right. Thank you.
I request there's 2 students from Punjab University from School of Public Health to receive the award on behalf of Dr. Gaurav Gaur. Are they there with us? Can you please come up on the stage and receive the award on his behalf? Coming to the end of the awards now. I've been asked to propose a vote of thanks. So it's a privilege for me to propose the vote of thanks for this national conference, AIDSCON-11. This is the 11th annual conference of Chandigarh State AIDS Control Society, which concluded today. On behalf of Chandigarh SACS, I would like to express my gratitude to Honorable Chief Guest, Mr. Alok Saxena, ASN DG NACO, who had come all the way from Delhi last morning to inaugurate this conference. Our guest of honor, Shri Yashpal Garg ji, IAS, Secretary Health, UT Chandigarh, who was present with us during the inaugural, and he really motivated us, appreciated the work of Chandigarh SACS and the work which has been continued in the presence of our present PD. I am thankful to Dr. Suman Singh, Director Health Services, who is with us today. Dr. Ratanmala Desai, President from FPI India. Dr. Apte, Director General, FPI India, who is with us. I am thankful to all my delegates, speakers, our chair, co-chair, who were there with us in the 12 technical sessions which were held. I am thankful to our judges who had judged our posters medical as well as social, my friends, my NGO colleagues, various organizations who were partnered with us, like UNDP, UNAIDS, WHO, USAIDS, CDC, FP, FPPI, ITEC, YG Care, Humsafar Trust, Ministry of Social Justice and Empowerment, National Institute of Health and Family Welfare, UNICEF, NCPI Plus, FPAI, ASI, PATH, SPYM. I hope I'm not missing any one of them. Thank you. We are grateful to each one of you who had supported us in organizing this conference. My colleagues, NGOs, and not to forget my media friends who gave us nice coverage today and hope to see nice coverage tomorrow morning too. All my friends in the staff of CSACs who had really worked very hard in the past few months in planning and in implementing and making this two-day conference a big success. I am thankful to all my friends there at NACO who supported us, guided us, and time to time gave their inputs to improve this day by day. Thank you very much. In the end, I would like to thank all my virtual audience, my delegates who joined us today. More than 1,000 people were with us today, so I would like to thank them. And not to forget TechMark team who was there with us to support all of you. Please, a big round of applause for them. They were there with me. No chai, no pani, no khana. They were always there. Always there. Hard work pays. Thank you very much. Thank you, ma'am, for joining us today here. And not to forget, I would like to thank, a big thank to our project director, Dr. Amandeep Kang. In her guidance, we were able to achieve this. Thank you, ma'am, for giving us a free hand and telling us, ki, Jao, I am there. Go and do it. We can do it. Thank you, ma'am, for motivating us. Really, we are fortunate to have you as our PD. Thank you, ma'am. I hope I have not missed anyone. If I have, तो मैं उनको थैंक यू कहती हूँ हाथ जोड़कर और प्रार्थना करती हूँ कि अगली बार भी हमें ऐसे ही सपोर्ट करना ताकि हम AIDSCON-12 अगले साल इन्हीं दिनों में कर पाए. Thank you very much. हाँ, next time we are planning to have an international conference, so ज़्यादा support चाहिए होगा. Thank you. Thank you.
Guys, permission to close the conference. Thank you very much.
I'm sorry. जैसे आपने बोला वैसे मुझे याद आ गया. Thank you, Tarun. Thank you. Big thank you to you.
Oh, ma'am. Thank you so much, ma'am. Thank you. Guys, end the conference, please.